Dr. Akil? Dr. Akil Goel? Can I share the screen and see if it is working?
Okay, so ma'am, currently we have not activated sharing the screen. Should we play the PPTs from here and you will present from there, or you want us to make you co-host so that you can share the screen?
But you can hear me, right? There is no issues about.
No, not at all.
Yeah. No, I'll try to share if it is happening, because I am getting this one that I can share.
Okay. If you are able to share, we can start doing that. Yes, we're able to see your PPT.
Yeah, I'll just put a slideshow and whether it changes, because there will be some issue with the slideshow.
Yes.
Is it changing?
Yes, ma'am, it is changing.
It's changing, right?
Yeah.
Okay, thank you.
Thank you, ma'am.
I would like to thank Dr.
A warm welcome to all delegates. We'll be starting our session soon after the oration will be completed. Thank you. A very good morning to one and all. On behalf of Team Eficon, it is a pleasure to invite all the participants, distinguished chairpersons, eminent speakers to Eficon 2021. I, Dr. Manasvi Chopra Saluja, along with my co-host, Dr. Divya Gehlot, would like to extend our heartiest congratulations and gratitude for giving us the opportunity to mediate and moderate today's session on front of pack labeling, with the highlights on the topic, front of pack nutrition labeling to promote healthier food choices, current practices and opportunities. Now I would like to invite my co-host Divya Gehlot to take the session forward. Over to you, Divya.
Thank you, Dr. Manasvi. Good morning to everyone. Proceeding further, now I will take the opportunity to introduce our chairpersons. The first chairperson of this session is Dr. Rakesh Kakkar sir. He is professor and head of community medicine and family medicine and medical superintendent of AIIMS Mangalagiri, Andhra Pradesh. He is MD PSM from Gandhi Medical College, Bhopal. Sir is also the editor of IAPSM's textbook of community medicine. Sir has been editor of Indian Journal of Community Health 2016 to 2020. Sir has been chairman of State Task Force RNTCP Uttarakhand 2017 to 2018. Sir has been editorial board member of Indian Journal of Community Medicine and Family Medicine 2019 to 2021. Sir has been awarded with Presidential Appreciation Award in Faculty category in IAPSM Con 2018. Sir has received fellowship from FIA-PSM in IAPSM Con 2021. Sir has guided more than 10 MD theses and PhDs. Proceeding further, I will introduce our second chairperson of this session, Dr. Hari Shankar Joshi sir. Sir is professor and head of community medicine and family medicine, also the research coordinator in AIIMS Gorakhpur. Sir has been awarded with fellowship from PSG FIA MER Regional Institute of Coimbatore in June 2018 with distinction. Sir has been reviewer for reputed journals, Public Health Nutrition, BMC Public Health, the journal Nutrition, Health and Aging and Cures. Sir has been external examiner for MBBS and MD for different universities and chief guide for 10 postgraduate students. Sir has published approximately 90 articles in national and international journals with more than 2,000 citations with H-index 18. Sir has also presented articles in many national and international conferences and been guest lectures for national and international organizations. Now I would like to request our chairperson, Dr. Rakesh Kakkar sir, to introduce our speaker, Dr. Rashmi Kundapur ma'am.
So, thanks to the organizers, especially thanks to Divya and Manasvi for nice introduction. And I would like to take this opportunity to thank the organizers, Dr. Pankaja, Dr. Pankaj Bhardwaj, and I would like to welcome with my co-chair, Dr. H.S. Joshi, all the speakers for today's session. That is Dr. Rashmi Kundapur, Dr. Ramesh Kapil sir, Ms. Vandana Shah, Dr. Pradeep Agarwal, and all these speakers, they are well-known resource faculty. And now we are going to start an important session, that is front of pack nutrition labeling to promote healthier food choices. So first of all, the first speaker is Dr. Rashmi, who is additional professor, community medicine and family medicine at AIIMS Bibinagar. She has done her community and family medicine from Rajiv Gandhi University of Health Sciences. And she took a very important and advanced training in many fields, like advanced medical education technology, and advanced training in research methodology, curriculum development training and problem solving training, management and leadership training. So all these trainings are very important. She was a examiner for DNB National Board for 5 years. She has received Best Paper Award in 31st National Conference of IAPSM in Chandigarh, and was awarded Young Female Scientist Award again in the same conference. And she has received a Young Scientist Award by Kutch in 46th Conference in Manipal by Karnataka Association of Community Medicine, and has received Presidential Appreciation Award by IAPSM in 2018, and also got fellowship by the IAPSM in 2019. So with this introduction, I would like to invite Dr. Rashmi. She will be presenting about the front of pack labeling and its role in controlling non-communicable disease. Welcome, Dr. Rashmi.
Thank you, sir. Thanks a lot. And thank you, first and foremost, before I start a session, thanks to the chairperson who introduced me, Dr. Rajesh Kakkar. Thank you for introducing me so well here. Thank you, the organizers, the moderators of the sessions, and Dr. Pankaja Madam and Dr. Pankaj Bharadwaj for giving this opportunity, and of course, the lead project for this, FOPL, Dr. Pradeep Agarwal, who is the backbone behind all this concept. So thank you all. And we start the session right now. I'll be sharing my screen. The concept is on non-communicable diseases and FOPL, front of package labeling and non-communicable diseases. So is my screen sharing? Like, it is changing?
Yeah. Please go ahead.
Nearly 5.8 million people, that is 1 in 4 Indians, are at risk of dying from NCD before they reach age of 70. An average age of Indian for right now is 73, and we find that 1 in 4 have a risk of dying of NCD before reaching that age of 70. Disease burden of NCDs have increased from 30% of the disability adjusted life years in 1990 to 55% in 2016. Imagine the burden of this disease, which affects the disability adjusted life years, which is almost doubled from in last around 16 years. Deaths due to these conditions is increasing from 37% in 1990 to 61% in 2016. Cardiovascular disease accounts for at least 27% of NCD deaths. Talking about the major problem what we are facing from NCD, which is increasing. Untreated and uncontrolled hypertension contribute to an estimated 1.6 million deaths annually. India is also fast becoming diabetes and cancer hotspot. What does that matter? How is that coming? We all know it is an epidemiological trend, and one by one everything goes on. Is that only that, or is there something else? The crisis is being further aggravated by COVID-19 pandemic. Persons living with NCDs face a greater risk of becoming severely ill or dying from COVID-19. All of us have heard this. All conditions as high blood pressure, high fasting blood sugar levels, and obesities, which are at risk for death, or also the severely ill and causing complications, are linked to unhealthy diets and an excessive intake of sugars, total fats, saturated fats, trans fats, and sodium. In turn, the excessive intake of these nutrients of public health concern, why am I talking is these nutrients are of public health concern, like malnutrition, is largely driven by widespread availability, affordability, and promotion of processed and ultra-processed food products with unhealthy nutritional profiles. We find this majorly in the processed and ultra-processed food, these unhealthy nutritional profiles, high food sugars and high fats, excessive fats and trans fats. That's why it becomes a nutrients of public health concern and availability. That's what we can say, that ORS is not available, but still we have an availability of all these packets even into the remotest part of India. We see the packets all in all Northeast where the health is not reached, but these processed food and ultra processed products have already reached. Now, what is FOPL to do with NCT? Research evidence suggests that FOPL makes nutrition information more accessible to consumers. How do I know what am I eating? The front of package labeling makes a nutrition information more accessible to the consumers. If I am a consumer, I would be wanting to know what I am eating. Using the FOPL, consumers can make informed and healthy food choices. It's our duty to give the people an informed availability of what has been eaten. Then it becomes the person's responsibility to take up. They can pick food items that are low in saturated, trans fats, sugar, and sodium. Now, they can pick it up depending upon what they want. A strong front of package label is one of the most efficient tools of influencing consumer behavior to alter dietary choices and reduce their vulnerability to NCTs. Is it going to happen? Yes, definitely. We have been seeing that there are a lot of evidences which says that front of package labeling will allow somebody to make an informed decision. India's stand on FOPL. In 2018, the Food Safety Standards Authority India established draft regulation for FOPL, which was subsequently withdrawn for further deliberation. In 2020, FSSAI restarted the process of developing FOPL and has been in consultation with civil society, industry, and nutrition experts for a viable model for India. This is the study which says the use of FOPLs led to a substantial reduction in mortality from chronic diseases. Approximately 3.4% of all deaths from diet-related non-communicable diseases was estimated to be avoidable when Nutri-Score FOPL was used. This study was done for different types of FOPL. But still, they say 3.4% of death, all deaths from diet related. So then the remaining FOPLs likewise resulted in mortality reduction. Health star rating system 2.86%. Reference intakes, what we see in some of the branded 1.9%, multiple traffic light 1.6%, and sense 1.1%. This was a France study which said that over a period of time, if you look into the FOPLs have definitely led into the reduction in deaths of non-communicable diseases. Remember, we are not only concerned with the deaths of non-communicable diseases, but also the daily adjusted life years, which has doubled in 16 years, has to be reduced. And that, if death by itself is reduced so much, definitely the DALYs also will be looked into. Interpretive and reductive. These are the two different types of FOPL which will be spoken about by others. I'm just putting into to show that what was the earlier ones, what I'm talking about. So you have some things like that. Systematic review provided comprehensive evidence for impact of color-coded labels and warnings in nudging customers' purchasing behavior towards more healthful products and underlying psychological mechanism of behavioral change. Yes. It has been said, a systematic review which said of 19 papers they did, and they could see that the color-coded labels and warnings had a behavioral change, psychological effect on people. Each type of label had different attributes which should be taken into consideration when making front of package nutrition labeling policies according to local context. Studies supported mandatory front of package labeling policies in directing consumers' choice and encouraging the food industry to reformulate their products. So this study was given meta-analysis, summarized the currently available 118 peer-reviewed study to update knowledge on most mainstream interpretive front of package nutrition labeling schemes. The traffic light labeling system, this was a 2021 study, which meta-analysis, which said that the traffic light labeling system, Nutri-Score, nutrient warning, and health warning were all able to direct consumers towards more healthful purchasing behavior. So any type led into color-coded labels, with it be TLS or NS, performed better in promoting the purchase of more healthful products, while warning labels of nutrient warning and health warning had advantage in discouraging unhealthful purchasing behavior. So two things: one encouraged more healthful products, the other discouraged the unhealthful purchasing behavior. So two things also matters when we talk about the quality of life and disability adjusted life. The difference in consumers' behavior could be explained by different underlying psychological mechanism for each label. That is, in each label, psychological mechanism. FSSI gave this traffic light food labeling and how it has to go, because all it contains is, it also contains the warnings and numbers and also the pictures. So both of that had a encouraging and discouraging the unhealthy and encouraging the healthy. So it was important to take up that this type was the FSSI traffic, which will be already spoken by others, and just putting it up to say that this type of labeling, when it puts into the food, naturally makes us feel that something is going wrong. The red halts us. Other things makes us feel that should we really go it, or should we think twice? So that's about the FOPL programs should use combination of text and symbols. This is given by WHO to present nutrition information quickly and simply, and should be evaluated based on impact and better given country. And that's what we are doing right now. Nutritional health values and easy to see and understand, whether improving the ease of comparison. Currently does not have currently dietary guidelines like what we have. So we should go by global and regional dietary guidance designed by WHO and its regional office. One system should be used by each country. Quite difficult in India, but still we should see that. We should see the WHO. There should be an educational program to help consumers understand the use of labels. So WHO guiding principles and framework manual for front of package labeling for promoting healthy diet should be important resource for Codex. Further, it is also to make Codex guidelines and WHO guiding principles complement each other. So even on a tomato, we are supposed to have a nutritional facts, which is not being present right now. So what are that being present so that it can increase, it can give a value for the healthy nutrients and make the people more wanting to take the more healthy foods. Front of package labeling is not only for processed and unprocessed, but also you can use it on healthy foods to make people more aware of what are the healthy foods, and they may seem more tasty also, unless and until we are using it only for discouraging also helps, also encouraging helps. Thank you.
Thank you so much, ma'am. It was very informative and insightful session on the role of front of pack labeling in controlling non-communicable diseases. Moving forward, I would like to invite Dr. Harishankar Joshi sir, our distinguished speaker, Dr. Umesh Kapil sir. Over to you, sir.
Hello.
Yes, sir.
Yeah,
Hello?
actually, ma'am, because of the meeting, I just joined this thing. Hello.
Yes, yes, sir. Yes, sir.
Actually, regarding the because of the PM visit, we have a meeting with the district authorities. So I not heard the session. I just joined here.
Okay, sir. Okay, sir, I just explained that we'll be moving forward and you'll be inviting Dr. Upesh Kapil, sir, to present.
Okay. Yes, I hereby invite our esteemed Dr. Mukesh Kapil, sir, for his session. And he's a president of EFI, and is a professor and head in the Department of Epidemiology in the Institute of Liver and Biliary Science, New Delhi. So, welcome, sir, for the session.
Okay, sir, thank you.
Pradeep Agrawal, and I would like to thank Dr. Pradeep Agrawal and all the organizing committee members for giving opportunity to Epidemiology Foundation of India to be a partner of this national initiative. I would like to mention that all the members of Epidemiology Foundation of India would be happy to share the responsibilities which would be given to them by the organizers of this meeting. Well, I would like to start my presentation by making a very simple request that since it is an online presentation, so there might be few difficulties. Kindly bear with me. The topic of my presentation is WHO nutrient profile model for Southeast Asia region. And I'll be taking the next 15 minutes and mentioning about it. The format of my presentation is what is nutrient profiling, what is its utility, what is the WHO nutrient profile model for India, what nutrient cutoffs have been used, what was the methodology adopted for development of a nutrient profile model for our country, and few concluding comments. Well, this is the WHO nutrient profile model technical report series published by WHO Southeast Asia region in 2017, and this provides all the details of the processes involved, how we gone about it, and how we have able to publish it. Now, the primary objective of any nutrient profile model is to help in classifying foods so that they can be utilized for marketing of foods and non-alcoholic beverages to children. This is the essential scientific basis of nutrient profile model. It also helps in assessing or evaluating the foods and beverages, non-alcoholic foods and beverages, if they have elevated level of any of the following. Now, just mark over here that when they talk about the elevated levels, they don't talk about high levels. They're talking about the elevated levels of sodium, free sugar, saturated fats, and total fats. Now, what has been seen that consumption of excess of energy, fats, trans fats, sugar, and salt has been associated with a number of diseases, specifically obesity and other chronic diseases. So we can say that nutrient profiling is a science of classifying or ranking of the foods according to their nutritional composition. It helps in preventing the chronic diseases and promoting health. Now, again, just remember that the WHO nutrient profile model is classifying the foods which are more likely to be the part of healthy diet than which are not likely. So here is what we are trying to do. This entire exercise is through healthy diet which can be consumed by the children or the population. Nutrient profiling also helps in marketing of foods to the children, health and nutrition claims which being made on the food packages. It also helps in developing labeling logos and symbols for information and education. And in this context, we are talking about the FOPL, but essentially WHO talks about the labeling of symbols and logos on food. Now I'll briefly share with you what was the methodology adopted for developing the nutrient profile model for our country. Now, I must admit that I was associated with this nutrient profile model, which was developed for our country. What we did initially, that WHO Regional Office for Europe developed a nutrient profile model, which was official first publication of WHO on nutrient profile model. So we took the help from this model, how they have gone about it. Then earlier we had the WHO issued guidelines on sugar intake by adults and children. Now this is an important WHO document which was evidence based, and it talked about one essential recommendation was reduce the intake of free sugar to less than 10% of your total energy intake. When I talk about the total energy intake, it is the recommended dietary allowance. And for Indians, we had considered 2000 kilocalories as the total energy intake. And 10% of this is 204 gram. 1 kilocalorie is equal to 1 gram of sugar provides 4 kilocalories. That means not more than 40 gram of sugar should be consumed. Similarly, for sodium intake, the WHO recommendation is less than 2 gram. Reduce it to 2 gram, which is equal to sodium equivalent to 5 gram per day of salt. Now, this is something important. Third, we had talked about, we took the data scientific evidence from another publication, Diet, Nutrition, and the Prevention of Chronic Diseases. This intake. And they talked about that your total calories, 10% should not be more than from the fat, and trans fat should be 1% of the total energy intake. Now, earlier also WHO has made recommendations on marketing of foods and non-alcoholic beverages. And WHO has always said that please undertake responsible marketing to reduce the impact of foods which have high in saturated fats, trans fatty acids, free sugar, and salt. So these are the documents which were considered, the evidence which already been generated and deliberated by WHO was considered for developing the NPM model for our country. We do have another document of WHO, the guiding principles and framework for FOPL for promoting healthy diets. It just talks about what should be the principles for developing a FOPL. Now, what we did was, coming back to the process or methodology, what we did, we collected about 1091 packaged foods from different parts of the country, essentially from Delhi, Pune, Bombay, Calcutta, and we went to the stores and then we collected it. And then the nutrient contents of these packaged foods were uh, entered in the Excel sheet. And what we did, because some packaged had the nutrient content 60 grams, some they do 40 grams, some they do it 100 grams, or some they do it each pack contains so much. So we calculated the nutrient contents per 100 gram of product. Now we divided the to all the what you call packaged foods into 18 categories like chocolate, cakes, savory snacks, yogurt, breakfast cereal, edible ices, beverages, ready to eat composite food. These are standard categories of foods which were earlier used, and we used these and put down the uh, total what you nutrient contents of these foods. And specifically, we entered the total calories, total fat, total sugar, and total sodium present per 100 gram of these packaged foods. This is one example that we had so much of packaged foods available. And honestly speaking, when you collect 1,000, 1,100, 1,000 or 1,100 these packaged foods, who has to consume it? We need only wrappers for our study. So it was not a happy situation for the research team of my department to request all the staff to consume these foods, which was not a good decision. I retrospectively I feel. Now, sometimes this is a example that sometimes they do not mention about the sodium content of the packaged food, although there is no compulsory or mandatory requirement, but it is being mentioned by a large number of people. Now, when we talk about the nutrient profile model, the main concern what we had was that it should be aligned to the existing national food and nutrition policies and guidelines. You develop an nutrient profile model, and you find that it's not inconsistent with the in consonance with the national guidelines. So what we did, we took the national dietary guidelines of India, which was recommended by National Institute of Nutrition, Hyderabad, of ICMR, and whatever the recommendation, the edible oil should be the restrict the salt. So what we did, these guidelines we considered for developing the nutrient profile model. We also took WHO guidance. Okay, the WHO has given us shown you the earlier documents and Codex guidelines in developing the nutrient profile model. This is a document from NIN, Government of India. Okay, now what we did was that any food which extended the, which had more than the recommended cutoffs, we classified is as a excessive in a particular nutrient. Say, for example, total fat, saturated fat, total sugar, total sodium, all these things were added, were being classified as the packaged food which has excess of a particular nutrient. Now, how did we define this? What we designed that the sugar threshold should be, the amount of sugar should be less than 10% of total caloric intake. And we, as I mentioned to you earlier, it was 2000 kilocalories, 200 kilocalories, 10%. That is about 50 grams of sugar. 1 gram of sugar provides 4 kilocalories. For sweetened beverages like colas and others, we put down our threshold of 5%. It should not be more than 5%. Otherwise, we call it a food which is unhealthy or likely to be unhealthy. Total fat content we talked about. If we have total calories of 2000, divide by 9, because this 1 gram of fat provides 9 kilocalories. So our total consumption should be 22 gram if you're taking it from the packaged foods. Now, sodium threshold again, we talk about the common salt. And again, what we said that it is WHO recommendation also that our food what we are consuming should not have more than 1 milligram of sodium per kilocalories consumed. This is important. If a food is providing, if a packaged food is providing 200 kilocalories or 300 kilocalories, that means the sodium content should not be more than, say, 300 milligram. For 300 kilocalories, 300 milligram. So this is important. Now, subsequent to that, we have tested this model in 5 Southeast Asian countries, and it's a field tested. And we try to look at whether this model works or not, what are the deficiencies in it. And we had the regional meeting of all the representatives, including of India. And we had feedback from each of the countries. And then we finalized the nutrient profile model for the Southeast Asian countries. And this is the model which was developed and finalized and printed, and now it is being circulated. Those of you who are interested in understanding more of how the process was done, how we calculated it, how other countries have been following, they can go through this document. It is available on the net, and Dr. Pradeep Agrawal, I will request that he can also share it with all the members. Well, with this, I thank for your patient listening, and thank you, Dr. Pradeep, for giving us this opportunity. Thanks a lot.
Thank you, sir, for highlighting the importance of nutritional model. Sir, now I will request Dr. Now I will request Dr. Rakesh Kakkar, sir, to introduce our next speaker, Vandana Shah, ma'am.
Please show the slide. So now I'll take the opportunity to welcome Ms. Vandana Shah, who is the Regional Director of South Asia Program, Global Health Advocacy Incubator. And she leads a policy and program development intervention in India, Bangladesh, Pakistan, and South Asian countries, and works closely with multiple stakeholders, including government, media, and social society to formulate and implement political, legal, and media strategies. So she is playing a very important role in policy development. She is helping government and supporting many important initiatives like tobacco control, obesity, cardiovascular health, food policy, droning prevention, and gender issues in Asia. She also coordinates a multi-country litigation team. As she is a LLM by profession. So formerly she was the executive director of North Carolina Health and Wellness Trust Fund, overseeing public health programs with annual budget exceeding 30 million US. She has served on the boards of various healthcare and non-profit organizations and currently also serves as a vice chair of board of Foundation for Health Leadership and Innovation. And today she'll be presenting about the food industry resistance to progressive FOP nutrition label. So I would like to welcome Ms. Vandana Shah for this session.
I want to just start out by thanking the organizers of Eficon 2021 and for organizing this very important panel discussion today on front of package labeling. My presentation is going to be focused on anticipating and countering food and beverage industry interference in front of package labeling and sharing global experiences from around the world. So a little bit about my organization. The Global Health Advocacy Incubator supports governments and CSOs in adopting and implementing strong public health policies that will reduce the death burden and disease burden around the world. So we focus on a lot of issues, and the issues that we're currently working on in India include road safety, cardiovascular disease, food policy, civil registration, as well as tobacco control. So today we're going to talk about a little bit about the interference and that FOPL faces from the industry, and we're also going to talk about recommendations for decision makers. So here's the question: why does the ultra processed food and beverage industry interfere in food policy? So globally, if you've seen, the food industry has managed to influence legal and political environments to constantly delay and hinder, or actually stand in the way of the adoption and implementation of healthy nutrition policies. So we see this around the world. So what's happening in India is not unique, that governments and advocates have encountered industry interference tactics as the main obstacle to achieving food policy change. And they sort of use the same arguments, the same tactics, and which we're going to go into a little more detail today to actually prevent policy progress. There is a huge power imbalance between these large global multinationals and governments, as well as civil society organizations, public health organizations, like the ones that are gathered here today, in being able to really counter this narrative. So what are the ways in which industry interferes in healthy food policies? The first is they capture the government. So they have tremendous power to both lobby the executive and legislative branches of government. It's a revolving door. So people leave government, they join the food industry. Food industry people are part of government. If you look at FSSAI today in India, it has a lot of ex-food industry officials. We also have in trade and agricultural ministries, as well as food ministries, a lot of industry officials. There's a lot of financial incentives to political parties from big food. I mean, we earlier had big tobacco, but now we also have big food. They seek involvement in technical committees. You can see in most food regulators, including India, technical committees are infiltrated by the food industry. And they also do a lot of public-private partnerships, voluntary regulation, and then their judicial power. They're always engaging in litigation against the policy, and they use trade and investment agreements to challenge the policy. Once again, the second sort of prong is capturing the science. So constantly we find food industries trying to fund, produce, and disseminate biased research to influence policy. They have a lot of influence because of their grants making and their funding on academic institutions, scholars, professional nutrition and health associations. If you examine the food and technical committees, even at India's FSSAIs, you will find that a lot of them have conflicts of interest. The other thing which they do is they're doing a lot of demonizing of scientific interests and going after researchers or public health advocates that are not on their side. And lastly, they do a lot of industry-sponsored education programs, study tours, conferences to win over government. The other piece is media capture. A lot of food industry also have co-ownership. They also have ownership of PR agencies, of large media agencies, and are able to influence the media. They also, they have a legitimate sort of, they're an actor in the country's development. So they try to put forth, that food regulation would be anti-development. They also talk about claims of job losses, economic damage, too much regulation by the government or nanny state. They're also forever trying to disseminate their own preferred solutions, which are, not, self-regulation, voluntary, public-private partnership. And then they always shift the blame away from the industry using the media that it is an individual decision to eat healthier foods. The other piece is, they also try to capture CSOs through their large corporate social responsibility programs. Especially in India, we see now most CSOs are getting a lot of funding from the industry. They also support a lot of like walkathons, marathons, physical activity to kind of neutralize their ill effects on health. They have a lot of alliances with health organizations. They've developed a lot of front groups, healthy eating, and good lifestyle groups. And they also try to kind of break up civil society. So in some ways, what are these core global arguments that we see played out in every country around the world? So whether we're in India or Brazil or Colombia, the arguments and the playbook is the same. So if you look at, 5 countries where the Global Health Advocacy Incubator has been running front of package labeling, you will see that each of these countries has experienced long delays. A 5-year delay in Chile. They actually, delegitimize the regulation using economic arguments. A lot of negative comments about FOPL in Mexico, and constantly delaying the debate in Colombia. Then the other piece with the regulation is they're always trying to meddle with the regulation and actually weaken the regulation, filing lawsuits. And then even after the regulation passes, they've also, worked on a lot of like preventing implementation, delaying when the law will take effect, also filing lawsuits to prevent implementation. So what are these common claims that we see around the world, whether it's India, Colombia, Chile, Peru? They actually have a lot in common. So the first claim, which is obviously on the face of it just self-contradictory, is FOPL is not an effective solution to public health problems. But we see from evidence in countries like Chile and now Brazil that FOPL actually leads to decreased purchases of unhealthy products, reduces the perceptions about product healthfulness, and then industry is forced to reformulate products. FOPL also has the potential to reduce obesity and diet-related diseases, save government money from direct and indirect healthcare costs. So basically, on the face of it, industry is self-contradictory, because if it is not an effective solution, why are they fighting it so hard and spending hundreds of millions to lobby against it? But just a word of caution that FOPL is not a silver bullet. It is part of a complementary package of policies like marketing regulation and taxes on junk food. The second claim that industry makes is individuals can make personal choices about what they eat, and they themselves are responsible for their health. Now, if you look at this, most individuals do not have enough information to make healthy choices. The current labels that we have, which are back of pack labels, are completely impossible to understand unless you're an expert nutritionist spending 15 minutes reading that label. The high-end warning labels that are now proving effective around the world and then are being pushed by advocates in India are easy to understand for a very minimally educated person. It clearly indicates if a product is high in sugar, salt, or fat. The third industry claim is that traffic light label is effective. Many studies have shown that these are very confusing because you have red on one, green on one, yellow on one. So ultimately, you're actually left with confusing information whether this bag of cookies or this salty snack is good for you or not. So warning labels means that you only have a warning if it is high in that element. So it's very clear that the label itself is an indication that there is a problem. The industry claim number 4 is that, FOPL warning label is trying to scare consumers from buying certain foods and beverages. But clearly, this is not right. High-in warning labels provides consumers with very simple, easy to understand and accurate information, giving them the power to make the choice whether or not if they have blood pressure, do they still want to get this particular brand of chips if it's high in salt? So basically, it puts the power in the hand of the consumer based on their unique circumstance. Because maybe if it is a child eating that pack of snack occasionally, maybe it's okay to buy. We have an independent study in Canada comparing different FOPL, including text, stop sign, and a triangle, found that 88% of respondents indicated that the symbol, which were high in warning labels, were just about right. And when in sort of indicating where the product was high in a particular ingredient. High in warning labels do not provide enough information and inform consumers on the health benefits. These types of labels unfairly label certain foods. Now, high in warning labels provide information that helps consumers clearly and accurately identify products that are high in sugar, fat, and sodium. So basically, consumers can use this very quickly. As you can see, this box of Nutella, it's high in sort of 3 of those dangerous ingredients. Labels that have positive claims like health star rating, which is confusing because you may have 3 negatives, but if you have a positive, because if you're high in fiber or high in flaxseed, then you get a positive label, which is completely confusing. So even though I will see high in salt, sugar, and fat, but you have a positive label that it's high in fiber or it contains, antioxidants, then you're completely confused whether you're going to buy this or not. And very likely you may buy it, taking something that is really harmful for, say, your cardiovascular disease. Claim number 6, FOPL would be costly and time consuming to implement. However, you want to see that this is really not true. Companies constantly change their packaging to position themselves in the market. In COVID, we found that companies redesigned their packaging to include COVID-safe messaging. In Uruguay, where the law was to go into effect in February this year, many products already had the warning label. Leading up to the implementation of FOPL, the industry can use stickers instead of redesigning. And we also found that there's absolutely no impact on jobs in a country like Chile, which comprehensively implemented these labels. So the industry claim number 7, and this plays out in a very big way in all countries, is that non-legal measures such as self-regulation, public education is effective first step to addressing public health concerns. The industry claims that they are willing to engage in additional alternative solutions to the NCD crisis. They will support education and they will support voluntary measures. But you find that self-regulation is not effective. It is haphazard. It is not evidence-based. And industry self-regulation is always based on confusing labels that do not put the power and information back in the consumer's hands. Industry's claim number 8. They always feel that nutrient profile should provide detailed information by serving size for selected products. So the industry wants to claim that it should be by serving size with detailed information, quantitative. They also want to push for lax thresholds and a lot of exempted product categories. But what is the evidence, which is also being acknowledged by all the experts in India, is that the label should be based on 100 grams. It should be a simple interpretive label, only focused on excessive nutrients. So the warning label style label will show where a product is high in salt, sugar, or fat. It will not give any other detailed information, and it'll be based on 100 milligram of the product. Also, it'll be based on the standardized thresholds based on the WHO profile for the region, in our case, CRO, and it'll be universally applied to all processed packaged food. And there would be thresholds for only 2 categories, not multiple categories, food category and beverage category. So my final slide in closing is for decision makers, for policy makers, or leaders that present in this conference who work with policymakers. What are the key recommendations we want to offer for policymakers? Do not allow the food and beverage industry to participate in the design, formulation, and evaluation of food policies. We need to make sure that we use legal language to protect the policies from industry's legal attacks and frame the policy in international and national human rights language when possible. We want to make sure that we are approving mandatory legislation, regulation, which is based on the best scientific evidence that is available. We also want to completely avoid the pit hole of industry, which is voluntary agreements, public-private partnership, and manipulation of the science. We want to ensure strong conflict of interest language and frameworks to protect the policies. And if where industry must participate, we want to make sure that there is clear and transparent participation of the industry that should be informed and consulted, but without allowing them to negotiate the policy premises and standards. So industry needs to be kept at arm's length in a fair negotiation. And it is very critical that that government is in charge, getting independent input from all of the experts and is not manipulated by industry. So with that, I'd like to bring my presentation to a close. Once again, thanking the organizers at Eficon for bringing this important group together. And I wish them all the very best in being able to guide the government to adopt a strong FOPL policy for India.
Thank you, ma'am, for a highly insightful session on food industry resistance to progressive FOP nutrition labels. Moving on, I would like to invite Dr. Harishankar Joshi sir to introduce our next distinguished speaker, Dr. Pradeep Agarwal. Over to you, sir.
Welcome, Dr. Pradeep. Yeah, Dr. Pradeep Agarwal is at present Associate Professor in the Department of Community Medicine, and he's a member of Governing Council, Epidemiological Foundation of India. And he has done his community medicine from HIMS Dehradun, and his work in WHO also as SMO. And he's one of the dynamic faculty in the field of public health. So I welcome Dr. Pradeep, you for your session. Over to you.
Thank you very much, sir. I hope I'm audible.
Yes, you're audible. Yes, you're audible.
Thank you. So I request the organizers to give me the rights. Okay, great. Okay, but I know that we are running a bit late of the program. I won't take up much of a time, but the topic why I'm coming in the last is I'm really thankful to all the speakers and to taking up the initiative of bringing and collating the things related to the FOPL and the way forward, how we as a public health expert can transform the existing knowledge into a policy that can be of beneficial for whole of the India. So in that relation, I am going to talk on call to action to public health professionals for a strong FOPL. Now, as already being contributed by most of the research and evidence available, nearly 62% of the total deaths of non-communicable are related to the non-communicable diseases. Keeping non-communicable diseases rising trend, now there is a felt need to adopt a regulatory policy that is a scientific evidence-based policy so that non-communicable diseases can be tackled. Another important reason is to promote healthy eating habits. Now that is more important for a long-term addressing the non-communicable disease. To address non-communicable disease, one of the strategies that have been adopted globally and is the eating habits is providing a nutritive value. and that comes in a form of front of package labeling that is being practiced in most of the countries with an evidence to build up an informed choice at a consumer level at the time of purchase. So keeping that global best practices and an evidence-based medicine, All India Institute of Medical Sciences Rishikesh is implementing a pan-India awareness generating project, Healthy Food for All. It is a part of our community responsibility and to build up a momentum so that medical voices can be generated and can act as a guiding force for the government of India to bring a strong, intuitive, informative, acceptable FOPL. The main objective of this project is to understand the need of front of package labeling, creating the awareness among the public to check the nutritional facts. As already told by one of the previous speakers, there is a nutritive facts available, but that is available on the back side. So how these can be more intuitive, more acceptable, more informative, understandable at a consumer level. Lastly is to empower the consumers for making a healthy food choices. That is all regarding the project. I just want to update everybody, and thanks to the organizers for bringing FOPL on the forefront and giving an opportunity for this plenary sessions. We welcome all the delegates. Anyone who would like to collaborate and contribute with us for a strong FOPL is most welcome. Thank you. Back to the organizers.
Thank you, sir, for this very informative session. Now I will request Dr. Rakesh Kakkar, sir, to proceed the session further. Thank you. Over to you, sir.
Thank you. I would like to thank all the speakers who have very well highlighted the importance of FOPL. And to summarize the session, approach needed to promote healthy diets and reduce overweight, obesity, diet-related NCDs, including cancer. And it also to stimulate healthy food production and product reformulation at industry level. So at consumer level as well as at production level, there's a need to change the policy so that all the consumers have the awareness to choose the right food to reduce the diet-related NCDs. So this FOPL provides a quick and straightforward information to the consumers to identify food and beverages which are unhealthy, and especially total calorie count, saturated and trans fats, sugars and salt are of special importance. So this should be FOPL, as it is a concrete public health regulatory and effective means for promoting healthier lives and protecting the public health. So this label should be simple to understand, interpretative, and help consumers to take decision to improve the public health. So our speakers have rightly pointed out, they have expressed the concern or challenges which are there through the industry. And Umesh Kapil sir has presented nutritional profile by the WHO. So I would like to thank all the organizers, Dr. Pradeep Agrawal for bringing this special topic and plenary session for making awareness to all the participants. So over to my co-chair, Dr. H. Joshi.
Thank you, sir. You rightly said, this session was very informative, and the speakers, Dr. Rasmi, Dr. Umesh Kapil sir, Dr. Vandana, and Dr. Pradeep, has highlighted the things in very well, and it is one of the very important thing, as you already discussed. It must be properly highlighted. So, and I am thankful to the organizers also for giving us this opportunity of chairing the session. of such a nice informative session. Thank you all. Thank you, sir.
Thank you. So what to Divya and
Yeah, I think there is a question. Rashmi ma'am, could you please answer? So I can see a question in a chat box. I am Dr. Bhanu from MGM CRI Pondicherry. What is Nutri-Score and what labeling we can see in usual market? How it differs from FOPL, which you mentioned. So there are three components. What is Nutri-Score? What labeling can we see in the usual market? And how it is different from FOPL, which we have mentioned. Back to you, ma'am.
Okay, thank you. Thanks a lot, Dr. Banu. I just want to put it up for you to say that Nutri-Score is, which it says about the nutritional scoring. I put up a label to show you that how the scores of nutrition is being put up. So that's the Nutri-Score. Means you will say how many, what is the present, what is absent, not any diagrams. That is Nutri-Score. And what we see in the labeling, what we see is we have as a total, like sugars, Nutri-Score will have in detail, like trans fats, sugars, and this, whereas here you may have carbohydrates. What is not very clear ki what exactly each ones are. Total carbohydrates, protein, and something which is a broader perspective. So front of package labeling, what I'm talking about, or what everybody is advocacy here telling about is, which will have a detail that unhealthy public health nutrition problem will be highlighted. Now I know there is carbohydrate so much. In that, I do not know what is the excess sugar. I do not know what is the excess salt. When I don't know how much salt I have to take, I will not be knowing also how much excess I am taking. I also do not know how much excess of trans fats I'm taking. So is that a trans fat? It has only fats. So I do not know whether it is a trans fat. I do not know whether it is good fat, all these. So FOPL, front of package labeling, basically talks about saying that how these things are in detail and told the people what is good and what is bad.
Thank you very much, ma'am. Another important question, and which one of the delegate have asked, is how you are going to cross-check warning labels mentioned on FOPL. Is there any objective criteria after launching any product?
Okay, is this the question to me? Should I be answering?
Yes, ma'am.
Yeah, okay. Labels mentioned, is there any objective criteria for launching the project? Yeah, whenever it becomes as a rule, or that's how it happens in majority of the countries, where we have seen that in majority of the countries, even before as the product quality is being assessed, there is also the front of package labeling being assessed before the product comes back to the market. So it's not, we see what happens in the market even before the industry puts across to the market, it will be checked. Like how we also see the drug regulations, how we also see that how all the drugs are appropriately done, there is a drug regulation. So if there could be a policy made, definitely there will be. And like what we see that there is no, we look into, there are people, food inspectors who come and check out. FOPL also needs somebody who can be doing that and have a checklist. Right now, we do not have a strong policy, though there is a whole issue. We do not have a strong public health policy. So there is no cross-checking, but if it happen, it was a definitely such things have to come into place. Without monitoring, without evaluation, no policy will also be working on. So that definitely we require.
Thank you very much. So I hope Dr. Govind Rao, and there is one more suggestion from Dr. Nilanjana regarding the use of more state specific. So you being an expert of FOPL, ma'am, and other people of working in the same field are requested to take up the issue if the FOPL can be regulated at a state level. I hope with this as a team, we would like to hand over the mic back to the organizers. Thank you for the opportunity.
Thank you so much, sir and ma'am, for such an interactive session. I would like to extend our heartiest gratitude and thanks to all the esteemed chairperson and speakers for being for participating and for their presence in the session. It wouldn't be possible without your support and guidance. Thank you so much, all.
Thank you. Thank you.
Thank you. Thank you.
A very good morning to all our respected chairperson, speakers, faculty and delegates. We welcome you all to the session on National TB Elimination Current Updates. As we begin, I would like to welcome and address our chairpersons. Professor Dr. Neeraj Agarwal sir and Dr. Pradeep Deshmukh sir. Professor Dr. Neeraj Agarwal, sir is currently the Medical Superintendent, Professor and HOD, Community and Family Medicine at AIIMS Bibinagar. He was also the former Dean at AIIMS Bibinagar from November 2020 to June 2021. He was also former dean at AIMS Patna 2019 to 2020. He was running multiple projects with the support of UNICEF, ICMR, Government of India, Government of Bihar, Minerva in various districts of Bihar. He was also nodal officer AIMS Patna during the COVID-19 pandemic. He launched the revised National Tuberculosis Control Program (RNTCP) at PHC Dayalpur. He has various numerous publications in international and national journals. Our next chairperson is Dr. Pradeep Deshmukh sir. He is the Dean Research, Professor and Head, Department of Community Medicine, AIMS Nagpur. Sir has done MD in Community Medicine from MGIMS Sevagram and has secured PG graduate certificate in nutrition. He has also been a part of international perspective in participatory monitoring and evaluation. Sir has 22 years experience of teaching in both UG and PG and has completed more than 30 sponsored projects with 120 publications. Sir has also the author of the book on qualitative methods in health and educational research. Sir is interested in nutritional and NCD epidemiology as well as participatory research and community empowerment. Thank you, sir. Thank you, sir, for taking out your precious time for being with this session.
Thank you.
Now I would like to request Dr. Pradeep Deshmukh sir to introduce our next speaker, Dr. Anilji Purti sir.
Good morning, everyone. I feel privileged to introduce Dr. Anil Purti, who is professor and head of community medicine at PIMS Pondicherry. He is also a vice chair of National TB Elimination Program, National Task Force India, has worked with state government on numerous national health programs, and closely worked with Department of Health, the Government of Puducherry, and Government of India for elimination of tuberculosis and National Polio Surveillance Program, and also the National AIDS Control Program. He has received many awards and fellowships and has been part of numerous projects. I think he is the best person to update us about the policy update on NTEP. I invite Dr. Anil Purti to start his presentation, please. Hello, is he there, Dr. Anil Purti?
Good morning. Nice to be able to meet each of you over this virtual platform. It's an opportunity to always participate in these CMEs where we are able to share some of these updates that we continue to learn from as we work together with the National TB Elimination Program, working towards what we together can achieve by 2025. My brief for presentation today is to share some of the policy updates, and I'm glad that Central TB Division has kindly shared these slides with us, and I'm presenting from the data that has been made available to us. Our Honorable Prime Minister of India has already made a commitment that each one of us needs to work together to achieve the ambitious tasks to end TB in India by 2025. And this is clearly ahead of what has been planned by other countries elsewhere. Specifically, the following states that are mentioned on the right side have already made signed commitments to work towards this end. The TB disease burden in India has shown a downward trend, however, continues to be a problem. However, with all concerned working dedicatedly to eliminate TB in India, there has been a downward trend from the data that we would like to share to each one of you. There definitely has been an increase in the reporting of TB cases. Of course, during the pandemic, there has been an issue of lower number of TB patients who have been reported to the national program. Dear friends, this is not only unique to India, but has happened in many other parts due to the global pandemic. Maybe please remember that HIV TB is about 2%. A drug resistant issue that we face, 2.8%. It appears small, but when we put at the absolute numbers in terms of numericals, these numbers are large enough to call our attention to work towards each one of them. In case we thought much of the problem with regard to these issues are in the urban areas only, no, it continues to be a challenge or bigger challenge in rural areas and also in tribal areas. This graph shows us the rate of TB notification over the past 2 or 3 years. And while there has been a downward trend, we believe it's catching up, and soon, with the help of all stakeholders, we should be able to get the reporting into the Nikshay portal, the online portal that the program is using for data capture, assimilation, and also for program management, Nikshay portal. There have been several steps that have been taken by the government of India with all stakeholders to overcome the COVID challenge. Just to put a few of them, in addition to getting the COVID laboratories up and running, even during the pandemic situation, the TB program has worked together to see that there would be bi-directional screening of all COVID patients, all TB patients being screened for TB, active case finding TB campaigns, contact tracing of households looking for both symptoms suggestive of COVID and TB, home-based sample collection, and also very important to ensure that at least 1 month's supply of drugs is delivered to the patient's doorsteps. This has been quite successfully done in many situations, as reported. The NTB targets aims to bring down the incidence of TB and its mortality to the figures that have been mentioned by 2025. At the current level, we are proceeding in the right direction. Perhaps we need to work harder in order to get to the figures that have been mentioned on this table. Well, the road to realize TB-free vision has been outlaid, and the best scenario would say that if we are able to screen and do the needful for the presumptive TB patients, achieve a notification rate of over 85%, coverage at least 15% of those with latent TB, and have the PPSA interface working actively for engagement of private sector, we could reach that road leading on to realize a TB-free vision. Just to punctuate on the same point, however, if this were to increase or efforts were to double, it could be a better or an improved target that we could achieve together. A third scenario that has been put forward, quite ambitious, but we're glad that the program managers have put it down so that each one of us are able to see and learn of what could be done by each one of us. Perhaps I think this is important because in addition to the PPSA engagement that I just mentioned, introduction of vaccines and non-health interventions like undernutrition, poverty, and living conditions are other add-on interventions with the support of various stakeholders, which will have an important bearing in TB control in India. The National Strategic Plan basically builds or has been put around these four principles. So prevention of TB, detecting more of them, building capacities, and putting all of them into treatment as per policy guidelines. In the activities around prevention, there has been a sustained effort to promote COVID-appropriate behavior, contact tracing. We do have a well-planned and documented program PMDT, or Programmatic Management of TB. There has been an effort towards community mobilization and facility-based or airborne infection control at health facilities. This now is also being rolled out at the community health levels. Continuation with prevention for preventive therapy. There are guidelines that have been rolled out, and this has already been started in a few target populations. Those of us who are keen to know more about, may I humbly request each one of you to kindly look through these policy documents that are readily available at the CTT website. I was just mentioning about this guideline, which is readily available at the website. With regard to detection of these individuals, there has been a push forward, getting out from the usual conventional facility-based or hospital-based diagnosis to reach out to the community through these various interfaces. One of them, an important one, having the diagnostic facility, having the state-of-the-art rapid molecular tests right at the doorstep level, literally, so that patients do not need to travel far to get a diagnosis. This has been made possible by several partners working together to support in detection of TB as mentioned. JEET happens to be one of them. The daily regimen has a fixed dose combination now. A lot of work has been done in this regard. The ASHA workers continue to provide support along with community volunteers, and by this mechanism, several methods have been adopted, including ICT methods, to promote adherence and to ensure that each patient gets the right drugs and the right dose at the right time. The PMDT document is readily available. We continue to have a training program through the ECHO platform. May I request as many of us can make it a point to do participate and attend at this training programs that are being held almost every few weeks and I'm sure it would be held in a nearby district or state, which you can please do participate in. On the occasion of the World TB Day 21, this document had been released by our Honorable Health Minister in presence of many other distinguished dignitaries. Building capacity would include IEC, multi-sectoral collaboration, surveillance, and to improve the procurement and supply chain. Each one of these have been meticulously organized and are available. These efforts go a long way to ensure efficiency in targeting the interventions for the population for whom they are intended to reach. DR services continue to be an important part in medical colleges, with these government orders being issued that it's important for each medical college to get engaged in diagnosis of MDR TB in India. Difficult to treat TB clinics, again, another important spoke and wheel method by which each state now has the possibility to engage, discuss, and get an appropriate scientific diagnosis and method of management for difficult to treat TB. And these clinics are available through the national level center led by NITRD from Delhi and several other centers around the country. These have been gaining momentum, and may I use this platform to invite as many of us interested to join this and participate in the program. The subnational certification is another very good initiative where districts and states do apply, submit their applications for being considered for these awards. The Ministry of Health Central TB Division does verify it. There is a ground level verification for which a third party is engaged through the Indian Council of Medical Research. They do verify the records, continue to interview participants, other stakeholders at the respective sites, and then come up with their reports. So this certification process is not only prestigious in terms of awarding the TB-free status, which has been given to Lakshadweep and Badgaon district of Jammu Kashmir. We'd really like to congratulate the teams who have been able to do this first. It's very encouraging for the rest of us who would fall elsewhere, the respective districts or states that we work, but gives us an opportunity to work towards these subnational certifications and work in the area to bring down both the incidence and the mortality as per the guidelines that have been laid down by the national program. There continues to be support and well-renowned experts, officials have been traveling far and wide to almost every state, interacting with various stakeholders to ensure that each of these teams are better prepared, are supported towards meeting the targets set for ending TB by 2025. We've had the opportunity to interact with a few of these teams and really like to appreciate they're doing a marvelous work. A couple of slides more, there is a push towards transition from smear microscopy to rapid molecular testing, vulnerability mapping for active case finding, scaling up interventions for private sector interventions. There is a whole module of how this can be done available. And what I like is there is an opportunity for community engagement, including social organizations, corporates, and leaders towards TB Mukt Bharat. Each one of us need to continue to work on these principles of prevent, detect, treat, and build, and support the TB program as we work towards ending TB in India by 2025. That's all the time that I have for now. I'm sure the other topics will be covered by the other speakers. Thank you very much for your time.
Thank you, sir, for sharing such an informative and valuable session with us. Now I request Dr. Pradeep Deshmukh sir to introduce our next speaker, Vinod Kumar Garg sir.
I invite Dr. Vinod Kumar Garg, State TB Officer, Rajasthan, to present on TB elimination activities in Rajasthan. Dr. Vinod Kumar Garg, please.
Good morning, everybody. First of all, I'd like to thank Dr. Pankaj Bharadwaj, who has given me this opportunity to speak on it. And topic is TB elimination activities in Rajasthan. I think it's the right time to find TB, to treat TB, and to end TB. Now, a little bit about tuberculosis. We all know that TB incurable disease caused by Mycobacterium tuberculosis, and it spreads when a sick person who is having tuberculosis of the lungs, he coughs or sneezes, then he expels the bacteria in the air. And whenever any person inhales in that air, he may become sick. Tuberculosis mostly affects adults in their most productive years, that is 15 to 60 years of age. However, no age group is free from the TB. Overall, 95% of the cases and deaths are in developing countries. In 2020, 86% of the new TB cases occurred in high burden countries, that are 30 high burden countries. And 8 countries accounted for 2/3 of the TB cases. And India is one of them. A journey of the TB elimination program. Initially, it was started in 1962 as National Tuberculosis Control Program. Then in 1993, this was revised, this was revitalized as RNTCP. A high power committee was set up, and in 1995, it was started as a pilot project. In 97, it was decided to start it in a phased manner. On 24th March 2006, it was declared by the Government of India that entire nation has been covered under RNTCP. And after that, in 2020, the program has been renamed, and now the name is NTEP, National TB Elimination Program. Little bit about the vision and the goal. We want to achieve a rapid decline in the burden of TB morbidity as well as mortality, while working towards elimination of TB by 2025 in our country, India. And our vision is zero death and zero disease and no poverty due to tuberculosis. To eliminate TB by 2025, that is 5 years ahead of the rest of the world. The global estimate is 2030, but India has promised to eliminate TB by 2025. Now there are 4 pillars. One is detect. We want to reach to every TB patient, especially in the private sector, and to treat them with high quality TB drugs. We also want to prevent the emergence of TB in susceptible populations, and we want to stop the catastrophic expenditure due to TB by all. And in the last, we want to build and strengthen the supportive system, including the enable policies and HR, human resources. Now, this is state profile. The population of Rajasthan is 8.1 crore. Out of that, 1.8 crore is urban, 6.2 crore is rural, and 1 crore is tribal population. In Rajasthan, there are 249 blocks and 288 TB units, 2,745 microscopic centers where sputum examination is being done. We are having 66 CBNAT machines in Rajasthan and 61 TrueNAT machines. There are 3 culture DST labs, 7 nodal DRTB center, and 33 district DRTB centers. Now this is examination rate, smear microscopy plus TrueNAT or CBNAT. In 2018, the rate of examination of presumptive TB cases was 766, which increased to 830 in 2019. But due to COVID, it decreased to 543 in 20, but we are trying our best to reach to a higher level. Until now, we have achieved 470 per year per lakh. If we talk about the notification rate, we can see that population is increasing. Notification rate increased in 2019 as compared to 18. The rate was 201 in 18 and it increased to 221 in 19. But due to COVID, we could not notify much cases in 20 and it decreased, it fall to 172. If we see the notification of private as well as public sector, the notification increased of both public and private in 19. Now, this notification, if we talk about the percentage which was achieved by private sector as well as by the public sector. Initially in 2018, there was a difference between the percentage achieved of the public notification and private notification. Private notification was far less as compared to public. But as the year passed, the public notification slightly increased, and now in 2021, the private notification is as equal as the public notification if we talk about the percentage of the achievement. Now, outcome. Once we start the treatment, at the end we declare an outcome of the patient. This is outcome of the patient who were registered in 2017, 18, 19 and 20. In 17, the outcome was, the successful outcome was 86%. But 2018, it fell to 77%. In 19, again, it increased to 82%. And in 2020, we have achieved successful outcome up to 81%. It is almost equal of the private as well as public patients. Now, treatment outcome of the private patients. In 2017, the successful outcome was of 49% cases only. It increased to 52% in 18, again 78% in 19, and in 20, the outcome has increased, or successful outcome has increased up to 82%. This slide shows that our private practitioners are doing well. They are working hard and their successful outcome after initiation of the treatment is increasing constantly. And it has reached up to 82%. Now we know that every diagnosed TB patient, HIV screening is must. Before starting treatment of the patient, HIV is to be tested. And if patient is HIV positive, then the patient is also referred for ART. HIV status is known. In public patients, it was known for 90% of the patients. It increased to 96% of the cases in 20, and in 21, we have known the HIV status of 93% of the patients. If we talk about the private patients, it was only 63% of the cases in 19. In 20, it increased to 90%, and in 21, it is 88%. Overall, we know the HIV status of 92% of the cases. After knowing the HIV status and the HIV positivity, fortunately, it is less in Rajasthan. In 19, it was 1%. In 20, again 1%. And in 21, it is again 1%. So almost 1% TB patients are HIV positive. Now again, after initiation of the treatment, the essential task, one of the essential tasks is UDST status, Universal Drug Sensitivity Test. Every patient has to be tested for this rifampicin sensitivity status. In 2018, we offered the samples for the UDST of the 28% of the patients. It increased to 51% in 19, again increased to 61% in 20. But due to some or other reasons, we are not having the cartridges at the moment. So it has decreased to 36%. We hope that very soon we will be able to increase this percentage. Then again, every diagnosed TB patient is to be screened for diabetes status, because if person is having diabetes, then it's difficult to get it cured. And anyhow, if patient is cured, then chances of recurrence of TB is more in diabetic patients. So to know the diabetic status is essential and mandatory. In 2020, we were able to know the HIV diabetic status of 90% of the patients in public sector and 88% of the patients in private sector. In 21, we have known the diabetic status of 85% of the patient in public sector and 84% of the patient in private sector. And after knowing this status, 3 to 4% of the TB patients are found to be diabetic. One good news for the private patients, as per instructions of the government, we are supplying our government medicines to the private patients. Patient going to the private setup, if he wishes to get the government medicines, we are happy to supply the medicines. Until now, we have supplied free medicines to round about 4,000 of the patients. This is a new PPIS, Patient Provider Incentive Scheme. This is services and incentive linkages. This is running only in Rajasthan. No other state is having this scheme. And under this scheme, as I said, that every diagnosed patient has to be tested for diabetes, for HIV, for UDST. And we are also required to know the bank statement, as we are paying 500 rupees per month to that patients. So to fulfill these activities, we are paying certain extra amount to the private practitioners. And this amount is other than 1,000 rupees, which is being paid to the private practitioner for notification and successful outcome. This 2,000 rupees is paid in 2 installments. First installment is of 1,300 rupees. It includes patient notification, bank detail sheeting, UDST, and HIV and diabetic status. Private practitioner will have to perform all these activities and will have to enter these results in the Niksha portal. Then he will get 1,300 rupees. Second installment is of 700 rupees, in which he will have to enter the successful outcome in the Niksha portal and distribution of the fixed dose combination government medications to the patient if patient is willing to get these medicines. So in this way, doctor will get 2,000 rupees for one patient. Now, highlights about our program in Rajasthan. There is a regular guidance and supervision by Honorable Health Minister, which ensures uptake in the program. Effective supervision and monitoring virtual meetings are being conducted, and on an average, we are in touch with the districts twice or thrice in a month. Rajasthan is first state which has achieved 100% digital signatures, and it has made our work of transferring the money to the patient very easy. Then state Niksha Patrika we have launched, which gives the doctors a good communication for the latest policies and best practices. Then way forward, we are trying to ensure 5 T's for TB, and including TB, there are now 6 T's. First is tracing, testing, tracking, treatment, and technology. We are trying to use the latest technology in the treatment and diagnosis of the patient. Then expansion of the molecular diagnosis. We are trying to reach up to block level for diagnosis, rapid molecular diagnostic test at every block. Then advocacy for engagement of political leadership. We are trying to sensitize the political leadership right from the Vidhan Sabha to the Gram Panchayat. Then intersector engagement, that is with the railway, defense, industries, and other sectors. We are trying to reach them and to take their coordination. Celebration.
Thank you, Dr. V.K. Garg, sir, for your valuable session. Now I request Dr. Pradeep, sir, to introduce Dr. Ashok K. Bhardwaj, sir.
Sir, would you like to introduce Sir Bharadwaj, sir?
Hello, you are asking me?
Yeah. Go ahead, please.
Yeah. Okay. Thank you. It's my privilege to introduce Dr. Ashok Kumar Bhardwaj, Chairman National Task Force. And though I not work with us, sir, but really I'm grateful to him on many issues which he supported me, and he came many times as an examiner or many other issue when I was working in GMC Chandigarh. So it's really, I'm proud privilege to introduce him, and also I'm thankful the organizer, Dr. Pankaj Bhardwaj, for inviting me for this particular conference and giving a much opportunity to introduce Dr. Ashok Bhardwaj. So Dr. Ashok Bhardwaj was emeritus professor at MM Medical College and Hospitals in Himachal Pradesh. Worked as a professor in community medicine in Shimla, Kanda, and Hamirpur. He was the national president of PSM in 2014 and 15. Then he received the Dhanvantari Orator of IPSM in 2011. Harcharan Singh Orator of IPSM in 2018. Vasudha Orator of IPSM in 2008. He had a lot of publication and a great orator, and he is a really champion of the tuberculosis and elimination of tuberculosis. For that, he was recently felicitated for his achievement in a field of tuberculosis. Now I invite sir to deliver his talk on this day. Thank you. Thank you, sir. Am I audible?
Yes, sir, you're audible.
Okay, right.
Starting the session of Dr.
Oh, yes.
Good morning, everybody. So, as we all know that our worthy Prime Minister, Shri Narendra Bhai Modi ji, has committed to end TB from our country in 2025. We know that with the current strategy in the program, we will not be able to do it. So, we requires additional interventions. One of the additional intervention is BCG vaccine, which the trials are going on. Another important intervention is TB preventive therapy. So I will be dealing with this TB preventive therapy in my session. We know that India has the highest estimated burden of TB infection. So 35 to 40 crore Indian are having tuberculosis infection. Of these are estimated to develop tuberculosis. For TB disease, and we have to provide TPT after ruling out active tuberculosis, and we can see the algorithm on the right side. Then this is the detailed algorithm. I will not deal in it because it is quite exhaustive. Then identifying at-risk population, how we can identify people who are at risk. So one of the strategies, the community-wise screening. So it's very difficult. Vietnam is doing it, but it's difficult for our country. So we have to have a targeted approach so that we can have public health response. Reason is not all individuals infected with MTB developed active tuberculosis, and there is no predictive test to identify who will develop and who will not progress to the disease. Then our target population is children less more than 5 years and adolescent, adult, household contact of permanent TB patients, children less than 5 years, and there are many other risk factors, other target group which are to be tapped in this TPT. Then people living with HIV/AIDS, I will discuss in detail. Adult and children more than 12 months living with HIV should be screened for TB using 4 symptom complex, which we all know. And TPT can be provided to those without symptoms. So symptomatic, we have not to provide TPT. Those without symptom, we have to provide TPT, but we have to rule out active TB in those with TB symptoms. So TPT should be given to all these individuals, irrespective of the degree of immunosuppression, whether they are on antiviral treatment, whether they have been treated previously for tuberculosis, or whether the woman is pregnant. We have to give TPT. Infant less than 12 months living with HIV who are in contact with patient of permanent tuberculosis are investigated for TB and should receive TPT with 6 months of isoniazid after active TB is ruled out. So we know that TPT reduces the overall risk of tuberculosis by 60 to 90% among patients living with HIV infection. Then all household contact of pulmonary TB patient, they should be given TPT we have to rule out tuberculosis. So in children of household contact under 5 year of age, TT after ruling out TB without TBI testing. We have two strategy: test and treat, and only treat. So for this group, it is all under 5. It is only treat. And in children of household contact more than 5 years and adults, so it is test and treat. We can test with other tests. Then chest X-ray should be offered wherever applicable. Then test for what are the tests for TB infection? We have two tests. One is age-old tuberculin testing (TST), and another is IGRA test, which everybody of us knows. So both tests measures immune sensitization with type 4 or delayed hypersensitivity to mycobacterial protein antigen that occurs following infection by MTB. So TST detects reaction to PPD, and IGRA measures the amount of interferon gamma released in vitro by white blood cells. Then what are the difference between two? If we compare them, the specificity is low in TST but is very high in IGRA, and sensitivity is high in both. Then ease of use is friendly, field friendly is TST. IGRA requires the lab. The cost very, very low, negligible in TST, but very high in IGRA. Private lab charges about 3,000 rupees. So manufacturing complex old product, complex multiple component, then children affected by young age, then patient living with HIV infection, it is we have to require the status before TST result. So it is also, IGRA is also affected by HIV and low CD4 count. So standardization is PPD RT23, it is a quantiferon TB code plus. Then IGRA specification we must have, because states are going to roll out, we must have the approved IGRA testing. So testing should be WHO approved, endorsed and licensed by the Drug Controller General of India. Test kit should also have certification of internationally standards, WHO GMP certification. So there are many currently certified commercially available tests. Then if the tests are outsourced, it should also be ensured that they are performed only by NABL accredited labs. And turnaround time from the sample collection to the test availability must be monitored. Then important is before starting TPT, we must counsel the eligible person and the family members. So we have to counsel what is the need for TPT. Patient is taking either for diabetes, for ARVs, for opioids, for antimalarial, because they all affect the effect of TB preventive therapy. So we have to have liver function test also, and the social and financial situations. We have to assess the support that would be required to overcome a barrier to TPT completions. Then there are some not much contraindication to TPT. So active TB disease, because we have to rule out active tuberculosis before starting TPT. Then acute or chronic hepatitis, then concurrent use of other hepatotoxic medications such as nevirapine, then regular and heavy alcohol consumption, sign and symptom of peripheral neuropathy like persistent tingling, numbness and burning sensation in the limbs, then allergy or known hypersensitivity to any drug being considered for TPT. So pregnancy or a previous history of TB are not contraindication for TPT. And contact with drug-resistant TB, we will be dealing not part of this presentation. So what is the guidance to states? So all states must intensify monitoring to saturate TBT coverage in patients living with HIV/AIDS and children less than 5 years, which is currently undergoing in the program. Regimen availability under the program, 6H may be considered for use in the respective patient group in consultation with the National TB Elimination Program. Give daily isoniazid for 6 months. If the 10-year and more children, 5 milligram per kg per day, and less than 10 year, 10 milligram per kg per day is the dose. Then the 3HP regimen, which still has not come in many of the states. This is 3 months of weekly rifampicin plus isoniazid. It is given for 3 months. Center will be responsible for TPT implementation. We are giving a greater role to the community health officer working at the health and wellness center. So then contact tracing will be done by the ASHA or the healthcare worker or the ANM, including community volunteers. The ART center and the tertiary care institution would be responsible for TPT services for all patients living with HIV infection and other high-risk groups respectively. The STO and DTO would be responsible for planning, capacity building, health system preparedness, human resource, etc., etc. And we have to involve the community for implementation. Now, here I want to add that we people in the Department of Community Medicine in all medical colleges has a greater role to play, because community engagement is an important aspect of TPT implementation. Because people say that we don't have any science symptom, why we should take medicine? So we have to go in the community, advocate the people, involve the various organizations, the community-based organization, other organization working in the field, so that people are oriented towards TPT, and we have the implementation, rollout of TPT in the country, and we have the result. So only then we can achieve the NTV goals of 2025 and fulfill the dreams of our worthy Prime Minister, Shri Narendra Modi. Thank you very much. Thank you for kind listening. Thank you.
Thank you, sir, for your nice lecture and understanding of tuberculosis elimination. Now over to organizer.
Thank you very much, sir, for a very informative session. Now I would like to invite Dr. Gunjan.
Good afternoon, sir.
Welcome, Dr. Gunjan.
Yes, sir. Good afternoon.
Good afternoon. Good afternoon, Gunjan sir.
Yes, yes, sir.
So, hello.
Sir, I'm audible?
Yes. Should I introduce to him, Akhil?
Yes, sir. I'm just sharing his CV.
Yes. So again, a privilege to introduce a chairperson for STF Rajasthan, Dr. Gunjan Soni. He is the senior professor and head in respiratory medicine, SP Medical College, Bikaner. He has excellence in medical education research, awarded certificate for merit at district level in 2004, 2008, and 2019 for extraordinary work in the field of respiratory medicine. Great, getting a hat trick in a merit at district level, teaching experience of 22 years, various national and international paper, he has participated in many events of the journal tax meeting and operation research workshop, awarded Best Doctor in 2018 by National Rajasthan Daily newspaper for excellent work in the field of the respiratory medicine, president of RMCTA Bikaner. So again, I invite Dr. Gunjan Soni to deliver his talk, and due to scarcity time, I will ask him to restrict for 5 minutes, and then we have some question answer session. So over to Dr. Gunjan.
Good afternoon, sir. Thank you for the kind words, sir. Please share my slide, or should I share my slide, sir?
Sir, are the slides visible?
The next slide. So the medical colleges are the temple where we train the undergraduate student, the interns, the postgraduate student, and they will go to the periphery and they will advocate the NTP program in a very effective manner. So they play a very important role in the health system, and they are important to assess and improve the quality of TB services in the country. It is of very important role because the research are being done in the medical colleges. We give the thesis, we give the OR project. So there's a very important role of medical colleges in the NTP. In medical colleges, we have a task force, and we have a core committee also. So we have a state task force, we have a zonal task force, and we have a national task force. By next slide, sir. Next slide, sir. So the role of medical colleges started in 1997, and it gained momentum in 2001 and 2002. The medical colleges, we have a system of core committees, state task force, zonal task force, and the national task force. So we present the meeting minutes to the zonal task force and then to the national task force. So there's a hierarchy is there, so that all the lacuna which is being there in the medical colleges, they are being reviewed by the experts. So medical colleges are very important in the implementation of the program. The NTP supports medical colleges for contractual manpower, lab reagents, ATD drugs, training and sensitization. The core committees are being held in every medical colleges under the chairmanship of the HOD Pulmonary Medicine, and they monitor the activities of TB program in the medical colleges, where all the members from various faculties participate, and they can discuss their problems regarding the control and elimination of tuberculosis. Next slide. So I told yes that these are the temples where we train the interns, the postgraduate, the undergraduate students. So it is very important in the training and teaching of the students, for the service delivery, for the advocacy of the program, and for the operational research. So being the leaders in the society, we have a greater role to play in the elimination of tuberculosis and in the program of NTP. Next, sir. Sir, we have in the medical colleges all the facilities such as designated microscopic center, DOTS centers are there. We have a recording and reporting of the data, carrying out advocacy for NTP, conducting operational research relevant to the NTP, and for this, the grant is being given by the state task force and the zonal task force and the national task force. So the students are encouraged to do their research in the field of tuberculosis, and which is very helpful in the elimination of tuberculosis. The diagnosis and treatment of the HIV patient and co-infection is being done here, because all the complicated patients come here for the treatment and the diagnosis. So medical colleges play a very important role in this. We have a dot plus site and the site for the multi-drug resistant and the XDR sites are there. We have a laboratory infrastructure for the early detection of the drug resistant tuberculosis. So this medical colleges in a health system play a very important role for the drug resistant tuberculosis, because most of the cases who are complicated not being treated at the periphery or they are treatment failure cases, they come to us, and by the help of the laboratory system, we can diagnose these patients, we can start the PMDT treatment also. Next slide. All the facilities are there in our medical colleges, and it is available in every medical college, such as digital X-ray, LPA is there, CBNAT is there, but I would request Dr. Vinod Garg to kindly arrange for the CBNAT cartridges. Without that, there is difficulty in doing the drug resistance. We are not able to know. So he will take the early action and will solve our problem. We can do the FNACs of the lymph node from the other side. We can do the histopathology, culture and DST for the diagnostic services of the tuberculosis can be done. Provide the indoor facilities for the severely ill patient or the drug resistant tuberculosis patient, and all the adverse reactions.
Thank you, Dr. Gunjan. Please, thoda sa, there is a time is shortage. Can we have some question answer session? Because already we are delaying the rate and delaying the in a session. So can I ask audience to ask a question? Sorry, sir. Any question?
There are questions in the chat box, sir.
There is, who can see you message? I am not able to see any question there.
No, I don't think there is any question.
Yes, Doctor.
I think we can conclude the session. We can thank the speakers. I would like to thank all the speakers, Dr. Anil Purti, Dr. Vinod Kumar Garg, Dr. Ashok Bharadwaj, and Dr. Kunjan Soni for updating us on the National Tuberculosis Elimination Program. Thank you so much. Over to you.
Okay, thank you, Dr. Pradeep, and over to the organizing committee.
Thank you, sir. We will start with the next session now on the applications of GIS in public health. For today's session, we have chairpersons Dr. Arun Kumar Agarwal. He is professor in community medicine and School of Public Health, PGI Chandigarh. Sir is the president of Association of Health Systems Analysis.
We are gathered here for the session of application in GIS in public health. We have our speaker, Dr. S. Srinivasa Rao, and our chairpersons, Dr. Arun K.R. Agarwal and Dr. Arun Sharma. Arun Agarwal, sir, is founder president of EHSAS, Association for Health System Analysis and Strengthening.
You can cut down on introduction. हमारी introduction हम कर देंगे, आप इसको छोड़ दो, 1 मिनट बचेगा आपका, ठीक है? तो
like Dr. Arun sir to introduce our speaker, Dr.
हाँ ठीक है, थैंक यू वेरी मच। चूंकि लेट हो रहे हैं तो इसलिए हम अपना 40 नहीं पढ़ेंगे। इतना समझ लीजिए कि डॉक्टर अरुण शर्मा जो हैं ये हमारे पहले रिसोर्स पर्सन थे। ही वाज माय फर्स्ट रिसोर्स पर्सन व्हेन आई हैड कंडक्टेड द GIS वर्कशॉप, नेशनल वर्कशॉप हियर एट चंडीगढ़, एंड आई एम हैप्पी टू सी कि डॉक्टर पंकज ने जो है हम दोनों अरुण को इकट्ठे कर दिया, एंड ड्यू टू सम ऑफिशियल कंस्ट्रेंट्स हो सकता है डॉक्टर अरुण शर्मा किसी समय ज्वाइन कर लें, अभी वो ही मस्ट बी गेटिंग फ्री इन सम टाइम, बट ही हैड आस्क्ड मी टू रिप्रेजेंट हिम, so the audience can consider that Dr. Arun Sharma is in me, and both of us are jointly chairing this session. Friends, this session of GIS is very important because this is information system using geographical systems, and we have a very learned and experienced speaker lined up for this session. And before I introduce him, this is for the audience who is listening to the session now or who will listen to this session recorded versions later on, that GIS is not only to map some information on the geographic map of a country or globally. That is just one part of how to make maps, how to depict your information on the maps. So that is cartography. But basically the real use of GIS is that if you can find some research question and you can use the information available in the GIS domain and to answer those cross-cutting questions. For example, if there is malnutrition in the country, you want to see that whether there is any relationship of malnutrition with land use, that wherever there are dry conditions or wet conditions, or if there are forests, or if there are rivers, or if there is flooding, is there any relationship of such things with malnutrition rates? Okay, people have used it in malaria, that wherever there is water accumulation bodies, if there is more of malaria cases in those areas, they can map then the water bodies and then predict that malaria is there. So to have it means that there are two important questions for GIS. One is that what is this technology and how to use this technology, and second part is how to ask good questions that can be asked through GIS. For this we have Dr. S. Srinivasa Rao, as told. He is General Manager, RRSC West and NRSC Jodhpur. I was looking at his brief biodata. It's really very impressive that he is a civil engineer by his qualification, and then later he mastered in geoengineering, and then he did his PhD also in the same field and has a lot of experience. And he is in very important positions in this regard. Member secretary of, he is currently associate project director, ISRO. ISRO is very important body who is dealing with all the GIS data through satellites, and he is member secretary NNRMS Standing Committee on Cartography and Mapping. Cartography is the science of making maps, etc. And he is the deputy project director NDEM project. He is project director SISDP EPRIS project. We might not be knowing the full name of these projects, but all these are related with the spatial technologies and land resource use and all that. 30 years of experience in geospatial technology, utilization of natural resource management. You see, it is here, I think the interface with the health people might be, if during his talk, he can focus on that how natural use management resources or the information which is available in GIS domain can be used to answer some of the health related questions. And he has been awarded for India WRIS project and Carto DM project and SCSDP project. So he's award winner in this, and he's specialized in design and development of Indian state plane coordinate systems. So these coordinate systems are very important for the GIS technology. Development of land information system using higher resolution satellite data, survey, resurvey of cadastral maps and large-scale satellite data product generation and thematic mapping and use of spatial technology for decentralized planning activities. So we have friends, very highly experienced and learned speaker with us. And over to you, sir. I mean, with the request that I understand from this experience that your work in health field is probably less, but if you can, why in your talk, if you can somehow relate some of the thematic maps or the experience which you have, that how that can be used in health, that would be a great feast for us. Thank you, sir. Over to you, Dr. Srinivasa Rao.
Thank you, sir. I sincerely thank Dr. Arun Kumar Agarwal, sir, and Dr. Arun Sharma ji also, who is going to join very soon. I would like to switch on my presentation if they remove the other presentation.
Yes, sir, please share your presentation.
Sir, are you able to see my presentation, sir?
Perfect.
Okay, sir. So kind of you, sir. How much time I have, sir? Initially, I was given 45 minutes. Accordingly, I would like to adjust.
I think you can adjust in 30 minutes.
Oh, good, sir. Good. Yes, sir. Sir, geospatial technology for public health over a period of time, it has evolved and it is going to play a major role. Initially, I would like to sincerely acknowledge and thank to in addition to the chairman and co-chair, Dr. Arun Sharma ji and Dr. Arun Kumar Agarwal ji, Director AIMS Jodhpur. We have a good association with AIMS Jodhpur, Director NRC, my director, Director CBHS, Central Bureau of Health Intelligence, where we have carried out a national project, and various my Chief General Manager, and my colleagues and Dean, faculty, and Dr. Giribabu, Dr. Gaurav, and other people, sir. This is maybe a combined presentation from various scientists from ISRO. You see, sir, when we say the geospatial technology, first thing that comes to our mind is the ISRO. Okay, that means ISRO for last 3 decades, I can say, done extensive work on this one. Basically, ISRO is working on 4 verticals: space transportation, infrastructure, and applications. And I belong to the application family. And even this even space applications also, we are working mostly on 4 pillars. One is the socio-economic security, disaster risk reduction, governance related, where evidence-based planning, other things are happening, and sustainable developmental goals and other things. So when you say socio-economic security, side, food security, water security, energy security, where satellite data is going to play a major role. Health also became a very hot topic. And for last, I can say 1 or 2 decades, we are doing extensive work on this one. And when you say geospatial technology broadly, what it covers, that basically discipline of data collection, storing, processing, delivery, and extract some information and put it in a spatial domain that may be there. And basically it involves the data collection and relationship between geographic and other factors. Those are the things. And majorly, when I say the data, means one is the natural resource data, climate data, and other data sets, as well as the health data also very important. So basically, when you say satellite data, what are the natural resources? Because of the climate, natural resources also playing a major role in the public health. Maybe you see the agriculture related or fisheries related, even that we have a number of satellite data starting from which is suitable to 250,000 scale to up to the 1,000 or 2,000 scales, where major irrigation infrastructure like canal networks, other things also can be developed. And NR census every year is similar to the demography census where they are doing the 10 years. So we also do natural resources census every year. Okay, particularly land use, soil, geomorphology, wetland, land degradation, snow and glaciers, and other things. Similarly, we also do a lot of forestry related and snow and glaciers and the decentralized planning. The technology has gone up to the panchayat level for planning. So what are the major functions of panchayat raj issues, how the health is going to play a major role. Similarly, National Urban Information System, where in which we are using the very high resolution satellite data, where in which each household can be mapped. Now the technology initial from satellite data, it went to the aerial, now it went to the drone technology where 1:500 to 1:1000 scale mapping can be done. So there is a lot of sources are available for mapping applications. Now, over a period of time, the last 3 decades, sir, a lot of data has been acquired, processed, and various thematic resources have been generated. And Bhuvan is one portal, I can say Government of India's portal, which is being hosted by Department of Space. We have huge data sets starting from the satellite data, that is also multi-plot and multi-sensor data, maps, as I mentioned, thematic maps get generated over a period of time. And this portal facilitates free download of data, or satellite data you can download, thematic data you can download, and real-time disaster services. That is very important. How this space technology plays a major role in disaster preparedness, or when it happened during the how we are going to react to the situation, various applications, and apps for crowdsourcing. The technology has now become, now the data collection, now it has came to the hands of the each individual. From initially maybe data collection may be done by the concerned department, concerned officials. Now the crowdsourcing has come. So information is coming from various sources, multiple sources are there. So Bhuvan portal is one thing where all can visit the portal, where you can have a lot of data sets related to the natural resources and disaster and other things. As I mentioned, the health infrastructure is also plays a major, because we are talking about the public health. A number of times the data has been geotagged by various departments of Ministry of Health and Family Welfare. Okay, but for the first time, Ministry of Health and Family Welfare initiated a national health resources repository. I can say this is the first national registry to support Ayushman Bharat program has happened. Okay, and in other words, the census of health establishments in India has been initiated by the ministry 4 years back, and this phase has been over. Now almost 1 million data sets have been collected. What are they? How we are going to explain. Second one, this is the unique facility number to which a health facility has been given. As I mentioned, 1 million. We went to this coding also has been done systematically from country to state to district, sub-district, or panchayat, or village. Within the village also street maps are there, what we call the enumeration blocks. Within that street map, what are the, how many facilities are there, unique number has been given. We have used the advanced intelligence analytics for evidence-based decision planning is going to be done. And comprehensive profiling for public and private health facilities has been done. As I mentioned, this is the census operations. It includes both the government and the private, public as well as the private has been done. And the ISRO's role is technology platform development for data collection, data visualization, data archival, and dissemination. So this data has been collected on various forms. I think for the ministry has designed some 10 forms they have designed. One is the line listing form, and similarly sub-centers, primary health centers, community health centers, all these government machinery, private hospitals, medical college, clinical hospitals, diagnostic labs, blood banks, pharmacy shops, which is all pharmacy shops in government in India has been geotagged, and a lot of attribute information has been collected, including the doctors also. When I say the information, what is that information we are during the census that have been captured? What is the physical location in the photograph, and the basic details of that particular health establishment, like a government or private, whether it is central government or state government or profit or non-profit, like that, and physical infrastructure, building ownership or dedicated rooms and other things. What are the services offered or facilities and equipment available, medicine and allied or surgery related, and the human resources that are available, how many doctors, paramedical staff, and all the numbers have been captured, and other support services have been done. So, and what are the support the each health establishments is doing to various health programs, and what are the technology that is available for data collection and sharing with the public. Those are also being collected. If you see the huge data set like attributes, if you see the sub-division hospital, district hospitals, around 1,132 attributes. Even if you go to a medical college, around approximately 1,478 attributes have been captured. That means it's a huge data. Okay, even if you want to do AIIMS Jodhpur, one institution, it may take 1 month time. So that is the depth of the information that has been captured during this census of health establishments, started with the Ministry of Health and Family Welfare, where ISRO has provided the technological support. And when you say how the data has been collected using the GPS, when mobile application has been developed, and they use the tab and where the GPS locations have been captured, and they viewed the street maps also, which are available in India, approximately 23 lakhs. That is the thing. And we also developed a portal called Bhuvan NHRR, National Health Resources Repository Portal, where people can visualize this portal, visit the portal, and see all the data sets that are available in the country. And if you see the visualization, we can go at the country level, approximately 1 million health establishments. When you go to the state level, district level, sub-district level, and on the bottom right, you are seeing the village level. Even if you click one health establishment, so you can see basic details, photographs, and a unique code has also been generated. And this is only a few snapshots. Okay, but as I mentioned, data depending upon the facility type, very detailed information is available. And for quick understanding, visualization of database, various dashboards also have been developed, wherein which it will consist of the tables and graphical information. For example, I can say the line listing dashboard. We can see the sunburst chart from country to the last one is single diagram from country, state to they can come down and see the thing. And similarly, if you see the doctor's dashboard also, and what are this dashboard consists the type of registration, qualification of each doctor, specialization of the doctor, date of birth, name, word, etc. Those are also being developed that are available in this portal. What is the, if I see summary of this data sets that has been captured, as I mentioned, approximately 10 lakh, more than 10 lakh establishments have been done, and 33 lakh health workforce is available, and 7 lakh doctors are there. And out of this 1 million health facilities, 2.1 lakh government health facilities have been, census operations have been carried out, and 8 lakh private health facilities have been captured, and 3.6 lakh premises comprise of 45% of the private facilities. Pharmacies are playing a major role. And this has been covered approximately 6 lakh villages, except some West Bengal, some states which have not cooperated. And the rural urban facility, if you see the rural India is mostly the facilities are population, 60% population rural area, but the medical facilities are less than 40%. Okay. Similarly, the healthcare facilities that are available at the category wise I have mentioned here, and the urban rural disparity is clearly coming out. So the facilities more population rural area and more healthy facilities in urban areas, their percentage is starting from PHC to the total things have been captured here. And during the COVID-19, this database has been extensively used by the ministry, like a number of health establishments having 10 or more beds for preparedness estimation of the COVID-19 outbreak, and health establishments having facilities like ventilators or centralized oxygen supply relevant for dealing with the COVID-19 patients has been taken from this particular project. And the health establishments having the critical care units are also captured from this particular project output. And what are the various analysis the chairman has nicely mentioned? One is if you see the left-hand side, where these are all the, if you see a health establishment, that is the green dots are indicating. But if you click at a particular location, we can give some distance threshold. What are the various hospitals surrounding me are available within 1 kilometer, 5 kilometer radius? All those facilities will come. Similarly, if I take the right-hand side diagram, if I click one particular health establishments, what are the villages this health establishment is catering? That means what is the watershed area of that particular health establishments? Both ways we can do, from a location to the health establishment, or for given a health establishments, how many villages it is covering, how many population it is covering, can do the various analysis. See, when census, we say it is only one-time job, but the health establishments, the facilities are increasing, new facilities are coming, existing facilities be upgrading. So we also developed a technology for upgradation of this data updation module. So how to do the technological point of view, what is the unique link? That means mobile number is taken as the key parameter. Well, through mobile number, we can enter the thing, and with that mobile number, what are the health establishments who are linked? Then once you identify your health establishments, you can, whatever the new facilities that have come, you can update the data. If it is a new one, you can give all the basic line listing details. So the mechanism is available. Very soon this is going to be in operation so that the data can be made available to the public. Similarly, what are the uses of this data? Because only maybe more than 100 crores has been spent by government of India. What are the various? This is extensively using by the the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, our national digital health mission, which has been initiated recently in the union territories. For that also data has been captured from here. And the COVID-19 response, this has been extensively used. And for various planning activities, so particularly Niti Ayog's aspiration districts, they have used. So many users are coming to
What happened?
So I think you got disconnected. You can reshare and restart.
I got disconnected or the Dr. Srinivasa?
Dr. Srinivasa, I believe.
You have to talk to him on phone. Is somebody talking to him on phone?
Yes, sir, we are contacting him. He is about to share and start.
चलिए जब तक वो ज्वाइन करते हैं तब तक आई मीन really जो whatever information he has given is really very useful. I tell you all the listeners that it is not very difficult to learn this technology. I mean there are 3 softwares which are available. If you are very comfortable in writing programs and you know R, so now this GIS can be used in R, and we have experts. Dr. Biju from Sri Chitra, he is expert in R and he teaches GIS in R. And but if you can afford and you can purchase some software, then ISRI has ArcGIS software which cost 4-5 lakhs. 4-5 lakhs.
Good afternoon, sir. One second, I come back.
Yeah, please.
So sorry for the disturbance.
No problem.
Okay.
So this is the technology. It has the other side also. But I was using this spare time to inform them about GIS in the meantime. So not much waste of time. Over to you, sir. What happened? Yeah, please.
Sir, are you able to hear me, sir?
Yes.
Okay.
Please share your screen.
Now, sir?
Your screen is not visible. You are audible. I think फिर से again log out हो गया शायद. Yes, yes. Now screen has come.
Okay, sir. Sorry for disturbance, sir.
No problem, sir. No problem.
Okay.
That is why we are still developing country.
Yeah. It is 10 steps forward, 1 step backward. Some policies, because we have NKN, sir, it is 100 Mbps. Because of some data security policies that is not allowed. So through dongle, I'm trying to connect to you. Sorry. Okay. And similarly, sir, now as I mentioned, now each Panchayat Raj, last week Panchayat Raj department also came forward how you can utilize this particular database where we are going to develop a health GS at Gram Panchayat level, addressing the evidence-based planning and the universal health coverage. By utilizing this particular database, we are going to do improved efficiency, identifying the unserved areas or overlapping areas, and equity addressing geographic inequality, and what are the disease trends that is going to come? Are they mapping a patterns of incidences, prevalence, and spread modeling, and the vulnerability context? On these aspects, we are going to work with the Ministry of Panchayat Raj institutions. Then we have the planet Earth health as impact on health, human health. That means so far we are discussing about the individual patient and other things. But what about the health of the Earth? Though the public health has a direct relationship with the health of the planet. So that means what is the impact of the climate change induced impact on the public health, or what are the natural resources, natural disasters, flood, cyclones, forest fire, and other things. Quality of air is having the major role, particularly in urban areas, Delhi and surrounding areas. This air pollution, water pollution is going to play a major role. So then we are doing the monitoring of outbreak of forecast of diseases. Telemedicine, one is the initial flagship program of the ISRO that has been implemented in various corners of this country, sir. And some of the spin-off benefits that are come, what we are doing, the technological development for artificial limb or prosthetic knee joint and artificial denture material. What you can say this is some of the byproducts from the ISRO's development. If you say the climate change, as you know, because of this increase in greenhouse gases, the carpet, the atmosphere carpet, is the thickness is increasing. Because of that one, so the outgoing radiation is reducing. So in that way, most of the radiation is reflected back to the Earth's surface. So because of that, the temperature is increasing. So what is the impact of the changes in temperature? Particularly one of the direct impact is the impact of thermal stress, or if you have the death, injury, in floods and storms will be there, or indirectly through changes in the range of disease vectors, as mosquitoes or waterborne pathogens or water quality and other things. And so therefore now climate change is therefore a newer challenge to ongoing efforts to protect human health. So where satellite technology, space technology playing a major role. For example, you see how when the satellite observations, we get the validated data, then we process and generate some services like scientific, strategic, social, commercial things. And if you see that the health of the Earth can be done with the meteorological parameters, number of satellite sensors are there, clouds, what is the water bearing clouds, distribution, other things, precipitation, how much rainfall is there, measuring the precipitation, measuring the temperature and albedo, and aerosol optical depth and other things, and the temperature humidity profiles also being captured through various sensors of the from satellites from different countries. So in this regard also, sir, ISRO has done a pioneering work. We have developed a lot of portals where which the terrestrial product, ocean products, atmosphere products, model derivative products, and cryosphere products have been generated. And routinely every day we are generating, and they are made available through Bhuvan NICES portal. So these data sets also can be freely downloaded and available to the users. So the one is what is the health impact of the health effects of the extreme temperature? One is the anticipated greater frequency and severity of heat waves, which is going to come. Then very old and young and the frail people are the most susceptible. And one thing is now a hot planet is bad for human health. So monitoring the health of the planet is an imperative, and the satellite technology, particularly geospatial technology, plays a major role. And ISRO is continuously monitoring this one. Second one, the extreme climates like increased cardiac or respiratory disorders may come, or epidemics of malaria, diarrhea, dengue fever, other things are also anticipated. And those are also even mental health, extreme temperatures also having some mental health, depression, post-traumatic stress disasters. Those are also have been identified by some of the well-known doctors across the globe. And we also developed, as I mentioned, in particular in Telangana state, sir, we are providing services particularly during the summer, how the heat is going to be there, when the maximum heat is going to come, what is the temperature, what is the location, and they are doing a lot of this information is being given locally, and the state government is propagating. They are taking some preventive measures, and the deaths that are happening are drastically reduced because of the services being rendered by ISRO on the hot weather information to the various state governments. Similarly, the air quality plays a major role. The primary carbon monoxide, and nitrogen oxide, or nitrous oxide, and various things. Then the secondary information, the health, particularly this ozone, if you say the atmosphere, the stratosphere ozone is a good one, where it is going to prevent the ultraviolet radiation. But the bad zone, this is the troposphere or the ground-based ozone, which is basically coming out because of the forest fires or industrial pollution or vehicular pollution. This is having a very direct impact on the public health. So the major 5 air pollutants, we can say carbon monoxide, which is produced when carbon does not burn in fossil fuels, present in vehicle exhaust, that is the one major thing. And the impact is the deprives body of oxygen, causing headaches, fatigue, and impaired vision. Similarly, sulfur dioxide, what is the source, what is the impact of that one? These are all I have captured because of the passage of time. I'm not going in detail. So these are the 5 things. Then the satellite retrieval of particulate matter, 2.5 meter, what is the matter available in the atmosphere that can be really modeled. And these are the map indicating the distribution of the particulate matter across the country. Okay, whereas every half an hour, this product can be generated. Similarly, air pollution, that is all coming from the dust storms that are coming from the Arabian country or Arabian Sea or the Gulf countries and Arabian Sea, and how it is moving. So the air pollution also, here we are moving the dust storm reaching over Gujarat through Arabian Sea. You can see that is particularly from the Gulf countries. Using the INSAT 3, we can clearly model. Here at this center also, we are developing a system for a dust storm warning system. When dust storm is going to come, how it is going to move over a period of time, next to 24 hours or 48 hours, so using the meteorological parameters we are modeling. So this a lot of space technology plays a major role in monitoring of the dust storms and what is its impact and migration. Similarly, sir, the COVID is one way it is very bad. A lot of human lives we have lost. But one blessing in disguise is if you want to measure this aerosol optical depth during the pre-COVID time, during the COVID when lockdown happened, there is a lot of reduction in aerosol optical depth. That means atmosphere, the particles, the particulate matter has drastically reduced, and we can clearly see what is the difference between before the lockdown and during the lockdown. Lot of improvement in the air quality has happened. Similarly, the particulate matter 2.5 meter, how the distribution before the lockdown and during the lockdown, there is also a lot of positive impact, where it's a 30 to 40% reduction in particulate matter of 2.5 and PM10 has happened. So these PM2.5, PM10, you can directly measure using the using the various models from the satellite data. So even water scarcity also has a lot of things, and I'll quickly go through other slides, sir. One is the impact assessment of Swachh Bharat mission. As you are aware, sir, because of this, the toilets, the government of India has given a lot of emphasis on construction of the toilets at home and community toilets. Over a period of time, approximately some 10 crore or 100 million toilets have been constructed. And because of this, during 2016 and 17 and 17, 18, there is a significant decline in the summer peak of the ADD, acute diarrheal diseases, due to the helminths, in particularly in the summer peak. And we have the monsoon peak, particularly in June, due to the virus and bacteria. So we mapped these two, increase in number of the toilet construction and people are using those toilets, and the decrease in the ADD outbreaks. So this study gives an importance, sir. This has been extensively used by the Honorable Finance Minister of Government of India while presenting the Economic Survey 2018-19. And this has also become a backbone for projecting to the next scheme. And similarly, sir, when I say 10 crore toilets have been constructed, is really 10 crores have been constructed or not? So because each toilet that has been constructed has been geotagged. Their photograph is there, where it is there. It is only one village, this image we are seeing, where each household you are seeing. So wherever the green dot is there, that is indicating the where toilets have been constructed. So last 1 decade, I can say, sir, evidence-based planning, the proof of concept, or the what has been constructed on the ground. That particular asset has been captured, the details are available, and Government of India, various state governments are using this Bhuvan portal and using this database, and the transparency of development is happening and it is available. Over a period of time, sir, in Indian season, the serial tropical cyclones are happening. Mostly the tropical cyclones are happening in the area, the Bay of Bengal. For last 2 years, more number of cyclones are also, storms are coming through Arabian Sea also. So when the cyclones are there, where the floods are coming, where the flood area, and what are the diseases that can outbreak because of the flooded area, we can easily map, and this information can play a major role by the public health departments to monitoring and managing those type of outbreaks. Similarly, sir, you have nicely mentioned about the malaria and Japanese encephalitis and filariasis. These are the important vector-borne diseases affecting the northeastern states. We have one center at the Northeastern Space Application Center. They are using this particular information, and they have prepared an early warning system for Japanese encephalitis in Assam, particularly Dibrugarh, Tinsukia, and those 3 districts, integrating multiple layers of information with the spatial analysis for identifying the risk zone prone areas. As I mentioned, the water bodies, what is the various land use, land cover types are there, where the stagnated water are there, and using various digital elevation model, using the various thematic information and collating with these diseases, we can really model where it is map we can do, and we can model things where it is going to come. It is almost in an operational mode. These projects are being done, sir. As I mentioned, the Bhuvan also supporting a lot of health related projects. Okay, particularly across the various state governments and the central government departments, particularly during the COVID period, where the tracking of how this disease is spreading, where are the hotspots, what are the buffers and the villages, how many villages covered with the hotspots, are the where vegetable markets are there during the period, people can easily approach them, where the food, some government outlets are there, where home isolation is there. So those information has been captured, and through Bhuvan portal, we also did service to the various departments. Similarly, sir, in addition to this one, with the various ministries of Government of India, particularly the health departments like Ayush department, they have a lot of herbal gardens. So around 1,880 herbal gardens have been uploaded. We have developed a technology, and the ministry people have captured this information, geotagged, photograph, and various information has been captured. So nowadays, whatever the information is available that has been brought into the GIS domain. So geospatial technology, I can say a revolution has happened. Almost Honorable Prime Minister has he chaired a one-day workshop where 80 departments of Government of India have participated, and all the departments are implemented. Most of the data has come into the GIS domain. Health department is also one thing where they are going to play the information is available. Now the term is you need not generate information. Information is available. We have to utilize. We have to think of how we are going to use this particular database. Similarly, sir, one case study I would like to mention here. Only a few slides are left, sir. One is the study based on the patient. What is the fluoride content in groundwater and infant health? How these two are related, as you are mentioning. Here we have a map. What is the fluoride content? That is in 3 categories: less than 1 ppm, 1 to 1.5 ppm, and more than 1.5 ppm. And we have taken the infant weight of this pregnant woman and after delivery, and what is the weight, the relationship between the infant weight versus with the content of the fluoride. We can see wherever the fluoride content is high, the infant weight is very, very less. So that means how both spatially, how these two are related, we are able to map. And many times we want to prepare this particular map, we need a lot of ground truth information. But now using this the patient, the pregnant woman or health data, we can do reverse also. How we can improve these maps also. That means correlating the natural resources phenomena, correlating the disease pattern or the health pattern of individuals, we can derive a lot of information. Other case studies are here in Jodhpur also. We have some fires where are they happening, and we mapped all those fires in the last 10 years. We can clearly see 2 peaks are happening. One is the industrial in hot summer areas where industries are there, where number of fire accidents are happening, and particularly where during the Diwali period, where in old city the fires are happening. So that means we can see the one is the industrial related and the climate, the festival related, cultural related, as well as the industry related. So this way we can identify where the hospitals are there, which are providing the services to treat the burnt patients are also can be worked out, and it can be identified, or planning for those facilities can be done using this data. Sir, geospatial technology for disease surveillance is happening globally, sir. One is the disease mapping is one thing, and disease spread and prevention, and disease modeling, and spatio-temporal visualization of various diseases, and the health resource allocation. On these 5 aspects, a lot of things are there. The government of India also has a lot of data sets, sir. ISRO is also supporting the health ministries. Now we are in the advanced stage of using this particular data. Now we can clearly see, sir, our GIS, geospatial technology, starting itself is because of this health sector. In 1854, Dr. John Snow connected location and illness with his history of making maps of London cholera map. So the origin is the health sector. Okay. So health is the first department. We can see here that if disease can travel faster, how the this Zika virus, Ebola virus from one continent to other continent, how we has transmitted, that we can clearly map it, sir. If disease can travel faster, information has to travel even more faster. Last few slides, sir, we have the COVID-19. Various departments have come up with national initiatives. So many dashboards have come, so many portals have come, where in which all the just technology extensively used, each state-wise, district-wise, even village-wise also. Some of the things during the COVID time, this have come up. And now information, now the citizen science is playing a major role, sir. Particularly how information has to be captured. One is what is citizen science is the public involvement, and the volunteers who are coming volunteer, because the most around 70 to 80% people are having the smartphones. So the information collection, transmission become more easy. So now crowdsourcing is the order of the day. So information is coming from various sources in graphs, in photographs, or some textual matter, some numbers are coming. The machine learning, artificial intelligence, the big data is also playing a major role. How to this information coming from various types, various sources, how to archive, how to process, how to derive information. So data science also plays a major role, sir, where it is helping the geospatial technology, particularly in the health sector. And this Arogya Setu app, sir, that is how it involves the mobile application. It has each coordinate, patient information is available. And once we know one person is there in surrounding areas. So here the man is represented by a mobile. So we can, by tracking the mobiles, we are indirectly tracking the man, or indirectly tracking the one patient and with whom he has interacted, other things. So the contact tracing and all other things, this is going to play a major role. I think, sir, now I think the government of India also extensively using this technology. I can say we are also in an advanced kind of status. And rerouting and internetworking, particularly if one area is under the containment zone, what are the other alternative routes and other things? This is the primitive use of the geospatial technology, identifying the alternative routes using the various networking tools. Similarly, sir, department also, space also supported telemedicine program where the ground-based network facilities are poor. Nowadays, this ground-based networking has increased a lot. Okay, and still we are supporting the many islands and other things where telemedicine facilities are there, where cares are there, and geo-tracking of health resources. Not only the central government program, various state governments also come forward. And the last 2-3 slides are ultimately, we are all working for the Sustainable Development Goal 3, ensuring health, lives, and promote well-being for at all ages, particularly thinking of the end of the epidemics of the AIDS, TB, malaria, and other things. Now, achieving the universal health coverage. So, where this these targets and the space technology plays a major role in providing the inputs to this to achieve this Sustainable Developmental Goal objectives. Similar, sir, and last slide, sir, the exploring new territories. India is going to launch very soon Indian human space flight program. Maybe next year it is going to be done. And now this also has a lot of space travel challenges for the doctors community to you, particularly when the astronauts are facing the microgravity. It has a lot of psychological factors and physiological factors are going to affect, and the space radiation and life support system, how it is going to be done. So what is the loss of blood, or how the astronauts' health is going to change from this the gravity at the Earth surface and the space around 200 kilometers height, how it is going to impact. It's a challenge to all the doctors and to support the ISRO also in this endeavor, sir. With this, I stop my conclude my presentation, sir. If any questions are there, I am very happy.
Thank you, sir. Thank you, Dr. Srinivasa. Let us all give him a big clap for such a wonderful session. Dr. Srinivasa, I must tell you that when I gave my brief, I was my prediction was that your presentation would be 95% non-health and 5% health, but it was entirely reversed. It was 100% health. So thank you very much for such a nice presentation. And you have informed us rather, I mean, all of us who are learning GIS, one of the question is that from where you will get the shape files. And we were told that all these have to be purchased from Census of India or this and that. These are not freely available. But you have informed and given us such a nice portals where a lot of data is now available that can be downloaded and that can be used by the researchers who are interested in this type of technology. And we really thank you for such an excellent presentation. And this is for the audience. I mean, you must not Dr. Srinivasa's email in your email account and make a rapport with him. If you are interested to work in this field, you might be having many questions, queries, which we may not be able to take at this point of time because organizers are running behind the schedule. But I am sure that you will maintain your contact with him, and I will personally like to maintain contact with you, Dr. Srinivasa, because I have started working in this field, and a lot of inputs from your side and collaboration with you might be useful to take this science forward in the domain of public health experts. So if Dr. Arun Sharma has joined, if no, then we conclude this session with lot of thanks, and that a lot of useful information has been shared. It was like a GIS storm for health sector. Thank you very much. Thank you, sir.
But I would like to thank the organizations. I would like to thank especially my colleague, sir, Dr. Giribabu. He is the person behind realizing this presentation. Sir.
Not only this presentation, probably he helped to come up from the breakdown also.
Yeah, that is more important. Yes. Yes.
Krishan Bhagwan, if it is there on the ground, then Arjun will not face difficulty.
Yeah, rightly fine.
Thank you. Thank you so much. Thank you. Okay. Bye-bye.
Thank you, sir.
ठीक है जी. Okay. Bye-bye.
Okay, sir.
We break for lunch. We will restart with the next session at 2 p.m. Thank you.
Good afternoon, everybody. Thanks for joining. We will be starting at 2 p.m. Thank you.
Good afternoon, everyone. I, Dr. Rupali Gupta, on behalf of Eficon team and AIMS Jodhpur, would like to welcome you all to the session on water, sanitation, and hygiene or WASH. I welcome Dr. Puneet Mishra, who is one of the chairpersons for the current session. Dr. Puneet was the president. Dr. Puneet is a professor at Center for Community Medicine, All India Institute of Medical Sciences, New Delhi. He was the president of Indian Association of Preventive and Social Medicine from 2013 to 2014. His areas of interest include non-communicable diseases, lifestyle interventions, yoga, meditation, spirituality, and holistic health. During COVID-19, he was a member of Central Team, GNCT, and Central RRT for Delhi. He has over 25 years of experience and has published more than 100 papers. Welcome, sir.
Thank you, Rupali.
I, Dr. Zeba Bano, would like to welcome and introduce the next chairperson for the session on WASH, Dr. Syed Zahiruddin Qazi. He is the Director R&D Professor of Community Medicine at Datta Meg Institute of Medical Sciences. He is also the adjunct faculty at Georgia Southern University, USA. He has received the prestigious Australian Leadership Fellowship Award. His areas of interest include early childhood development and maternal and child health. He has published over 100 articles in renowned journals. Welcome, sir.
Thank you. Thank you, Rupali.
Now, I would humbly request Dr. Puneet Mishra to welcome and introduce our first speaker, Dr. Sandul Yasubant.
Thank you, Dr. Rupali, and all the audience, and welcome to this important session on the WASH. And we have three speakers today, very eminent speakers. Our first speaker is Dr. Sandul Yasubant, who is Technical Officer Research at Indian Institute of Public Health, Gandhinagar. And he has done his MPS from Sri Ramchandra Medical College and Research Institute, then PhD in Public Health from University of Bonn. And he is adjunct faculty at Datta Meghe Institute of Medical Sciences. And he has published more than 50 peer-reviewed international journals. His area of interest includes health policy and system research, One Health, disease prevention and control, environmental and occupational health. With this short introduction, I would like to invite Dr. Sandul Yasubant to present his work today, and his topic is going to be prioritizing WASH assessment for HCS, practical reflections from a multi-level, multi-site study. So, Dr. Yasubant. Dr. Yasubant there? Dr. Yasubant?
Good afternoon to everyone. I am Dr. Yasubant, working as a Technical Officer Research and in Institute of Public Health.
Sir, he has shared a recorded video. I will be starting it right now.
Great, great.
Dr. Yashovant, working as a technical officer research and in Institute of Public Health, Gandhinagar, and also an adjunct faculty at the Tamega Institute of Medical Science, would like you present a topic called prioritizing the water sanitation and hygiene assessment in healthcare facilities, a practical reflections from a multi-level, multi-site study. The scope of presentation will not be limited to comparing the global and Indian scenario and why we should bother about the WASH specifically in HCFs and what are some challenges of while doing this WASH assessment and why we are promoting the prioritizing the WASH and which component need to be prioritized under WASH in HCFs. If so, then what could be the indicators and which components some are more essential and we should not miss out of those from the assessment, and of course, the advantages of it. One of the global statistics shows that 1.8 billion people lack basic water services in healthcare facilities. Although we do have a large disparity among to the basic water services to the basic sanitation services or the waste management services, but one should not forget about that WASH in HCFs is the provision of water, sanitation, the waste management, hygiene and environmental cleanliness of infrastructure and services across all part of a facility. When we say across all part of a facility, it's nothing but to improve the IPC behavior. It should not be restricted only to hand washing, but also to the environmental cleanliness, let's say the surfaces, the floors of laundry, cooking or waiting areas. So that the WASH in HCFs is much important for IPC improvement. When we switch our focus from the global scenarios to the Indian context, and this is the figure that shows that the country progresses in improving the IPC to control the antimicrobial resistance, one of the global agenda, where the India stands in the category of P, which says that a national IPC program or operational plan is available for the WASH standard, but are not fully implemented. That means we are facing challenges to implementation or executing those WASH standards. Given said that there are multiple benefits of WASH, let's say one estimation shows that 15% of patients in LMIC develop one or more infection during their hospital stay. That means we should conduct the WASH assessment to minimize or prevent those proportion of infections. So similarly, it's not only about the tackle antimicrobial resistance, but also to promote the dignity of vulnerable populations, although we do have a lot of benefits or advantages that why one should focus on what's in HCFs. Some of initiatives that we deliberated and started working on was since 8-9 years back, where we started only with assessing the labor room with the multi-country study, India and Bangladesh. But the issue remained that why we should focus only to a specific area of healthcare facility. It says that all parts of healthcare facility need to be focused. So we changed our switch to the assessing 3 different states with 3 different health indicators, and we scoped from beyond the labor room to the across all part of the healthcare facility. And that was not the end of story. When we say we do assessment, but can we observe some kind of impact out of it? Then of course there need to be some intervention or the packages that grossly improves the WASH, let's say the infrastructure interventions or attitude and behavior promotions. So we started to work on the behavioral promotion towards the WASH. Again, that's not the end of the story, where we shifted to the Assam, one of the state, assessing that how much the cost you have for the WASH improvement, and is that correlated to the impact that we are receiving at the end of the assessment. And that led us to derive and saying that we need some kind of prioritization of WASH in HCFs. That means either the facility do have some of cost for it or not, what is the local context, what is the need of that healthcare facility, or what should be the criteria or the strategies of WAS that need to be focused at the beginning or at the top priority. Although there are different types of system tools available, we used one of the system tools saying that prioritizing the WAS strategies as per the local needs should be the ultimate goal of any assessment. Even said that, let me take you through the one of the example of one of our assessment that although we do understand the water, sanitation and hygiene should have different components. So let's say some are observed or some are reported, focusing on to the one component now, the water. The functional water point is one of the observed indicator that need to be collected as a part of WAS assessment. But what is the prioritizing of indicating the functional water point for my healthcare facility? So that's most important to understand here. So we say that need to be ranked, let's say, as compared to the type of water sources or water interruption. What is the priority or the rank that need to be given to the functional water point? So let's say I say it's my top priority, it's the top agenda that I should look into it. So once you decide that, you can move ahead with collecting some of informations. Let's say the sub indicators, either what is available, the people are using it in a good state of repair or not. Once you collect the information, the background calculation of weightage and ranking indicates that the functional water point was my top priority. However, it falls into the yellow zone. That means attention required to improve the better quality. So as a WAS manager, I should take the decision that I should focus on the indicators which are into the red zone to improve into the yellow, or those indicators from the yellow to the green zone. So that is the importance of prioritizing the WAS components within the assessment. Although there are some essential components here one should not forget. Although we are focusing into the water, sanitation, hygiene, including biomedical waste management, one of the integral component is the microbiological assessment, because one of our evidence shows that visually clean is not necessarily microbiologically clean. How it indicates that, let's focus into the one of the facility 7, which has the cleanliness score of about 63.6, but same time it has highest percentage of positive samples. The microbiological contamination is also high. That means the WAS assessment should not exclude the microbiological assessment, and the WAS assessment should correlate with the microbiological findings. You can see the sum of evidence that shows that different patterns of species are also being observed and documented at different WAS components. So that means if we are missing to the microbiological assessment, the WAS assessment remained incomplete. To move ahead with the story that why prioritization is another important factor that one should understand, that the costed improvement plan or how much I should invest on WAS and what should be the impact out of it should be well understood before the assessment. Let's say this is one of the ideal practice that has been followed so far, is that we do some kind of prioritization workshops and qualitative assessment at the beginning. We try to understand what is their need. We try to understand which component of WAS need to be prioritized or strategified at the beginning, then doing the assessment or designing the package for the local context, then estimating the sources or estimating the cost, and then looking at to the end line and the assessment which shows there was an impact or there was no impact. Also grossly, the advantages we say that prioritization is much important because the WAS indicators differ from facility to facility. The rank of indicators can be changed by HCS based on their priority. Although there are like 50 essential indicators which require routine monitoring, one must focus on to the microbiological assessment also. And grossly, this weightage and ranking gives a strategic way out to the WAS managers that says that which component of WAS need to be prioritized or need to be focused at the beginning and what can be taken over to the consequent time period. So given said that, I must say acknowledge to my each and every team members who are working grossly for a decade of time on the WASH assessments. Thank you very much for your attention. Thank you.
Thank you. Yes, sir.
Yeah.
You continue.
Yeah, thank you, Dr. Swant, for nice presentation and about the indicators which are required to assess the healthcare facility, and you have finished well within time. So that's good. And what we will do is we'll take all the questions from the audience at the last, from once all the presenters are done. So our next presenter is Dr. Robert Drewelvis. And he is associate professor at London School of Hygiene and Tropical Medicine. He has done his MPH from Embry and then PhD from Department of International Health, Social and Behavioral Interventions Program from Johns Hopkins Bloomberg School of Public Health. And he has worked widely in the area of water, sanitation, and hygiene, especially with focus on health. His recent research focused on hygiene and WASH behavior change in healthcare facilities and schools in South and Southeast Asia, and also in Eastern Africa. He is co-founder and director of the COVID-19 Hygiene Hub. And of course, his area of interest includes WASH and health. Besides that, he also works in the area of infectious and tropical disease. So may I invite Dr. Robert Drewelvis for his talk. Dr. Robert, I think you are, yes.
Yes, I believe we're going to play a recorded presentation. Please
Yes,
correct
sir.
me if that's wrong. Okay, great. Thank you. Hello, my name is Robert Drewelvis. I'm with the London School of Hygiene and Tropical Medicine, and I'm going to present on our study, Improving Hygiene Along the Continuum of Care in the Perinatal Period. This was a feasibility study we conducted in partnership with the National Institutes of Public Health in Cambodia and WaterAid Cambodia. This work was funded by Australian Aid as part of the Water for Women program. Now, when we think about hygiene, we typically kind of default to the household environment and issues around enteric infection prevention. But when we think kind of more broadly, infection and specifically sepsis is responsible for about 10% of all maternal deaths and 15% of all neonatal deaths. So the systemic infection is a problem that may not be addressed by our traditional enteric-focused WASH intervention strategies. Most of these infections are acquired during birth and the immediate post-birth period, and these can be prevented through improved hygiene along this perinatal period, along this entire continuum of care. And important to note when we think about that perinatal period is that this is a period that spans multiple environments, from the healthcare facility during childbirth to different parts of the healthcare facility during postnatal care, finally to the household environment. And improving hygiene along this entire continuum of care ends up being quite difficult. We see globally that there's very low rates of compliance with hand hygiene protocol, both at facilities and in the home environment. We have systemic barriers that we need to address, such as the lack of infrastructure and equipment, or institutional norms that are not conducive to improved hygiene behaviors. And finally, we also have very few intervention models that work for low resource settings. Most of our existing interventions are targeted at high income countries and really focus on education and information. So the aims of our study were to assess the feasibility of a novel multimodal healthcare facility-based behavior change intervention to improve hand hygiene behaviors as they relate to maternal and neonatal sepsis. This was a 4-phase study. It started with both quantitative and qualitative formative work research in phases 1 and 2, leading to a participatory intervention development process in phase 3. And finally, phase 4 is culminated in a controlled before and after study. This was in 4 intervention facilities and 4 control facilities, and the intervention ran for 24 weeks. I'm going to focus most of our discussion here on the controlled before and after study. So how do we define hand hygiene during the perinatal period? So because we're spanning multiple environments, it actually requires us to think outside of just kind of our traditional norms. During childbirth, we developed a system for measuring hand hygiene during childbirth related to the WHO 5 moments approach. And for the postnatal care, both at facility and at home, we focused on kind of an adapted version of these 5 moments that are specific to the newborn care. Now, our earlier formative work really did find a number of factors that were driving hygiene behaviors in this context. So when we think about the midwives, things that really kind of enabled proper hand hygiene was that midwives already understood and knew the importance of hygiene during childbirth. There was readily available infrastructure and supplies, and they had a strong peer support network. However, things that potentially our intervention needed to overcome were relatively low risk perception. While they understood the importance of hygiene, they didn't think it was that important within this context. There was infrequent training and exposure to infection prevention and control models, and just general time and staff shortages. Now, focusing on caregivers, the other kind of main players across these environments, we did note during our formative that caregivers were very receptive and open to feedback from midwives. And they all had a very strong desire to protect the newborn. However, there was very little knowledge about the risk related to systemic infection, inaccessible or inconvenient hand washing facilities, both at home and at healthcare facilities during postnatal care. And caregivers were balancing a number of time and other caregiving responsibilities. So our final intervention, which was designed in partnership with the organization 17 Triggers, looking at delivery rooms, what we did is we integrated a number of kind of stickers or nudges within this environment to trigger hand hygiene at key moments. This was designed in participation with midwives across many of our facilities and implemented in participation with midwives. We also developed an interactive interactive training manual that midwives could listen to on their phone and engage with them over a several-hour period, really discussing the importance of hand hygiene and integrating this within the broader culture of the healthcare facility. For our postnatal care, our intervention had 2 different parts. One was really focused on changing the broader environment. I'll discuss that in just a second. But it also included kind of key messages that were delivered to kind of caregivers when they arrived at the facility to give birth. This included kind of explaining the importance of hand hygiene to new mothers, giving her a lanyard with alcohol-based hand rub that she could use while in the healthcare facility. We had a script that were given to midwives, as well as sessions for the cleaner about how to support and enable proper hand hygiene. Now, I mentioned before that the lack of accessible infrastructure was a problem, and we did address that. We built new hand washing facilities in all of the postnatal care areas. The foot of every bed had a new alcohol-based hand rub dispenser that was installed at the base of this. And we painted everything green to kind of link this all together kind of visually visually. And finally, we also had the intervention was targeted at improving things within the household level. All mothers who delivered were given this lanyard with alcohol-based hand rub that they could take to the home environment. And these small hats that were given to all of the newborns that say in Khmer, wash your hands, is a way to kind of trigger hand washing before coming into contact with the child. So I'm going to divide our results into three different things reflective of the three different environments where our intervention was focusing. The first is childbirth. And here we have to deal with the fact that this is a medical environment and hand hygiene is a bit more complex in these environments. We have to deal not only with hand washing with soap, but also clean and sterile gloves at certain points. It's also not an instantaneous environment. So we needed to consider what happens between hands being washed and when specific procedures were performed. And was there the potential that hands had been recontaminated by touching objects, touching other patients, or leaving the room? And we really looked at three key opportunities here: hand hygiene prior to vaginal examinations, prior to the start of the delivery, and prior to immediate newborn care. Now, our results here, this is kind of a rather convoluted table, but just really focus here on the percentage point difference. Across all of those three moments that we discussed, so childbirth, vaginal examinations, labor and delivery, and immediate post-newborn care, if we look across all of these, in our control facilities, adequate hand hygiene, meaning hands washed with both soap and water, and clean gloves worn, and all potential recontamination avoided, declined by about 10% in our control group and increased by 11% in our intervention group between baseline and end line. So this is about a 20 percentage point difference at the end line between these two, once we take into account kind of how things were at baseline and our end line. And our regression analysis, where we've controlled for shift and the rank of the healthcare providers, this results in an adjusted odds ratio of about 4.7. So the odds of adequate hand hygiene prior to the initiation of any of our key moments of interest was about 5 times higher in the intervention facilities. But I do think it's important to kind of look back here at this table and specifically looking at those end line numbers. In our control facilities, that meant 14% of all of these at end line, 14% of these key events were conducted with hands in adequate hand hygiene, and only 27% in our intervention facilities. So the magnitude of change here was not huge, but we do see a large significant difference. Now, focusing on postnatal care, here things are much simpler. It's really just did someone wash their hands with soap prior to contact with the newborn, and we've looked at various ways of various more specific measures of newborn contact. But overall, what we see, this is our end line results only. This is within the same controlled before and after study, but adequate hand hygiene at baseline was 0, so it can't really be included in any of our measurement models. At end line, what we do see is a very slight improvement in the intervention facilities. While we had about 2 observed moments of hand hygiene at the appropriate time in our control facilities, this was 27 in our intervention facilities. That's about 2% in the control facilities, up to 9% within our intervention facilities. So we do see about an 8 percentage point change, but in the intervention communities, facilities, that's really only up to 9%. So while we did have a measurable impact in hand hygiene in the postnatal care period, the absolute magnitude of that change was very small. And finally, at the household level, in the end, we saw improvements from 0% in the control group to 2% in the intervention group. Now, this is hand hygiene, meaning hand wash with soap and water or alcohol-based hand rub used in relation to any newborn care event. Now, the numbers here are quite small, so we really didn't even bother with a statistical analysis. We saw a small improvement, a 2 percentage point improvement, but that's up from 0. We can't really think that we really saw much of an impact here. So just in summary, our multimodal intervention that incorporated cues and nudges and a participatory training model was successful in improving maternal care during childbirth, specifically hand hygiene during maternal care. And this was a relatively modest improvement, but nevertheless, it was an improvement. The newborn care during the immediate and early postnatal care at the facility also saw modest improvements, but it was starting from such a very low baseline. We don't know kind of the level in which kind of the impact, if these levels of improvements resulted in impact. And we saw no measured intervention effect at the household level. And again, just to drive home that the absolute change was limited and the impact of this is unclear. Moving forward, we'll be revising our training and delivery model in new interventions. Rather than a one-day training, we'll be using a low-dose, high-frequency model that'll be spread out over a many-month period. And we'll also be integrating hygiene promotion and hygiene facilities into antenatal care and antenatal care delivery. Thank you very much. I look forward to any questions.
Thank you, sir.
Thank you. Thank you, Dr. Robert. And we'll take all the questions at the end of this session. And now I request my co-chair, Dr. Zahiruddin, to introduce next speaker, please.
Thank you, Dr. Mishra. Indeed, this is a very good, exciting session which is going on. And I now request Dr. Ravindra Kewal, from the Additional Professor of Environmental Health from Department of Community Medicine and School of Public Health, to discuss more on this very important topic of water and sanitation issues in North India, bridging the gaps for better health. In short, his brief profile: he is MTech from Hisar and has done BSc from Belgium. And from UK, he has done postgraduate certificate in higher education. His main interests are on air and water quality and health risk and mitigation policies for the persistent and emerging pollutants. His work, he has been a member of two associations, one IPHA and Indian Science Congress, and he has been the co-investigator for DLHS4, and his main research areas, his focus areas has been on noise pollution, tobacco diseases, indoor air pollution, water pollution, and trends of water airborne diseases. So I request Dr. Ravindra Kewal to please start on the very important, relevant topic of today's world. And thank you to the organizers. Thank you.
Good afternoon, everyone. First of all, I would like to thank all the chairperson, Professor Syed, who is handling this session, and also Dr. Professor Misra. So we have seen that there are talk about how to manage risk. First, looking at the intervention level and at the basically, you can say, user side. But we also need to identify risk basically at the population level, because we know that there is a source, there is a pathway, and there is a exposure. So we need to work accordingly our strategy, because we have a 1.4 billion population, and we know that there are, if you look at the global burden of disease, the water and sanitation could take up to 20 to 25% of the disease and death burden. This has been highlighted that these all death, either below 5 years or you can say other age group could be prevented, and we need to focus about this and water and sanitation coverage, including if we talk about MDG or SDG, they have been specifically highlighting focus for a clean water and sanitation. If we talk about in 1954, we had our first basically 5th year program where we thought about how to address the water and sanitation issue. But the concern was that we never able to attach it or link it with the health aspect. If we talk about sanitation, means sanitas means health, but we failed somewhere in terms of linking water sanitation to health. And you could see here that approximately in rural area, 66% of the do not have access to clean water. We have provided the water, but we need to ensure that the water quality is safe. If we talk about, it could be various physical, chemical or biological contaminant which are affecting. So not only in the rural location, but also in urban area, and mostly the population is economically, you can say, weaker section. So they have dual sword. First is the poverty, and second is the environmental considerations. So considering this, basically, we are sharing few studies, like in rural area, we are promoting toilet, and the houses are very much closed, and you will see that one has a toilet and the next door there could be a hand pump. So is there a water contamination from these toilet to the basically the drinking water? So we looked at and we find out that yes, on-site sanitation practices are leading to certain, you can say, risk factor for the consideration of the safety of the water. So what we did it, we make a semi-structured questionnaire, we made a site visit, and then looked at upon various consideration, means starting from water quality, water storage and handling practices, water treatment practices, and general health and sanitation status. What we observed that yes, water quality is polluted, and another thing is that majority of the household, they were using government pipe supply. Other, if we talk about, they keep separate water for domestic and other purposes, and only 2.6% of the household reported they treat water. So when we are talking about, there is a water storage practices which are, you can say, doubtfully could lead to the infectious disease. So there is a need to work upon those unsafe practices. So what we concluded there, basically the population should be made aware of cost-effective water treatment practices. And there need to be education of various technique and processes available for water treatment. And we need to focus on health promoting society through social cultural, or you can say addressing their traditional practices. Apart from this, actually, we know that on 2nd October 2014, the drive about Swachh Bharat Abhiyan reached to the rural sanitation, basically building toilets. And at that time, we were using various smartphone-based, you can say, app, and we looked at how it could affect or promote the basically uptake of the toilet building practices. What we adopted in this was basically in Punjab area is a community-led total sanitation, which was initiated by Kamal Kar from Bangladesh, and he worked upon. And then this approach was applied so that people build their toilet. So basically, you know that you take the population by purposefully, and then kind of a discussed feeling you bring, and then they demand for the, you can say, better sanitation practices. So all these things which are shown in this image, either toilet counting, reporting open defecation, evidence of toilet construction, or public awareness, watch committee, and you can say young ambassador, they were somehow linked to a WhatsApp app. And then they were making application, and all were daily making the progress in terms of making the district or a particular area ODF free. But what we noticed that the privacy of the data was concerned, because these smartphones were not belonging to those people directly, and they could also share some of the family picture or other things. So this becomes sometimes an embarrassing situation for whose personal information is being used. So we also linked with means where some gaps are there in terms of planning, monitoring, or validation, and how we can address. Briefly speaking, it provided a two-way communication for effective application of Swachh Bharat Abhiyan, you can say, or to achieve the goal, but there are some ethical use and which we could address through proper training and consideration. Another thing was that we also looked at the water usement and treatment and sanitation practices. We thought that Chandigarh would be different and how different from other part of India, but there have been relationship with the water quality, and we observed that water treatment processes, or if we talk about diarrheal cases, there is a kind of a association. So as I highlighted, basically the urban poor are more affected by the poor water quality. Also, they have less means of treatment for their facility. So despite having a water supply facility, the so-called Chandigarh is basically urban slum free, but we could observe those slums, and there is a concern for that. And that is why probably this year also we saw some cases of diarrheal outbreak in Chandigarh. And we propose that this intervention should include first at government level, means proper maintenance of the water distribution. We need to have a regular monitoring mechanism, because we or other institutions, they come at the time of crisis only, so that we ensure that safe drinking water is provided to the population. Talking about the community level, or you can say how we can go ahead, the government has provided the infrastructure, but we need to ensure its proper maintenance. Another thing is that we need to take care of the mass media, because people are not aware of various, you can say, precaution they can take. Another thing was that they were not aware, means how to get chlorine and how to disinfect their water, drinking water basically. So we need to have, we need to involve various sectors, including NGOs and other organizations, so that we achieve you can say, desired goal. And at individual level, we also need to act through promoting personal hygiene. My first colleague and second colleague who were delivering the lecture, they also highlighted this, that the treatment technology, they also need to be focused so that we have a health promoting society. So apart from this, actually in Chandigarh, we looked at the groundwater which is being supplied for drinking purpose, including for arsenic and other heavy metal, and their geographic spatial distribution was seen, and where you can say there is a dumping site, or there is a e-waste site, or waste collection site, or rural practices, the contamination was found to be related there. So like we are focusing on building, you can say, various things in terms of either toilet or something like that, we also need to focus about routine water quality in terms of identifying the chemical risk, so that population health can be ensured for their better health. Thank you.
Thank you, Dr. Ravindra Kewal. It was really interesting to listen to you. The two relevant studies, they were very relevant and very to the mark of today's topic. And the four related studies you have shown, they may be of great help to the viewers, to the listeners, and they may go back and see those articles. And the same way you talked about those young ambassadors and the applications that are being used for such technologies. They are really innovative and thought-provoking, and I thank you again to you for enlightening us with your speech and the research you have conducted. There really of great importance, and I hope the readers, the young researchers, may listen from this and learn from this, and have a good learning curve from this. Thank you very much. Thank you.
Thank you, sir.
It was really interesting. Thank you. Dr. Mishra, if we can allow if there's any questions. Dr. Pankaj, hello. Thank you.
Actually, requested, we actually started late, but get that time by cutting the lunch time. So I think now we are on time, so we can have one or two questions, or chairpersons can also have few points for discussions before we start our second session. So over to chairs again.
Yeah, so we can take one or two questions. So it's open to audience for questions, and you can raise hand, you can write in the chat box, or
I don't see any questions now in chat box.
Yeah, I know that. I would request my coordinators, my PGs, to take questions from the virtual platform. So from virtual platform, we need to get them here actually. So do we have questions in the virtual platform? Please check.
Yes, sir.
All three sessions were wonderful, and they were enlightening, and there may be a lot of learning curve for our young researchers.
Sorry, sir, we do not have any questions.
Because questions, so I would like to get this thing from Dr. Khaiwal itself, because they've got a huge work when it comes to the wash and during this COVID-19 time. So I think they've released a lot of guidelines and books on sanitation, hygiene. So is there a change after this COVID-19 is there? Because everybody is talking about hygiene, good, appropriate behaviors and all. So do you think it is an opportunity, and or do you think that people have a very short-term memory and they're going to forget all the things?
Thank you, Professor Bhardwaj. You have asked a very relevant question, and this highlight that basically we see a spike in hand hygiene and good sanitation practices, we can say. But as you also mentioned, over a period of time, these practices will fade away, like we are going away with our mask. So we need the behavior change need basically continuous approach to address the concern. So I believe that it has raised a concern and it has reached to the masses. But how to sustain those efforts? Probably there could be some aid from the COVID-19 pandemic example, but we need to continue our efforts so that we provide them the facility and then ensure a behavior of routine hand washing to hygiene. Thank you.
Thank you, Dr. Ravindra. One more from my end. You talked about young ambassadors. So how was your experience? And are they like continuing with the young ambassador work, or how you are promoting them, and how you feel they may be sustainable?
Thank you, sir. Basically, we made a village committee under which these school children were engaged. And when you engage the school children, basically the motivation of all team become double. So if we have the young children in our group and they feel also kind of a motivation that they are working with the scientists from PGIMER or from means basically administration. So that was the key moment, you can say, where they were playing double the role also. Not only highlighting our motivation, and when there was supposed to go early morning for you can say open defecation watch, so these were the guys who were coming right on the time and were actively supporting the team vigilance basically. Of course, we took care of their safety and concern also, so all these guidelines were also followed. But we need to have these young ambassador, and we should promote them also. So the city basically administration also rewarded some of the more you can say enthusiastic and you can say those who are contributing more, so that their contribution is well recognized.
Yeah. With this, how you are like making it getting continued? Like there is always an issue that they work for few weeks, for few months, and then after that it comes down. So how you are able to continue the activities of these young ambassadors?
Sir, I must accept that there is discontinuity at this moment because of the COVID-19 pandemic. But as soon as we resume our field duty, which we are in near future, probably they will be well aware and they will be contribute in a more, you can say, enthusiastic way, and they will be more aware of why they are doing this.
Any thoughts on like upgrading their like knowledge and giving some certificate course or something, or like small benefits of taking them to the next level of their knowledge and getting it translated into action?
Thank you, sir. This is an excellent suggestion. Actually, we proposed a EcoVille project to DST, and under which actually not only this, actually we proposed a honorarium to also to them, because they will be responsible for their own village, and they will be those who are studying and as well as managing some grant to support their education. So if that project is funded, EcoVille means ecological village is the concept, and they will not only focus on waste and sanitation, but looking after for low pesticide uses and many other you can say area of environmental concern.
Yeah, at the same time, very good example of like where you have a toilet and the very next few feet away you have a water pump there to take water. So that complexity is always there in urban slums. So what recommendations you gave to the community there?
So basically, it depends on the aquifer depth and the age of the basically casing. So as the casing goes old, the iron casing is normally there. That basically, if you can say there is a broken or something like that, that lead to the contamination. So we need to ensure that this iron casing, if it is old, means we should not, after a certain age, we need to change it, or we should allow a new you can say casing. Second thing is, sir, we need to ensure that the sanitation facility, like everyone is building toilet in rural Punjab. But what I am feeling is that we are bringing the risk closer to home. Why? I will tell you, sir, what happened. They asked for a honeycomb technology for the pit. It means it may contaminate the upper aquifer, but not the other. But what is happening, people have used instead of that a proper septic tank. And now in the rural, what we say, ponds, all the effluent is reaching. And that is contaminating and may pose a major risk to the population. And we need to investigate this. And we are working in this direction also, because they got incentive to build the toilet. But at the same time, septic tank is always linked with, you can say, sewerage network system. But we have not provided a sewerage network system in our rural population. So this aspect need to be addressed. And I'm sure with many colleagues like you and Dr. Kapil, I can see, Dr. Professor Umesh Kapil, I can see, Dr. Bhardwaj. So kind of a consortium could be made, and we could have a colleague like Dr. Robert, those who could also be engaged with their wealth of experience from other world that could be explored further. Thank you, sir.
Great, really great work. Really highly appreciable.
Good.
Over to Dr. Mishra.
Good work, Dr. Khewal. Yeah. Good work, Dr. Khewal. And I think a lot of interesting point has been highlighted, and especially the last point of discussion about we are making toilets all over the country, especially in the rural area under the mission, and what are the issues which may arise if we are not using the right technology, or not doing in the right way. It may contaminate water. So that is an important point, and I think consortium should be made, and recommendations should be given to government, because this is a very huge mission of government to have toilet in all the rural areas. But at the same time, the appropriate technology is also important. So we have a few more minutes. So I would have few quick questions from other two speakers, if there are not any questions from the audience. I mean, I want to know a little bit more from Dr. Robert about his study which he has done in Cambodia. What are the challenges you faced there while you were doing this kind of study from the healthcare workers and from the population where you did this study?
Thank you. It's a great question. I think kind of the first, I want to say this was a study that while it was in Cambodia, I think the context in which we were operating is very generalizable across a lot of low resource contexts. Some of the challenges we faced, we were actually trying to do this study during kind of the high rates when COVID, during the first wave of COVID-19. And what we had originally planned for kind of direct face-to-face interactions with healthcare facilities forced us to think through kind of more of virtual delivery of kind of any training packages, any participatory methods. So I think what ended up being a challenge we kind of created an opportunity with this. And what it allowed us to do was create a virtual platform that's now quite scalable, taking advantage of things like Telegram groups and kind of online platforms where we could deliver these trainings across facilities. I'm using trainings quite loosely because it was less didactic training, but we were able to kind of integrate kind of technology into this. And our future studies are going to be looking at how we can further build off this virtual platform for reaching healthcare workers. Now, that did present even a further challenge, as that was less robust at reaching households. So kind of how we can engage with individual households, kind of new mothers and their families, that under kind of a virtual distant remote platform was just a lot more difficult as well.
Thank you, Dr. Robert. And there's for explaining it nicely. And I know, I mean, due to COVID time, it's a challenging time to do any study. And thank you, Dr. Robert. I have a quick comment or question from our first speaker, Dr. Yashwant. Doctor, are you here, Dr. Yashwant?
Yes, sir. Yes, sir.
Okay. I think it's really needed that you have developed a kind of score to see the healthcare facilities in terms of WASH. I want to know. I mean, you have visited so many health facilities. So where we stand right now, if you, I mean, with your experience, if I talk about maybe one state or maybe country, where do we stand in terms of WASH in healthcare facility as per your observation during your study?
Yeah, thank you, sir. And I think two components that I want to highlight while we see the WASH assessment in healthcare facilities, because it's not that much prioritized in relation to any other intervention in the healthcare facility. Let's say the infrastructure development or any other training program that is being excluded from the WASH trainings or WASH components. It's just because not that we do have the IPC committee and so on, but the real work of WASH being done by the grade 4 workers or the cleaners. But what we lack actually is the training or the capacity building. So let's say the greatest one of the example that I can give is that they do not know how to mop the healthcare facility, or they do not know, so not enough idea on spillage management. So these kind of gaps we do have still, although we conduct WASH fit assessments and so on, the quality checks, and we do microbiological assessments. So there is a need that we equally true to do the capacity building of these grade 4 workers who really taking care of the WASH of a healthcare facility. No doubt the IPC committee should have all the clinicians into the part, but we should not neglect this grade 4 workers. So that is the one component that I want to highlight. And last but not the end is the WASH necessity that need to be realized, because within the context of COVID, it has been well vitalized, but we still far lack in the, let's say, one of the additional factor, electric supply to the healthcare facility. If that is not, there are some indirect factors which has contribution to the WASH improvement that need to be prioritized in some of healthcare facilities. So thank you so much, sir.
Thank you. And you have really pointed out a good observation here that we need to increase the training of especially those workers who are engaged with cleaning, mopping, and all those things, class 4 workers. And I think your recommendations would be taken well by the authorities so that we can improve upon on this aspect, because healthcare facilities are the places where we should definitely work hard to achieve all the goals in respect of WASH. So with that, I would like to thank all the 3 speakers and for this wonderful session, and would like to thank organizers for giving us this opportunity to interact with all the 3 eminent speakers and audience. With this, I conclude here my comments and give to my co-chair, Dr. Zahir, if you want to add anything before we conclude this session finally.
Thank you, Dr. Mishra, and thank you, the organizers, Dr. Pankaj, and all the three speakers. They were all wonderful, and it was a good learning curve for all of us, and a great opportunity for all of us to work on this in this area. Thank you very much. Thank you.
Thank you so much, and thank you all for joining us. Thank you so much.
Thank you, sir. Thank you. Namaskar.
Thank you, sir.
Thank you.
Good afternoon, one and all. We, Dr. Neelam and Dr. Jinesh, welcome you to the session on public health in Rajasthan. I would like to invite Dr. Pankaj Bhardwaj, Vice Dean Research, Additional Professor and Coordinator of School of Public Health and Organizing Secretary of Eficon 2021 to introduce the chairpersons of the session.
Okay, thank you, Neelam.
Dr. Pankaj.
Yes, sir.
How I can be shifted to all A? My session is over there.
Okay, sir, आपको leave करना होगा ये hall, and you leave this hall, and then you need to go to.
नहीं करना आता यार.
लेकिन आप बस leave कर दीजिएगा सर hall को नीचे से, and then फिर आप दूसरे hall में सकते हैं. मैं आपको दूसरा thread भिजवाता हूँ सर. जी. एक मिनट के लिए रुकना नीलम. I send somebody to share the link for to Okay, so I think these are some of the glitches which when we are online and when there is a virtual platform and we have multiple links together. So I'm taking this privilege to have this session on behalf of All India Institute of Medical Sciences. हमारे कुछ लोग, so I request all of you to kindly mute yourself. So it's my privilege to invite the chairs of this session today. And we have with us, can we have the next slide, beta? Yeah, we have with us Dr. S.D. Gupta, who is the trustee, secretary and chairman of IHMR University, Jaipur, and Dr. Amita Kashyap, madam with us. So it's my privilege to introduce our first speaker first. Can we go to the first slide, beta? Yeah. So sir is the chairman of बेटा आप आगे पीछे कर रहे हो. Chairman of IHMR University. He is the adjunct professor in Department of Epidemiology in John Hopkins School of Public Health. Sir is the chief editor of Journal of Health Management and Developing Program and Implementation Science, Gates Leadership Fellow, and former Joint Director, Government of Rajasthan Medical and Health Department. I have a privilege of working with him for past few months when I got an opportunity to work as a team under his chairmanship to work on the School of Public Health, which were announced in the budget session for the state of Rajasthan. I welcome you, sir, here. We have, it's a privilege again to have with us our another chairperson with us, Dr. Amita Kashyap. She's the professor of community medicine at SMS Medical College, Jaipur. She's the former head of Department of Community Medicine in the same medical school. She is the former director of SIHFW Rajasthan. Madam has been engaged in trainings and operational research with UNICEF, UNFP and state government, and supervised and monitored integrated skill training in RCH in the state of Rajasthan. She is a member of governing board, Asha State Resource Center, and she's a convener for short-term skill upgradation course under the aegis of RHSDP supported by World Bank. So it's my privilege again to welcome my chairs. And now I hand it over to both the chairs to introduce our other speakers. Over to the chairs. Gupta sir, are you there? Yeah. So, madam, yeah. So to Kashyap, madam.
Yeah. So good afternoon, everyone. And I have the privilege to work with SD Gupta sir. And it's my real privilege that sir is sitting here and I'm sitting with him. It's a great honor for me. And I just want to introduce the other participants. Can I see the slide of this one or? Okay, I think I will use mine. Okay, so I have just got the message from Kusum Gaur that she has some important work and she won't be here in this session. So the other participants we have amongst us is Dr. Rekha Acharya. She's a senior professor and ex-head of the Department of Community Medicine in SP Medical College, Bikaner. She has worked in various community action-oriented programs, various national health programs. She works as external monitor monitor for WHO and PSP in Bikaner district. In high-risk areas of mines and tribal populations, she monitored for immunization. She worked as medical officer in malaria endemic zones of Rajasthan for prevention and control. Then presently she is taking, I think, some special lectures on epidemiology and community communicable disease management. And she has more than 10 recent publication in various journals. So Dr. Kusum is not with us. Should I introduce her because she's not here? I
No,
think Dr. Pankaj.
Kindly introduce, ma'am.
Okay. So Kusum is in SMS Medical College. She's a senior professor and she has many accolades to her name. She's a WHO fellow and she is a nodal officer for COVID in Rajasthan. And she's a developer of socioeconomic status scale, a spiritual health assessment scale, and she developed a p-value statistical tool which can be used on mobile. And many of our students use it. It's a very feasible thing that she has given to the students. She is the first author of Community Medicine Practical Guide and the Community Medicine Logbook for UG and PG. She is working on spiritual health, doing a lot of work on that. And she is chief editor of International Multi-Specialty Journal of Health. She is in National Advisory Board, like in Indian Journal of Forensic and Community Medicine and Indian Journal of Engineering, Research and Science. She's a good human being. She's a very nice teacher. And I am working with her, so I know her personally. Then we have Dr. Afzal Hakim. He is a senior professor and presently heading the Department of Community Medicine in SN Medical College, Jodhpur. He is working as nodal officer in COVID control room, COVID vaccination center for SN Medical College, Jodhpur. He is coordinating medical education unit in the medical college, and he has 7 publications to his name. And Wasim is a very dear friend, and he is a very nice human being and very committed worker, community health. I think his passion, I think it seems by his works. So he's professor and head in the Department of Community Medicine, RUHS Medical College, Jaipur. He's member and coordinator of community committees formed to start first public health college proposed by the government of Rajasthan. He's member of CBME Implementation Committee, Accreditation Committee, and for Unfair Means Committee. He's nodal officer for 2 adopted villages of RUHS, and I know he's doing a wonderful job. It's a flagship activity initiated by our Honorable Governor of Rajasthan. And he personally meets me and he has told me so many good initiatives he has taken, he started in those villages, and he got the impact also. Then he is holding post in medical college as academic in charge of PG section, medical education unit coordinator, member of curriculum committee. He is basically holding many administrative posts in the medical college, contributing in establishment of new medical colleges, DOSA as a district nodal officer. His services in the pandemic of COVID-19 responsibility as a nodal officer in state is admirable. Then we have Rupesh. He is associate professor and head of the department. He has been with us in SMS Medical College. Again, a very committed worker. And he is presently nodal officer of Multidisciplinary Research Unit, MDRU, Department of Community Medicine, Government Medical College, Dungapur. More than 10 years of experience as teacher. Previous colleges where he has worked is Gitanjali Medical College, Udaipur, Pacific Medical College, Udaipur, and he attended many national state conferences for IAPSM and IPHA. He has done courses in medical education and various mentoring workshops, MCI, which was organized by MCI, which is mandatory for the faculty. And he has done the certified courses for diabetes and cardiovascular diseases and stroke from PHFI. So these wonderful experts are with us as a panel. And the most important is that the topic today is very interesting, and I just want 2 minutes to speak on it because it's a very topic close to my heart. Because I think public health is a distinct discipline, and we have used it. No, I shouldn't say we. Many others have used it with only common sense. While it has all scientific principles and the dogma of public health, if we learn it, then it has a very specific role in not only control and containment of epidemics and pandemics, but of course for giving better health and better opportunity to an individual to exercise its potential given by the God, which we are usually not achieving because we are not given the due importance we actually deserve. So I think we need experts in public health, not only at the periphery. We need public health experts at the periphery as well as at the center position to envisage to have the vision for primary promotion, health promotion and health prevention. And as we say, if we nip the fire at the start, if we can extinguish the first sparkle, then we can save the forest. So that is the thing. We have just thought that public health is only for epidemic and pandemics. I think it's a day-to-day affair, and we should be given due importance and roles. So the public health needs to be nurtured as importantly and as passionately as any other discipline, because I know all disciplines have their important roles. I know that all disciplines have their specific boundaries, but public health boundaries are merging with many other disciplines. And that is the reason we are not given our due respect. So we have to find the acumen which is specific to us, and of course it has to merge with other things, because curative care has to be there, because prevention needs cure also. Because even if we talk about pandemic and epidemic, if we don't have cure for the ailing people, then neither we can save our names nor we can save the suffering. And if we save the patients, if we cure the patients, we are mitigating the source of infection. We are mitigating the transmission. So it is important. And we have many accolades to our share, like eradication of smallpox, guinea worm, polio elimination, control of Zika, control of SARS, control of MERS, so many, and now COVID. So I should not be speaking too much, but what I want is we need to invest in developing a foolproof teaching and training strategy for UG and PG, which should involve hands-on training in the community. We have amongst us Dr. S.D. Gupta, needs no introduction because he is epidemiology starts from S of S.D. Gupta, sir. Sir, please speak something.
Let me see. Okay, am I audible?
Yeah, sir, you are audible.
Okay, thank you so much for inviting me to this important conference. And in fact, epidemiology is very dear to me all through my life and spent my life in this. So thank you, Pankaj. Thank you, Amita, for introducing me to very, enthusiastic group of people who are participating in this particular session, and the young faculty. And I see a great future for public health in them. So, the topic is this public health in Rajasthan and future and all that. So I think Amita was a bit modest. She didn't talk about her contribution to deal with this pandemic in Rajasthan. I'm talking about Rajasthan at this moment. So I was on the Chief Minister's Advisory Group on COVID in Rajasthan. And we had always many experts with us, but there were 7 members of that group. So out of 7, 5 were clinicians, pulmonologists, or physicians, or gastroenterologists, cardiologists, and only 2 persons were from public health. Dr. Ashok Agrawal, who is not in active public health, but is a great promoter of public health, education and leadership. And I was there. So I should give credit to ourselves that we were able to guide the government to deal with the COVID pandemic in Rajasthan. And public health, PSM department played a very important role. At least I know of the first wave where we were very actively involved. And I'm very proud and also very delighted that the Chief Minister always accepted our recommendations and applied. And as a result, you all know, Rajasthan became a model for prevention and control of COVID pandemic. So PSM departments played quite an important role in the current pandemic. I believe this pandemic is coming to an end. I'm not, in my earlier, few weeks back, I used to say, why not third wave? It should be there because throughout the world it has happened, and in Southeast Asia it has happened. Why not in India? But I'm feeling more confident now that the third wave may not be there in India because we have reached high immunity levels, natural immunity, subclinical infection immunity, and also huge vaccination coverage. And I must admire, I don't know why Amita thinks that PSM department is not given importance. It is all vaccination program in the medical colleges were managed by the PSM department. So let us not take that way that we are not given importance. So we PSM department, public health people have played very important role in this disaster that we have had. Anyway, with this perspective, I just want to don't want to separate out Rajasthan from what the global and Indian perspective is, because Rajasthan has also entered in the 21st century. And it's not different than other places globally as well as nationally. We might be lagging behind in some indicators, but I actively worked in the government about 30 years back. And the situation at that time is difficult to imagine. And before that, I joined the profession in 1974. And the infant mortality rate at that time was 125 per 1,000 live births. Maternal mortality rate was 500 plus. And what we have today, so Rajasthan has made a tremendous progress in the last 50 years, but the pace is not that great as we would have thought of. But we were part of smallpox eradication, we were part of polio elimination. One unsung success of Rajasthan is that we eradicated guinea worm disease. Most of the cases of guinea worm were in Rajasthan, and Rajasthan eradicated it totally. So there are many, and leprosy is also at the elimination phase, almost. So I must say, not because that I am in Rajasthan, I've been traveling through the world and throughout the country, in every state, and in their rural areas and all that. And I find Rajasthan has some sanity in health system and provision of healthcare. At least we have some system. People are very much committed to. So anyway, so we must prepare for 21st century. In the first 20 years, we already have 3 pandemics. How many we will have in coming time?
Yeah,
we don't know.
Yes,
so
sir.
We have to prep.
Sorry, sir. Absolutely, sir. I was interrupting, but yes, absolutely. As you said, so we have few questions to the panelists, sir. And because in the interest of time, because I want more discussions from your side, from the side of seniors.
Yeah, I'm coming to that.
Yes, sir.
So we have to prepare ourselves. We need to really see the changing disease pattern, the changing reforms in health systems. We need to look at the new technologies, especially digital health coming in a big way, insurance introduced in a big way. So the public health people need to learn all these things. They should learn leadership, they should learn management, they should learn what is this information technology, they should. And besides that, important public health practices, they must master it, like disease surveillance or investigation of outbreaks, screening of health programs. All these are important public health practices. So in this decade, this is the decade for public health. And PSM department have a great opportunity, I must say. And this young generation must come forward. So thank you so much. And I'm quite aware of this, that we are short of time. So I will request Amita ji to start with the presentation by the speakers.
So can I, Dr. Pankaj, can we take the questions in the end of the session?
Yeah, actually, as there are no presentations, there are no formal presentations, madam.
Yeah, so let us, oh, sorry.
So
yeah.
we have already put up few points to our panelists, and
okay.
Final comments and the experts.
Sure.
From
That's
both.
Good.
And so let's come one by one to the panelists and hear from them about the issue which we would like to discuss from them. Few points we have kept from Dr. Kusum, and as madam is not there, so we'll take that question to others also, because we have already worked in that. But I will start with Dr. Afzal sir first, because I've been working with Afzal boss also in Jodhpur. Sir, are you there? And am I audible? Great.
Yes, you're audible.
Great,
Good
sir.
evening, everyone. Dear seniors, Amita ma'am, SD sir.
Sir, as you're in administration at multiple places, I've seen you multiple places you are in administration. So would like to know about your experience. And a very quick question which is coming in our mind is, that do you think the teaching and training in postgraduate in community medicine helps in getting all these positions?
Not exactly. See, my experience is, and I hope Amita ma'am and SD sir would also agree, I have seen since I've been into service for 22 years. So my experience is that any work which the principal doesn't understand, he gives it to the PSM people. Is it right, ma'am?
Yeah,
कुछ सालों पहले तक तो ऐसा ही होता था. बट हाँ, ये जरूर है कि अब समय के साथ साथ, स्पेशली आफ्टर द स्वाइन फ्लू एपिडेमिक एंड नाउ दिस कोविड, स्वाइन फ्लू के एपिडेमिक के बाद से ही हमारे एडमिनिस्ट्रेटर्स ने पीएसएम की इंपॉर्टेंस को जानना शुरू किया. और स्पेशली आई वर्कड इन द वैक्सीनेशन पार्ट. सो विद द एडवेंट ऑफ द न्यूअर वैक्सीन्स इन द मार्केट एंड अदर वैक्सीन्स, पीएसएम की इंपॉर्टेंस दिन पर दिन बढ़ती जा रही है. कोविड ने पीएसएम को बहुत ज्यादा इंपॉर्टेंट बना दिया है, especially in the eyes of the college administrators. जितना मैंने यहाँ पे काम किया, we were given due importance during the COVID times, being asked by the district collectors, by the divisional commissioners, by the ministers, secretaries, कि किस तरह से क्या planning होनी चाहिए. And PSM department at Jodhpur was given the responsibility for the 6 districts of Western Rajasthan, and to manage the outbreaks by sending the rapid response teams. The initial flights of the migrants which came to India was first landed at Jaisalmer. So we were given the charge to look out the landing part and how to safely transport those passengers to their respective isolation centers. ये सारा काम PSM की देखरेख में ही हुआ था. So yes, I will agree that PSM has the department has been given importance in this COVID pandemic.
तो सवाल फिर वही रहा सर, हमारी ट्रेनिंग जो हम ले रहे हैं पोस्ट ग्रेजुएट से, इस सवाल को ऐसे रखता हूँ सर दूसरी भाषा में. एनेस्थीसिया के लड़के को एनेस्थीसिया देना सिखाया गया, उसने वही दिया, जिंदगी भर एनेस्थीसिया ही सीखा. मेडिसिन के लड़के को मेडिसिन देनी सिखाई गई, गायनी को ओबीजी सिखाई गई. हम अपने लड़कों को क्या सिखा रहे हैं और वो फाइनली क्या कर रहे हैं आफ्टर पासिंग दिस एमडी? इज देयर अ गैप और मिसमैच? कहीं कोई मिसमैच तो नहीं है? हम उन्हें सिखा कुछ और रहे हैं कुछ और आने के बाद?
There is always a gap, and there always will remain a gap. Complete तो चीज कभी होगी नहीं. So yes, we at Jodhpur, like mostly the PG students that are coming to us are coming from the in-service quota, and उनका एक ही target होता है कि PG करने के बाद they again want to go in the district health administration as the RCHOs or deputy CMHOs. Initial posting उनको वो मिलती है. So they are more interested in looking after the administrative work.
तो फिर हमारी टीचिंग ट्रेनिंग, हम अमिता मैडम के पास आएंगे, फिर गुप्ता सर के पास फिर दोबारा जाएंगे, तो फिर तो हमारी टीचिंग ट्रेनिंग ये पीजी करिकुलम का क्या मतलब है सर? बिकॉज जो मैंने एनेस्थीसिया के बंदे ने तो यही सीखा कि एनेस्थीसिया कैसे देना है. एक ओबीजी के लड़के ने सीखा कि बच्चा कैसे बाहर पैदा करवाया जाता है.
पंकज, I'll say you something. जो लोग MD PSM कर वापस डिस्ट्रिक्ट हेल्थ के अंदर जाते हैं, उनको जब भी कोई प्रोग्राम्स आते हैं, गवर्नमेंट के नेशनल हेल्थ प्रोग्राम्स आते हैं, कोई पेंडेमिक आता है, कोई डिजीज आउटब्रेक्स होती हैं, कोई स्पेशल ड्राइव्स चलानी होती है, तो उसके अंदर उनको ड्यू इंपॉर्टेंस दी जाती है, एंड दे आर बीइंग पोस्टेड देयर एज नोडल ऑफिसर और ऑफिसर इंचार्जेस फॉर दिस प्रोग्राम्स. सो डेफिनेटली द ट्रेनिंग ऑफ PSM, especially in the field of public health, it works, and it's working, and we hope that it gets better day by day.
ठीक है सर. अमिता मैडम के पास क्विक रिस्पांस के लिए जाते हैं, फिर क्विक रिस्पांस.
So Dr. Pankaj, I can get your question, and yes, there is a huge gap. Basically, we are not giving due recognition to the needs of administrative skills. That is what I said. Specific training, specific equipments, specific hands-on roles should be there in PG. Not only PG, even in UG. Like this new CBME is trying to do it, but still we have devised, I should not be saying that, but yeah, we have devised methods how to do field work in the classroom. Many of those hands-on trainings are shifted to role plays.
Yeah, okay. Thank you so much, ma'am. Thank you so much. Quick comment गुप्ता सर से लेंगे, and then I'll go to रुपेश एक important सवाल पूछने के लिए, because I think he is the youngest out of us. So गुप्ता सर, आप क्या कहेंगे सर? हमारी टीचिंग और है, और सर हम करवा कुछ और रहे हैं अपने लड़कों से जब वो MD करके निकले.
That's what I said. We must prepare our young graduates as well as particularly postgraduates who are coming out of community medicine. They must be adequately trained in administration and management because the future is in leadership and strategic management. The future is in collaboration and partnership and networking. Even individually for their own growth, they require all this. So it's very important, and somehow we need to really look at, let us not follow any book particularly, but let us follow the curriculum which is required for community medicine. It will be very nice if we can review our curriculum and do some innovative modifications in that to incorporate these. This administration and management is real challenge, but we are not training our people in that.
The CBME has done it.
Yes, thank you so much.
But we devise the passages to walk out of it.
Yeah,
so basically,
I think ma'am, आप बिल्कुल सही कह रहे हैं. Now over to Rupesh. Rupesh, you are the youngest out of all of us, and I think आपके ideas मैं देखता रहता हूँ group में ना, that keep us motivated. People who have already been in their mid or higher age group. क्या बदलना चाहोगे रुपेश? अगर तुम्हें कहा जाए कि PSN की टीचिंग ट्रेनिंग में what do you think are the gaps? मैडम ने भी gaps की बात की, सर ने भी gaps की बात की. क्या gaps हैं जो आपको लग रहा है अब हैं जो बदलने की जरूरत है? It's the time to revamp. It's the time to relook. It's the time to give them a shape again. Rupesh, आप mute him.
Firstly, I would like to thank you, the Eficon 2021 team, to give me opportunity to be a part of panel discussion. My sincere regards to all senior faculty of public health of Rajasthan. Yeah, certainly, I would say I have been working in the medical college for the last 11 years, out of which I had spent 8 years in the private medical college of Udaipur. Now currently I am working at government medical college Dungarpur past 3 years. But I had felt among these years of teaching and imparting the knowledge to the students that many faults lies with us, because my students are not taking our subject seriously. Why they are not attentive towards attending the classes? Why they are missing? I think what I had observed that many faults lies with department, with faculty. To give good learning and teaching to the students and imparting the training among students of our subjects, we need to be prepared first. We must have adequate knowledge, adequate skill, good communication. We should do firstly homework first. And we should have generate ideas how we can involve the students in better way by taking the good interactive session, whether in the theory class, in didactic lecture, or in the clinical posting. Whatever we are teaching, there must be coherence between the theoretical part as well as for the practical part. Whatever, let it be any topic we are teaching, it must be shown in the hospital, because we know that our subject is multidisciplinary. We are integrated with obstetrics, medicine, we are integrated with pediatrics. Whatever components we are teaching to our students, it must be shown and it must be given observation, so that whatever we are teaching, if we students see in the reality, then there will be better understanding and better acceptance. So I would say that firstly, many times what we find that our faculty should have good attitudes to know the things better in better way first, and then only we can reproduce and it will create better results. So we need to strengthen our ourselves. We need to work on the SWOT analysis. What are our strengths? What are our opportunities? So we need to work on that aspect. Then only we can.
I think we are getting you, Rupesh. मैं तुम्हें बीच में cut कर रहा हूँ because I can get most of the points which you are saying. तुम्हारी बात से लगा, Rupesh, that you want that it's in your opinion that we need to get ourselves, we need to get our house clean first, then we need to go outside. But definitely, I agree.
Yes, surely, sir.
We need to clean our home or house first, because that is more important for us. Thank you, Rupesh, for this point. मैं थोड़ा सा point को फिर इधर से थोड़ा और घुमा के लेके जाता हूँ. रेखा आचार्य मैडम भी हमारे साथ हैं, very senior faculty from us. मैडम, आपसे अगर ये कहा जाए कि मैडम आपने क्या बदलते हुए देखा है मैम कम्युनिटी मेडिसिन में, जब हम टीचिंग ट्रेनिंग की बात कर रहे हैं इन पास्ट, प्रेजेंट एंड फ्यूचर, क्योंकि जैसा सर कह रहे थे अभी गुप्ता सर, इट्स द टाइम टू स्पीक अबाउट लीडरशिप, इट्स द टाइम टू स्पीक अबाउट मैनेजमेंट, नेटवर्किंग. तो क्या वो अब हो रहा है, या फिर पास्ट में भी नहीं था, प्रेजेंट में भी नहीं है, फ्यूचर में भी हम क्या करने वाले हैं हमें अंदाजा नहीं है. सो वी वुड लाइक टू टेक फ्यू पॉइंट्स फ्रॉम यू मैम.
Good afternoon everyone. Sir, Dr. Pankaj, thank you very much to give me this opportunity to sit with this learned personality, Amita madam, Kusum madam, and supermost SD Gupta sir, and my colleagues. So your question is, what are the changes we faced in our teaching or in public health in Rajasthan state? Sir, in teaching and training, IT technology, IT encouragement of IT is the best facility we give to the students. Computerization and internet facility. So research it facilitates our research, plus connectivity with the other people. If we see the Rajasthan state is facing so many problems as our country is facing. And nowadays the dengue is the prime vector-borne disease. Sir, in my viewpoint, our teaching and training should be in such a way for undergraduates and postgraduates that they should be a public health manager. They must not a clinician. They must have a comprehensive package, preventive, promotive, curative, and rehabilitative. And we must give them training in such a way. Sir, we should say them that we are as a part of community. If any problem in the community, doctor will face the problem. Same. So our field practice area should be strengthened. PG and UG teachers, we must teach them public health in the field, not in the classroom. This is the important. And resources regarding the same should be utilized or should be taken from the government, that we have to make public health expert. As we are the part of, in the medical college, we are the part of human resource development. So we must develop our doctors as a public health expert. Another thing is that public health problems can be minimized with the help of community participation. So all the field workers, if our medical officer is sensitized enough regarding the same, if he is whether postgraduate or not, if he is MBBS, if we are teaching them during 5 years curriculum, if we are giving them idea regarding the field, how they deal with the public health, then and then only we can reduce the problems. So, sir, one is sensitization of our PG and our MBBS as well as PG experts doing field or doing in the medical college should act as an expert, public health expert, and they must sensitize periodically their health worker or lower level workers. As I see in the field, ASHA, ANM, all the field workers, they are doing activities of public health in the community, and they are responsible. So periodical sensitization program for them, that how to deal with the people, how to identify public health problem, how to generate data, how to fill the performer, and we should send the performer. So strengthening of surveillance system with the sensitization of grassroots level worker, and this can be done by the medical officer. Who is the medical officer? Either MBBS or MD. And during our curriculum, during our study period, we should make them as a part of public health expert regarding prevailing health related problems. And I can say that public health department did very well during COVID, as I am a part of RRT, rapid response team. We did very well in contact tracing, data collection and reporting. Our ID specialist is working very well, and that's why we are able to check the problem. We are not free from the problem till date, but we check the problem. So our teaching and training should be in such a way that we must generate public health experts. Public health experts must percolate training up to the grassroots level, and we must ensure supervision of grassroots level worker regarding data collection as well as other surveillance activities. Then and then only we can reduce public health problem in our country, in our state.
थैंक यू सो मच मैम. आई थिंक 2 पॉइंट मैडम की उससे पता चल रहे हैं बिल्कुल क्लियरली, और वो पहला ये कि सबसे इंपॉर्टेंट फील्ड बेस्ड ट्रेनिंग है, कि जो कह रही है कि शायद हमारा तो लैब ही वही है. सो आवर लेबोरेटरीज एक्चुअली द फील्ड प्रैक्टिस एरियाज. दूसरी सबसे इंपॉर्टेंट चीज जो मुझे मैडम की बात से समझ आई वो है पब्लिक हेल्थ डिपार्टमेंट्स या कम्युनिटी मेडिसिन डिपार्टमेंट्स तभी काम कर सकते हैं जब रिसोर्स कंस्ट्रेंट्स ना हो. यानी अगर मेरे को मेडिकल कॉलेज में भेजा गया है और मैं एक मेडिकल कॉलेज में कम्युनिटी मेडिसिन में डॉक्टर हूँ एंड मेरे पास रिसोर्सेज नहीं है, बाहर के लिए बसेस नहीं है या चीजें नहीं है जिसके कारण मैं लोगों से मुलाकात कर सकता हूँ, या there are it's not just the infrastructure, it's maybe in manpower, it may be in the other inputs. अगर वो नहीं है तो प्रॉब्लम आ सकती है. यहाँ से एक पॉइंट I'll take it from Wasim, and that is because Wasim is also very close to my heart. I think he's our the most important point in Jaipur. Jodhpur में हमें जब परेशानी होती है, we always look to him, and he's so nice and kind. He help us when it comes to the problem related to स्टेट हेल्थ डिपार्टमेंट्स ऑफ राजस्थान. वसीम, आपसे ना एक बात पूछना चाहूंगा, एंड वो ये है कि डू यू थिंक पब्लिक हेल्थ एंड कम्युनिटी मेडिसिन क्रॉस रोड्स पे आ गई है, एंड व्हाई इन दिस सब्जेक्ट आई एम, बिकॉज आई एम नॉट दैट सीनियर एंड नीदर आई एम नॉट दैट जूनियर इन माय स्पेशलिटी, लेकिन हमेशा से एक चीज मुझे देखने को मिलती है that we are always feeling threatened, and I don't know threatening of what. So there is a question which comes to our mind, in the mind of my young chaps, क्या परेशानी है, क्या हम रियली में क्रॉस रोड पे खड़े हैं और हम हमेशा घबराए क्यों रहते हैं?
गुड इवनिंग सर, एसटी गुप्ता सर, अमिता मैम, थैंक यू डॉक्टर पंकज. और जैसे कि आपने कहा कि हम क्रॉस रोड पे हैं, तो ऑब्वियस हम इन द पब्लिक हेल्थ और इन द कम्युनिटी मेडिसिन वी आर इन एट क्रॉस रोड, because there is no clarity or in our rules and functions and in the approaches, and our approaches are ambiguous with the both or any other specialty also. So community medicine and public health both represent society's organized and public support effort to improve the health status of the entire population. But we have ambiguity in our function, like अभी जैसा कि मैडम ने कहा कि हमें डाटा कलेक्शन से ज़्यादा इम्पोर्टेंट है, हमारे पास रिसोर्सेज होना चाहिए, और सर ने कहा कि नहीं, अगर हमें मिलता है मौका तो हमें लीडरशिप लेनी चाहिए. तो मैं सोचता हूँ कि हाँ, हमें लीडरशिप लेनी चाहिए, और ना कि हम एक पेशेंट केयर में जाना चाहें या कम्युनिटी में हम इंडिविजुअलिस्टिक केयर प्रोवाइड करना चाहें. उसके कंपेयर में हमें मैनेजमेंट और लीडरशिप एस्पेक्ट या नेटवर्किंग वाला पॉइंट जो है वो उस टाइम हमें उस तरफ हमें जाना चाहिए. तो जो हमारा क्रॉस रोड है या हमारी जो डायलेमा है, हमें लीडरशिप की तरफ जाना चाहिए. और वी आर नॉट प्रोवाइडर, सर्विस प्रोवाइडर, वी आर मैनेजर ऑफ सर्विस प्रोवाइडर. हमें इस तरह से हमें अपने आप को प्रेजेंट करना चाहिए कम्युनिटी में. सो मेरे को लगता है ये सही है आपका कि क्रॉस रोड पे हैं, और अगर हम आगे डेवलप करना है तो जैसा कि मैडम ने बताया हमारे को रिसोर्सेज कम है. तो रिसोर्सेज अगर हम लीडरशिप में आते हैं, हम मैनेजमेंट में आते हैं, हम कॉलेज मैनेजमेंट में आते हैं, मुझे नहीं लगता कि उन कंडीशंस पे जाके हमें रिसोर्सेज की कमी पड़ती है. हमें शायद मैन पावर में मिलती है, और अगर हमें और दूसरी लॉजिस्टिक्स वगैरह भी चाहिए तो अगर हम कॉलेज के एडमिनिस्ट्रेशन में हैं और या हमारा जो सिस्टम है उसके मैनेजमेंट में हैं, और अगर हमारी नेटवर्किंग है, तो हम कहीं से भी ये सिस्टम या रिसोर्सेज जो हैं वो हम डेवलप कर सकते हैं. दूसरा क्वेश्चन है सर आपका कि क्या हम थ्रेटेंड हैं? ऑब्वियस हम थ्रेटेंड हैं, क्योंकि हम क्लिनिशियन से भी थ्रेटेंड है. ऑब्वियस हम उनके मतलब सेकंड कैडर के हम के कंपेयर में अगर हम माने तो, भले हम मानना चाहें या ना चाहें, हम क्लिनिकल्स के साथ में पेशेंट केयर देना चाहते हैं, वो हम क्लिनिशियन से बेटर नहीं दे सकते, ठीक है। वो ऑब्वियस वो उन काम के लिए, जैसे आपने कहा था कि ट्रेनिंग किस चीज की हो रही है और हम कर क्या रहे हैं, तो हमारे में डिफरेंस है कि हम जो कर रहे हैं वो उस चीज की हमारी ट्रेनिंग नहीं हो रही है, इसमें कोई शक नहीं है। हम पेशेंट केयर उतनी स्पेसिफिकली नहीं सिखा रहे हैं हमारे स्टूडेंट्स को भी, तो प्रॉब्लम है। तो हमें हमारी तरह लीडरशिप की तरफ जाना चाहिए और हमें वो काम को ज्यादा इंपॉर्टेंस देनी चाहिए। रिसोर्सेज वगैरह की कमी मेरे को लगता है कि हम अगर लीडरशिप में जाते हैं, हम मैनेजमेंट में जाते हैं, हम नेटवर्किंग में जाते हैं, तो हमें ये जो लीडरशिप वगैरह की जो रिसोर्सेज की प्रॉब्लम है वो क्लियर हो सकती है। जहां तक थ्रेटन है, तो थ्रेटन तो हम क्लिनिशियन जो हमारी स्पेशलिटीज हैं उनसे भी थ्रेटन है, और इवन जो एमपीएच कोर्सेज करके आने वाले हैं, क्योंकि देर आर मशरूमिंग ऑफ द पब्लिक हेल्थ कॉलेजेस नाउ, एंड और एमपीएच के ग्रेजुएट जब बहुत सारे होंगे तो ऑब्वियस हमारी फील्ड प्रैक्टिस एरिया में हमसे ज्यादा इंपॉर्टेंस मिल सकती है। तो हमें थ्रेटन तो है दोनों से, हमारे कलीग्स क्लिनिशियन से भी और एमपीएच जो कोर्स करके आ रहे हैं उनसे भी।
सवाल बहुत मुश्किल था, शायद जवाब बहुत आसानी से दिया वसीम ने। वसीम की शायद जो नेचर है वो इतनी अच्छी है कि उसने बहुत सीधेपन से उसका जवाब दिया है, जबकि सवाल सही में बहुत टेढ़ा था, बहुत मुश्किल था मेरे लिए भी। जब लोग मुझसे पूछते हैं, अभी और सीनियर एक्सपर्ट्स की तरफ जाऊंगा और यस, थैंक यू वसीम और गुप्ता सर बैठे हुए हैं, बिकॉज जब जैसा अमिता मैडम ने कहा पब्लिक हेल्थ की बात आएगी, एपिडेमियोलॉजी की बात आएगी, तो ऐसे शुरू होगा। सो गुप्ता सर से सवाल कर लेते हैं हम सब लोग कि सर जब एक कम्युनिटी मेडिसिन के ट्रेनी रहे थे, तो लोग कहते हैं ना अपना फोकस सीधा रखो, सामने रखो, आप अपने आप को फ्यूचर में कहाँ देखते हो। तो सर आप हमें कुछ बताएंगे, ऐसा क्या आपकी इस पूरी इस जर्नी में रहा है जो आपने देखा और जो आप चाहेंगे कि हम लोग भी देखें, आने वाली पीढ़ियां भी देखें जो कम्युनिटी मेडिसिन में है, जिसके कारण आज आप, जैसा मैडम ने कहा, आप वो एस हैं, यानी we can look up to you as a person from public health and we all acknowledge and we all pay due respect. तो वो क्या चीज आपने देखी जो आप कहेंगे कि नहीं तुमको सबको भी देखनी है, and that's why I am what I am today.
Again, you have asked this difficult question, but Amita has seen me growing. I think first thing we should look within ourselves. We should try to build our competence. We should not, stand with a, head hanging down. We should be very competent, build competences, and let us talk with the evidence. This is what I did. I was one of those persons in those days in 1974. I was sent to Rural Health Training Center. And I was not moved for another 7 years or 8 years. But I must tell you, I enjoyed my work. That's one thing that I did. So it was a very rich experience for me. So my advice to all community medicine colleagues is, don't feel threatened. People ask me, who are your competitors? I always say, I have no competitors. They should compete with me. I don't compete with. So you have to set your gold standards so that people compete with you. Nobody can do disease surveillance. Nobody can do data analysis. Nobody can produce evidence. Nobody can, be master of case detection and, starting preventive measures and demonstrate. Public health has shown that it is the only way to deal with the disease, this pandemic. No disease. I recently analyzed some data on patients, and I found remdesivir does not work. Tocilizumab does not work. I also looked at the role of prednisolone and other, antivirals. Let me honestly tell you, it is only prednisolone that was significantly associated with at least 60-70% risk of death. And I'm saying this with the data, I'm not hypothetically talking about. And Amita might recall in our meetings that I always said, no, this remdesivir does not work. Tocilizumab did not work. And all were clinicians, think of it. Let us be bold on that, what we think. So, I see Wasim and Pankaj, we all were doing this new school, RUHS School of Public Health. So Wasim suggested me, and I felt like he's suggesting that I should lower the expectation and compromise. I said, no, we will have this. It is up to government whether they want it or they don't want. So let us be upright, work hard, don't refuse for work. We don't have to produce enemies for us. We should be part of the institution and we should be happy to work. We should enjoy it, whatever menial work may be. We might feel it is menial. So be part of the team, I would say, and try to be on the right hand of the boss. If you have some ideas to do things, not only that you should be competent, but you should have a goodwill in the department. So everybody is with you. So these are some of the non-academic skills that we require. You learn to work together and be happy with. And keep in mind, people used to ask me, yeah, you are already MD, you are already established. Why you want to do your PhD? Are you crazy? You don't have money. No funding is there. Still you want to do PhD? I know now, I have understood that my knowledge is not complete. I have to build it further. And I did that. So asking me about, I worked in secretariat, I worked in the directorate. मैं सबके काम करता था, और rather secretaries used to fight among and between them to कि नहीं ये हमारा काम करेगा, आपने उसको कैसे बुला लिया. This is the kind of fight. The reason was I was quite competent and was able to deliver. So I'm not bragging about all this, but let us be competent. Let us have a positive mindset. Be focused. कुछ भी menial job नहीं है. And don't forget to publish. Yeah. And publish in journals which are cited. Yes. Don't publish in journals all the hard work that you have done goes waste if you publish in small street side journals. Must always aim it. They might ask for some payment. If you request that you are a teacher and you cannot afford to pay, they will waive off it. But think of publishing in established journals. That will establish your credentials in the public health or wherever you are. Yeah. So these are in summary that I have some ideas to say.
Thank you so much. I think that is what experiential learning is all about. So when we hear something from somebody who has experience of doing it, that makes sense to us. And thank you so much, sir, because आपने 2-3 पॉइंट बहुत इंपॉर्टेंट लिए. और मैं अपने व्यूअर्स, क्योंकि मेरे 1200 से भी ज्यादा जो व्यूअर्स हैं, जो बाहर हैं, जो वर्चुअल प्लेटफॉर्म से ये देख रहे हैं डिस्कशन, सो उन लोगों के लिए कि आपने कहा कि लीडरशिप स्किल्स के लिए पहले वो लीडरशिप स्किल्स सीखने होंगे और वो हमें शायद वो लर्न करने हैं. वो जरूरी नहीं है कि वो सबके अंदर है, चाहे आप पीएचडी करें, चाहे एमपीएच करें, चाहे एमडी करें, बट learn that up, and that is something which is very important. आपका एक पॉइंट भी मुझे बहुत अच्छा लगा, be on the right side of your boss. That is also very important.
That is very practical thing,
Very practical thing, sir.
We all work in institutions and in big organizations, and we know that we need to know the conflict management. We need to know how to work.
Right.
ये जो skills आप बता रहे हैं, ये शायद पढ़ाए जाने चाहिए या फिर लीड बाय एग्जाम्पल, जैसे सब लोग कहते हैं. वो कहीं ना कहीं एक लीडर हमें ऐसा दिखता रहे. वो हमें लीडर अमिता मैडम में दिखे, वो लीडर हमें रेखा आचार्य मैडम में दिखे, वो हमें वसीम, रुपेश में भी दिखे. तो वो ये ऐसा है कि दैट इज समथिंग फॉर अस. एक सवाल फिर लेते हैं, अमिता मैडम के पास जाते हैं. मैडम, अब आपसे एक क्विक कमेंट लेना चाहूंगा कि बिकॉज यू आर एट द हायर मोस्ट लेवल ऑफ मेडिकल एजुकेशन आप हैं, और आपसे फिर ये गुजारिश करे कोई कम्युनिटी मेडिसिन का पीजी कि मैडम कुछ पीजी करिकुलम में बदल दीजिए, तो क्या एक या दो चीजें आप चाहेंगी जो बिल्कुल बदल देनी चाहिए मैडम? क्योंकि आप यू आर एट द मोस्ट हायर मोस्ट साइड ऑफ द मेडिकल एजुकेशन, तो क्या बदल देंगी जो आपको लगेगा? और उसको बदल के, क्योंकि एक पुरानी कहानी है, मैं अपने हमेशा अभी मुझे नेशनल मेडिकल कमीशन ने बुलाया और उन्होंने पूछा ये मुझे ऐड करना है, तो मैंने उनसे कहा कि ऐड करने से पहले मुझसे ये पूछ लीजिए क्या निकालना है। घर में कोई चीज तभी नहीं आ सकती है जो पुरानी चीजें निकले वहां से, बिकॉज अदरवाइज तो वो घर घर नहीं रहेगा, वो तो फिर एक अजीब सी जगह बन जाएगी। क्या चीज निकाले मैडम इसमें से, और क्या चीज इसमें ऐड कर दे दो, एक अच्छी सी चीज।
मैम म्यूट है आप।
मैम आप
अमिता मैम अनम्यूट कीजिए।
हाँ, ओके। सो निकालने के लिए हमारे पास ऐसा बहुत ज्यादा नहीं है, लेकिन हम उसके उस निकालने के बजाय हम उसे रीमॉडल कर सकते हैं कि जब हम मान लीजिए प्रोमोटिव केयर कुछ सिखाना चाह रहे हैं, तो उसके साथ साथ उसका मैनेजमेंट और लीडरशिप उसमें वही एम्बेडेड कर ले। सो आई थिंक जैसे अगर हम कचरे को निकाल के बाहर फेंकते रहेंगे तो एनवायरनमेंट में कचरा होता है। अगर हम अपने कचरे को रिसाइकल करके उसको ब्यूटिफाई कर लेंगे तो हम अपने ही लिमिटेड रिसोर्सेज में और हायर अचीवमेंट्स कर सकते हैं। तो मैं जो शुरू से कहती हूँ वो यही बात कहती हूँ कि हमारे रिसोर्सेज को जब हमारा प्रिंसिपल या सेक्रेटरी अपने या दूसरी जगहों पर डाइवर्ट कर देते हैं और हम उससे कॉम्प्रोमाइज कर रहे होते हैं, तो हम उसमें हैसल फील करने के बजाय what I have always done is मैं सीएमएचओ को बोल के बुला ले, सीएमएचओ के जो काम चल रहे होते थे उनकी जीप में अपने बच्चों को भेज देती थी ट्रेनिंग के लिए। सो मेरे को हमेशा वो एसडी गुप्ता सर की बात की आपको नेटवर्किंग करनी है, तो अब आपको बॉस का राइट हैंड रहना है। तो मुझे जब भी गाड़ी की जरूरत पड़ी मेरी टीचिंग के लिए मुझे हमेशा मिल जाती थी, लेकिन वो प्रॉब्लम क्या है, वो एक प्रोसीजर नहीं है कि वो हर किसी को मिल जाए। तो जो आपने कहा क्या करिकुलम में से निकाल दें, तो हम आई थिंक बहुत जो थ्योरेटिकल ट्रेनिंग का पार्ट है उसको हटा के और जो प्रैक्टिकल ट्रेनिंग, जैसे हम पहले 70% थ्योरी कर रहे थे, 30% प्रैक्टिकल कर रहे थे, अब हम क्या कर सकते हैं कि जो 70% हमारा थ्योरी था उसको इस तरह से रीमॉडल करें कि वो 70% में से 20% थ्योरी एंड बाकी थ्योरी बाय प्रैक्टिकल चला जाए। आई थिंक इट इज लाइक हमें एडमिनिस्ट्रेशन ऐड करना है, हमें लीडरशिप ऐड करना है, हमें हम इफेक्टिव पब्लिक हेल्थ कम्युनिकेशन सिखाना चाहते हैं, बिकॉज कम्युनिकेशन एज ए कम्युनिकेशन सिखाने से कोई फायदा नहीं है। मैं बाय एग्जांपल बताऊं कि आपको मैलनरिश्ड बच्चे को किसके माँ बाप को उस कम्युनिटी को कैसे चेंज करना है, तो उस मुझे बाय एग्जांपल दिखाना चाहिए फील्ड में करके कि देखो ये माँ नहीं मान रही थी, इसको इस तरह से हमने हैंडल किया तो ये मान गई, ये कम्युनिटी ये चेंज नहीं लाना चाहती थी, हमने इसको इस तरह से हैंडल किया, ये हो गया। आई थिंक दिस इज माय टेक।
I think very apt suggestion जो आपने दिया मैडम, because that is something as you said it is not easy to to do the change in the curriculum. That is not that easy. You can only give it a different shape. Same question अफजल सर, क्योंकि सवाल हमारा सभी से एक ही रहेगा, ये these are suggestions. So बिल्कुल क्विक कमेंट, क्योंकि लगता है हमारे दूसरे जो सेकंड जो हमारा सेशन आने वाला है उनके भी एक्सपर्ट्स धीरे धीरे ऐड हो रहे हैं हमारे। सो बट सर अफजल सर, आपसे भी 2 पॉइंट हम लेना चाहेंगे। अगेन सेम क्वेश्चन, व्हाट वुड यू लाइक टू रिमूव एंड व्हाट यू वुड लाइक टू ऐड?
सम थिंग्स लाइक हमें एडिशन के लिए तो टेक्नोलॉजिकल पार्ट को ऐड करना होगा। अब जो ब्रीड हमारे पास स्टूडेंट्स की आ रही है, दे आर मोर लर्निंग बाय द सॉफ्टवेयर्स, लैपटॉप्स इंस्टेड ऑफ बुक्स, दे आर यूजिंग देयर लैपटॉप्स। तो हमें भी कुछ इस तरह के सॉफ्टवेयर्स डेवलप करने चाहिए फॉर इजी लर्निंग, इंटरेस्टिंग लर्निंग एंड शॉर्ट टाइम लर्निंग के लिए, जो उन स्टूडेंट्स को सूट करे। सो IT शुड बी इंकॉर्पोरेटेड मोर एंड मोर इन आवर करिकुलम। उसकी इंपॉर्टेंस को हम बदलते समय के साथ नकार नहीं सकते हैं। कुछ चीजें ऐसी हैं जिन पे हम लेक्चर्स के अंदर बहुत ज्यादा टाइम खर्च करते हैं, हिस्ट्री ऑफ प्रिवेंटिव मेडिसिन, इस तरह की चीजों को हम अब इग्नोर कर सकते हैं, क्योंकि वो अब स्टूडेंट्स के लिए इतनी इंपॉर्टेंट रह नहीं गई है। स्टूडेंट अब जो आ गए हैं वो मोर एंड मोर एग्जाम ओरिएंटेड चीजें पढ़ना चाहते हैं, जो एग्जाम में आता है, जो मल्टीपल चॉइस क्वेश्चंस में आता है। तो इट हैज टू बी डिफरेंट फॉर द UG करिकुलम, अ बिट डिफरेंट फॉर द PG करिकुलम। तो बेस जो हमारा है UG करिकुलम, उसको हमें थोड़ा बहुत रीमॉडलिंग करने की जरूरत है, उसको फ्रेशन अप करने की जरूरत है। जैसा कि मैम ने कहा, इट वाज वेरी राइटली सेड, हमें थोड़ा सा रिसाइकलिंग करना होगा। एंड वी शुड फॉर्म एन एक्सपर्ट ग्रुप ऑफ द PSM एंड कम्युनिकेट विद द नेशनल मेडिकल कमीशन फॉर द सेम। तो ओवर द टाइम शायद कुछ चेंजेस हो जाए।
Yeah, and thank you so much, sir. A quick comment, Rupesh, aapse bhi, because as I said, you are the youth of us. Rupesh, are you there?
Rupesh, please unmute yourself.
Rupesh, please unmute.
So whatever syllabus we are having, I'm okay with it, but just we need to have active participation of faculty as well as students. It should be field oriented, it should be field centric activity, and we should certainly curtail the theory portion, and we should give more and more exposure to students towards the field activity. They need to be incorporated in all activities, whatever we are doing as faculty, as departments, in the form of, let it be, suppose we are celebrating any health days, the student must be involved. We can give lot of activities in the form of seminars, quiz, role plays, and any type of competition, intra competition, because our subject is taught in 3 years from first to final year. So we can have healthy competition among the students. We can create such environment as faculty. So I think from my sides, we need to focus more on the field activities, and they should be given more exposure towards our core areas. That
Okay.
is my suggestion.
So your point's well taken. As you said, that field activities need to be increased more and theoretical part,
Yeah.
and then we
Recorded.
back seat. Over to Wasim.
Yeah. Both, I think management part is should be increased in our PG curriculum, as well as digital health. We can include this in the PG curriculum.
Yeah, thank you so much. रेखा मैडम, आपके कमेंट, दो क्विक कमेंट. पहले निकालना क्या है, क्योंकि मुझे सबसे इंपॉर्टेंट लगता है निकालना क्या है, फिर कुछ ऐड करेंगे. आप मैडम म्यूट हैं.
Sir, we should minimize our classroom teaching, and we should increase our hours or days of rotatory, interdepartmental, interdisciplinary field teaching, which must be supervised by a senior faculty, so that a comprehensive package we can give to our student.
Okay, that's great, madam. That's great. So over to Amita ma'am, and then final comment from SD Gupta sir.
So डॉक्टर पंकज, सब लोग बार बार इस बात को एम्फेसाइज कर रहे हैं कि फैकल्टी को पहले अपने स्किल्स और अपने आप को स्ट्रेंथन करना है. मेरा ये कहना है कि ओवर द इयर्स फैकल्टी क्लासरूम और अपने रूम तक रह के पब्लिक हेल्थ करने की कोशिश कर रही है. फील्ड में फैकल्टी ही कम जा रही है. I remember in our days, Dr. Vandana Sen, Dr. SD Gupta sir, Dr. Joshi, all senior faculty members. I was senior demonstrator, and these people were with us in the our Urban Health Training Center and RHTC in the field with the students. While these days, even if you ask a senior demonstrator to go there, he will send a PG. And HOD cannot be there at the field every time. So this happened. This is happening. We have to bring a change here. I don't know how, because even good leadership cannot overcome the lust of power with, I shouldn't be saying all this, but yes, I need faculty to be strengthened in field work, because if they give their own fieldwork examples to the students while teaching, they have the strength of hitting the target, going inside the heart of the children. Because I know if I give them example while I was doing this, a person said this, and I counteracted, and I said this, and they had brought. Because I have seen Dr. T.P. Jain speaking to the prostitutes, and that changed my whole perspective. I was very anti-PSM. I never wanted to stick to the department. And he told me that you are such a good communicator. You have good language. You have this and that. Chalo mere saath. He took me in the field, and then I saw how he changed the whole thought process of those ladies. And that gave me a perspective that if I can change people to think अगर मैं लोगों के दिमाग में परिवर्तन ला सकती हूँ तो मैं उनके जीवन में परिवर्तन ला सकती हूँ. तो ये सब्जेक्ट सबसे अच्छा सब्जेक्ट है. बट आई एज अ टीचर might not have been that successful कि मैं अपने स्टूडेंट्स को इतना सिखा पाती. आई होप कि कुछ ने सीखा होगा.
मैडम नहीं, ऐसा बिल्कुल नहीं.
व्हाट वी नीड टू डू कि फैकल्टी जो है वो कम्युनिटी में जाए, कम्युनिटी में काम करे. कमरे में डेस्कटॉप पे बैठ के टीचिंग लर्निंग नहीं होगी कम्युनिटी.
Absolutely. Thank you so much, ma'am. Again, the point comes to experiential learning, and again, lead by example, as you said, that with all these examples, which we do in field, will help to make this subject better. And I think to the best of its capacity, as every one of us saying, needs a kind of a change in public health practice. Final comments, Gupta sir se lete hain before we leave the session for our next speakers.
Just few quick comments, Pankaj and colleagues. One is, Amita is rightly pointing out, let us focus on, let me use a formal term, what she is saying, is the faculty development part, right? So I think we need to create a program for faculty development in Rajasthan. And maybe AIMS may be having funds. If they don't have fund, I volunteer to spend money from my institute to work on faculty development. I'm really concerned about it. Second important thing is personality development and soft skills in the faculty. These are required, soft skills. From technical point of view, I think we must go beyond park for epidemiology.
सर पार्क से हट के लोग गॉडेस पे आ जाते हैं. उससे
ऊपर गॉडेस is also very fundamental sort of stuff.
That is what I'm saying. वहां से हटके तो
Dr. Goddess was my teacher and my mentor. He took me for PhD and I taught with him for 3 years. So all this what is written, he used to teach us and we used to teach. So that is a very good book for learning epidemiology, but that is very basic.
For UG.
For UG and even for MD people. But they have to go to applied epidemiology. Let's build those skills. That's very important. I think this is the time for public health practice.
Yes.
Promoting public health practice and building skills.
Yeah.
Not only in the faculty, but also among students of community medicine. That is the second thing. What is to remove? I tell you what has been done. We teach still water, we teach sanitation, we teach pollution, air, all this. Can we do applied aspects of this? People are talking about wash. Do we talk about wash? You know, what we teach in PSM, now people are teaching again to us in the form of wash. Now, pollution, air, we teach a lot. Kya air temperature hona chahiye, kya atmosphere. Now people are talking about air pollution. They show the photo of India Gate of COVID-19, how sharp and clean it looks because there is no air pollution. There was no air pollution. So I think what we are doing is right, no issues, but we should reduce the details in classroom teaching. Let students read and we deal with the applied part of it. So we have to improve or redefine our learning and teaching methodology. There is nothing wrong with the content of it, but I think we need to redefine our learning and teaching methodology. More focus on participation and self-learning. Self-reading is very important. हम क्या करते हैं इंडिया में, सब कुछ उसके ऊपर उड़ेल देना चाहते हैं. अरे छोड़ दो उसको. He is a grown-up man. Let him read. Let's focus on applied part. Let us focus on practice part of public health or community medicine. So nothing to throw out. Everything is important, but let us change our methodology. Let's leave it to the students to learn themselves. What we do, we facilitate and we talk about applied aspects. आज जो आपका MD में निकल कर जाता है, वो अभी भी अनफिट है हेल्थ सिस्टम में, क्योंकि उसने तो किताब में पढ़ा है, वो पढ़ा नहीं है जो हो रहा है. Applied part नहीं हो रहा है. So these are some of the ideas. I'll be very happy to help in faculty development and even soft skill development. We can find out people, get the consultants, and we can have Zoom meeting for soft skills development. No issues. I will arrange the resource persons. Don't worry about it. but have such online training for faculty development, for soft skill development, for leadership development, all that. I volunteer for this.
Thank you so much. Thank you so much. I think the very purpose of this meeting, which we thought to take the opportunity and the platform for bringing all community medicine people together in this platform of our conference, Eficon 2021, is I think with the final words of Dr. Gupta, wo hame lagta hai humne pa liye. When the kind of thing which he said is very important, these faculty development, we need to develop ourselves, capacity ourselves, we need to work on, and there are people to help us out to get their capacity. Thank you so much all for joining. We have a lot of questions in the chat box, but in the interest of time, we are not able to take questions because the next session is in line. That's a very interesting session on tobacco cessation. We have with us all the experts. And before I leave, I take this opportunity to thank all the panelists who have joined us from all the parts of Rajasthan and has allowed us, All India Institute of Medical Sciences, Jodhpur, to host this meeting. And you allow us, you permit us to have these questions and you answer all those questions. That's an important thing. हमारा पहला एक छोटा सा एफर्ट है और हम ये सोचते हैं कि आने वाले टाइम में हम इसे जारी रखेंगे और हमारा ये जो ग्रुप है जहां हम बात कर रहे हैं एक्सपीरियंशियल लर्निंग की capacity building की वो जारी रहेगी. Thank you so much once again. Thank you so much all the participants.
All the best, Pankaj ji.
Thank you. Thank you.
Thank you,
Thank
sir.
you. All the best.
Thank you, ma'am. Thank you so much.
All the best, boss.
Thank you, sir.
And congratulations for successfully organizing this meeting.
Thank you so much, sir. Thank you so much.
Thank you.
Yes, sir.
Pankaj, can we leave now?
Yes, yes, sir. Yes, sir. We may leave and over to the organizers, my colleagues in the hall to take to the next session.
Thank you so much.
Thank you.
Good evening, Dr. Pankaj. I would just want to quickly check with you if Dr. Chuni Lal or anyone from AIIMS Jodhpur is about to begin the session. Hi, good evening, everyone. I just wanted to ask if there's anyone from AIIMS Jodhpur who is about to introduce, or should we proceed now?
Yes. Hi, Shivam, we are joining.
Good evening, everyone. I, Dr. Aarti, on behalf of the Eficon team and AIIMS Jodhpur, welcome you all to the sessions on landscaping tobacco cessation, now or never. Today's symposium would be moderated by Dr. Shivam Kapoor. Shivam Kapoor is working in the capacity of technical advisor for Stop Tobacco Organizations and Tobacco Products in the Union. The Union is a membership organization. It is established in 1920 and is led by people who are committed to its vision, healthier for world for all, free tuberculosis and lung disease. Dr. Shivam Kapoor's key focus areas include monitoring tobacco industry in India and is involved in stopping tobacco organizations and products campaigns. He is also involved in carrying out operational research in tobacco control. Previously, as a technical advisor, monitoring and evaluation, he has been involved in strengthening National Tobacco Control Program in India. Research coordinator at the Union, he led 2 multi-centric research projects in collaboration with Johns Hopkins University on film rules compliance and brand stretching in India. Trained as a public dentist at the 2 leading Indian dental institutions, Government Dental College and Research Institute, Bengaluru, and Manipal College of Dental Sciences. With his experience at Maulana Azad Institute of Dental Science, New Delhi, he worked and excelled as a public health professional and tobacco cessation counselor in both clinical and community settings, and also contributed in the National Oral Health Program under the aegis of Ministry of Health and Family Welfare, India. His research work is published in various leading national and international peer-reviewed journals. I humbly invite Dr. Shivam Kapoor to welcome the chairpersons.
Yeah, thank you for this generous introduction. Good evening, good morning, good afternoon, everyone, depending on wherever you are. I welcome you on behalf of the union and on the behalf of Eficon 2021. So the symposium at hand today is Landscaping Tobacco Cessation Now or Never. The format of the symposium is a hybrid model. We are going with 3 recorded sessions, and after that we'll be having a live session also. We have our 2 chairs with us today. I would take this opportune moment to introduce both of them. Can we have the slide of the first chair? Meanwhile, the objective of the symposium is intended to help participants gain broader understanding of advancing cessation in the country, to advance tobacco control at both national, sub-national level. More specifically, it will seek to orient the participants about epidemiology and public health challenges, opportunities in tobacco cessation in India, build capacity around the existing provisions under the National Tobacco Control Program, and use of appropriate technological aids, eventually leading to tobacco endgame. We have our 2 honorary chairs with us. Dr. Rakesh Gupta, sir is honorary consultant at the Santoba Durlabji Memorial Hospital and Medical Research Institute. Sir is former associate professor in surgery and cancer surgeon and director American Cancer Society, Tata Memorial Center and Hospital Alumni of Mid-80s. He's been working for 3 decades in cancer, and with his immense experience in cessation, he's an advocate, a master trainer, and a practitioner as well. He's a WHO Director General Awardee, member of Asia Pacific Journal Network of Quitline since 2012. He has implemented public health models on smoke-free cities, tobacco-free workplaces, systems approach in cessation, with more than 50 scientific publications and over 100 national meetings related to tobacco control and cessation. Sir has authored 2 books in Hindi, compiling his own 145 write-ups on tobacco control. Next slide, please. We have with us Dr. Ratan K. Srivastav, sir. Sir is Deputy Director, COVID Team, Uttar Pradesh from Mamta Health Institute for Mother and Child, former HOD, Community Medicine, BHU. Sir has been alumni of London School of Hygiene and Tropical Medicine and London School of Economics. He's the teaching community medicine with his vast experience of more than 40 years and around 80 publications. He's carried out research in various projects funded by UNFPA, UNICEF, Government of Gujarat, USAID, ICMR, and WHO. Sir has authored a chapter on diabetes and has area of expertise in telemedicine, epidemiology, health service research, health program evaluation. Sir has also been associated with tremendous experience in maternal anemia, maternal and anemia control under RCH program, nutrition, leptospirosis, medical education. Sir was also a president of IAPCM at the national level and Secretary General of Indian Society of Hypertension. I welcome both of you, sir, and we are pleased to have you today. Over to you, sir. Please say a few words and introduce our speakers.
So, Dr. Ratanji, can you want me to go first?
Dr. Rakesh, आप बोल लें फिर मैं बोलता हूँ.
All right. So welcome participants and my esteemed colleagues who will be making the presentations. I have just a few things to say. One thing I would say is the title of the session should have been Tobacco Cessation Now and Hereafter, because it is not now and never, because we will need tobacco cessation delivery for a long time in the country, because the number of current users as per the Global Tobacco Adult Tobacco Survey. Second, we have nearly 25 crore current users of tobacco. So we have a huge need in the country. We also know that tobacco cessation helps immensely to reduce the burden of tobacco in the country and also the resultant illnesses and the deaths. And you may be knowing already, but let me reiterate that India is suffering from about 4,000 tobacco-related deaths daily. That means about 1.5 million deaths in the country every year. So it's a huge burden. And therefore, we need tobacco cessation on priority. And I consider this is a very, very useful platform for and a good initiative which has been taken by our epidemiologist. My own mentor in tobacco control, Dr. Prakash Chandra Gupta from Mumbai, Halis Sexaria Institute. He has definitely not only taught many of us in tobacco control, brought us in, nurtured us, but he has also shown us the importance of epidemiology. And I consider now here is the entire mass who can make a difference by the implementation and application of the teachings you already have in epidemiology as to how epidemiology can help in enhancing tobacco cessation delivery. And I was hearing the speakers from the previous session, and I think one of the key things which has come out is that there is a need to go in the field and do the work. And who else can do it better than you guys? So all very best wishes, and I'm looking forward to hear from our esteemed colleagues as well. Over to you, Professor Ratanji.
Thank you, Dr. Rakesh. I think you have been working over there for many years in tobacco also, so you know many things. I was exposed in Surat or in some areas and had experienced this tobacco smoking. What I feel is a behavior basically. I have seen like as a pastime. If somebody is sitting just free and waiting for somebody, so he will think what to do now. So he will just take out a cigarette, he will burn it, and then he will throw, you can say, push smokes outside. So it's basically habit forming things. That is one thing. This is what I personally feel. Now, one good thing has happened that WhatsApp has come, Facebook has come, and mobile has become so that people can get addicted to it and they can think of leaving tobacco smoking. This is one thing. And so I think some sort of addiction, like even chewing tobacco, that also gives you a some, I think, knock also in your brain. But if we develop something to eat like elaichi in a flavored form, so in place of tobacco, people may eat elaichi. Or what I have seen these photographs, like health education, when they are fixing, I was worried, and I think companies were worried that if we will put a photograph of cancer, people will be scared and they will be fear from that and they will not smoke. But what I have seen, interesting thing, now it is printed and nobody watches on it. So means continuously if something is, same thing is printed. In one country I was reading that every 6 months they change the photo, they change the style. So many students, they collect it also as a hobby. So I do not know, more experiment is required. So today we are having a lot of expert. Dr. Sonu is here and he's going to tell us the very interesting epidemiology on tobacco cessation. Let us see what he gives latest information. Then Dr. Vikrant is there. He's going to speak on public health challenges and opportunities to tobacco cessation. So it's again a very interesting topic. Then Dr. Shivam Kapoor himself is going to speak on tobacco cessation under National Tobacco Control Program and role of technology. So I think all will be very interesting. I was just reading, sir. I found that tobacco contains more than 4,000 harmful chemical substances.
Very right.
And this is too much. 4,000 is very large figure. I was not aware of that so much. And I think there may be so many things to speak, but I will keep now silence. Let my expert speakers to speak.
Okay.
Okay.
So I take this opportunity. Kindly show me the screen for introducing Dr. Sonu Goyal. Dr. Sonu Goyal is a professor in the School of Public Health, and he is a professor, and he is also the director for Resource Center for Tobacco Control at PGI Chandigarh, and he is a person of international eminence He is MD Community Medicine and PhD in Human Resource Management. He is Adjunct Associate Clinical Professor in the School of Medicine, Faculty of Education and Health Sciences, University of Limerick, Ireland, and Honorary Professor in the Faculty of Human and Health Sciences at Swansea University, United Kingdom. He has over 20 years experience in public health and formerly held an additional charge of Deputy Medical Superintendent and Purchase Officer at PGI, Chandigarh. He has over 120 papers published, has authored 38 chapters and produced 12 films on national health programs and edited many public health books. His awards include the Young Researchers Award by IAPSM Ford Foundation, Harcharan Singh Oration Award, Vasudev Oration Award, and many more to his credit. Visiting faculty, he is also visiting faculty of many international universities and vice chair of Tobacco Control Section and leading Empower Research Group of the Union. To summarize all this, let me say that he is the thrust force behind tobacco control currently in the country, and he is the epicenter for energizing all of us in tobacco control. And we have a lot of faith actually in him that he will take tobacco control to the newer heights. And I always feel that his day is of 48 hours, not 24 hours, the amount of the work that he does. Next, please. Professor Ratanji, I will say, please introduce Dr. Vikrant Mohanty. Kindly unmute yourself.
Okay, yes. So should I introduce about Dr. Vikrant?
Yes.
Okay.
Yes.
Dr. Vikrant Mohanty is professor and project head and principal coordinator, Department of Public Health Dentistry in Maulana Azad Institute. And I think chewing tobacco and many things lead to dental health. So he is a very appropriate expert. And he has been principal program coordinator at National Resource Center of Oral Health and Tobacco Cessation at MAIDS initiative funded by Ministry of Health and Family Welfare. He was medical officer in charge, mobile clinic project under NHM. Largest mobile dental clinic, he had that experience project in India. He is recipient of IGTC scholarship and completed his global tobacco control program at John Hopkins Bloomberg School of Public Health. This is very reputed international institution. Very recently received the UK India Education Research Initiative to visit Institute of Dentistry under Queen Mary University of London. I think this is again a very reputed. He has published more than 50 articles in national and international journal. So certainly I think we will be very happy to listen such an expert, such an experienced and learned person. Sir, so our next speaker will be over to Dr. Rakesh.
Dr. Ravi Mehrotra is the founder for Center for Health Innovation and Policy Foundation at Noida. Professor Mehrotra's expertise covers the gamut of cancer prevention, the state-of-art diagnostics and treatment. He was founder, CEO of the ICMR India Cancer Research Consortium and directed the ICMR National Institute of Cancer Prevention and Research and ICPR at Noida. He is MD, DPhil, and has fellowship of the Royal College. He is on the editorial board of 10 international medical journals, has published over 200 scientific articles. He is also the awardee of Dr. PNYE and Dr. Lachman Awards in Cancer Prevention and the Ernest Fernandez Award of Indian Academy of Cytologists, in addition to being its past president. He has established the WHO Knowledge Hub on smokeless tobacco during his tenure as the director of NICPR. He has contributed to the several key global policy and technical documents on cancer as committee members at the International Agency for Cancer Research. And currently, let me also add that he is also one of the PIs to the ASTRA project, which is working on the smokeless tobacco control in the South Asian region. So may I request now the Jodhpur Center for providing us with the recordings of all the speakers.
Yeah, request the team to play the recordings in a row all the three of them. And after that, we'll have the live session with Dr. Ravi. Please begin with the recorded sessions. Thank you. Dr. Chunilal, Dr. Gauri, is there any issue with the recordings?
Same, shall I play?
Sure. Shami, you begin playing the first recording. That'd be great.
Of Dr. Sonu.
Please, just, I hope you have the sharing rights here.
While they are going to share the recordings, in the last session, I found that majority of the people were speaking in Hindi. So are we supposed to speak in Hindi? अगर ऐसा है तो और भी अच्छा है, क्योंकि बोलने में थोड़ी सी आसानी हो जाती है और उसमें शब्दों का चयन अच्छा हो जाता है और अर्थ भी जो है वो हम ज्यादा अच्छे से दे सकते हैं. तो ऑर्गेनाइजर्स बताएं प्लीज कि हमें क्या करने की जरूरत है.
सर अगर यही रिक्वायरमेंट था, आई थॉट पहले ही बता देते तो हम भी रिकॉर्डिंग भी हिंदी में ही कर लेते सर.
जी बिल्कुल.
We went on with the most possible evidence, as well as talking about how we can motivate. Otherwise, it would have been much more simpler and easier for people to understand actually.
Yeah.
मुझे भी ऐसा नहीं बताया गया था, but I think now we can discuss.
Never mind. Post recording display, we can definitely talk in Hindi.
Shami, is everything okay while playing the recording? Yeah.
Hello to everyone. Today in this important session on tobacco control, I'll be talking about epidemiology of cessation. I am Dr. Sonu Goel, a professor of health management at Department of Community Medicine and School of Public Health, Postgraduate Institute of Medical Education and Research, Chandigarh. This topic is even more important considering the fact that the World No Tobacco Day theme has focused on commit to quit. Most of the audience might be aware about the harmful effects of tobacco use. However, many of you might not be aware about the fact that tobacco is the only legal product in this world or on this earth which kills half of its users. In low and middle income countries, 80% of world's 1.3 billion tobacco users, more than 8 million people consume tobacco annually, out of which 7 million are direct tobacco users and 1.2 million are indirect or are exposed to secondhand smoke. Around 2.5 million disability adjusted life years are lost due to tobacco use, out of which around 148 million disability adjusted life years are lost due to smoking. As per the Global Adult Tobacco Survey conducted in 2016-17, the largest tobacco survey which is being conducted after every 4 to 5 years, it says that around 26.7 crore people in India, adults, out of 97 crore adults are tobacco users, out of which around 20 crore people use smokeless tobacco and 10 crore people are smokers. Around 3 crore people use both smoking and smokeless tobacco. So this translates to around 28% population of adults using tobacco. If we go with the Global Youth Tobacco Survey, 2019, which was conducted in youth aged 13 to 14 years, we have around 8.5% of youth which are consuming tobacco. And you can see the Arunachal Pradesh, Mizoram, and most of the Northeast states have as high prevalence of tobacco use among youth to the tune of around 58%. And Himachal, Karnataka, Goa, these states are having the prevalence of around 1 to 2%. So at the global level, we have certain policies which are focused on tobacco control. And the major policy which we are talking about today is WHO Empower policy, which says M is monitoring tobacco use, P is protecting people from tobacco smoke, that is secondhand, preventing from secondhand smoke. Third is offering help to quit tobacco. Fourth is warning about dangers of tobacco by means of the warnings on cigarette packs or maybe on movies, and forcing ban on tobacco advertisement, promotion, and sponsorship, and raising tax on tobacco. These are the proven strategies for tobacco control. And one of the important strategy which we'll be talking about today is the offer help to tobacco, quit tobacco. Now, the good part, which is there in the slide, is that most of the tobacco users want to quit. If you see on the left-hand side, the Global Adult Tobacco Survey, which is conducted in 16-17, says that around 55% smokers are planning or are thinking about quitting. And almost similar percent, that is 50%, smokeless tobacco users are also planning for quitting. This means around more than every 1 in 2 adults are thinking about quitting. On the right-hand side is the figure of Global Youth Tobacco Survey, which also states that most people want to quit because they want to improve their health. So that is important for all of us, public health professional and the clinical professional, that if we just say about the health, so that your health will be deteriorating, so we can have more people who will quit tobacco. And the green part, which is there in this slide, is the tobacco quit line, which is one of the good practices in India. People were not aware about it. Only around 4 to 5% people have actually called tobacco quit line to quit. And around 16 to 18% of the youth have actually heard about it. So we need to do more so that people know that there is a tobacco quit line, which is free of cost service available by Government of India. The National Family Health Survey, another survey which is being conducted on at the national level, also says that around 30% women tried to stop smoking or using tobacco in the past 12 months, and around similar percent men, smokers or tobacco users, tried to quit. So this is again an encouraging figure that they have tried to quit but may not have quit. So they are our potential for cessation. Let us come to the global figures now. You can see that the countries like Botswana, Senegal, Mexico, Kenya, around 70 to 80% of these countries, smokers, are intending to quitting. If you go to our previous slide and also in this slide, it is showing that in India it is 50%. But many countries are above India. You can see India down the line, but you can see not many countries like Uruguay, Costa Rica, Argentina, most of the African countries and most of the countries which are in South America, they also want to quit, intend to quit. This is another good thing in this slide, that the countries with highest level of achievement, they are the best practice country in terms of tobacco dependence treatment or availability of tobacco dependence treatment. And India is one of them. Other countries, India is joining in line with Australia, Brazil, Canada, Ireland, Kuwait, Mexico, and Singapore. So these are the countries which are mostly there in the US, Europe, and the countries which have the tobacco dependence treatment. So India is one of them. So that is one of the good things which we have. Here you can see that most of the high income countries, which is being shown by the top line, that they are incorporating cessation support in their primary care facilities. So all PHCs, CHCs, the primary care facilities, 80% of their CHCs have the cessation support. But if you see the middle income countries, only 50%. And low income countries, as low as 15% of them are actually providing support, cessation support in the primary healthcare facility, which is really important. That means the counseling facility and the treatment facility and tobacco dependence treatment facility, everything is there at the primary healthcare level, which we want. From 2007 to 2018, we have seen the progress in tobacco dependence treatment, but that is relatively slow. You can see that in 2018, nearly 23 countries out of 195 have actually had tobacco dependence treatment, although the coverage of population is 2.4 billion out of 7.6 billion, but we have only 23 countries where we have tobacco dependence treatment. Same thing is there with the National Tobacco Toll-Free Quit Line. These are the toll-free number which assist the tobacco users to quit. So if you see the high-income countries, 70%, the percentage of world population covered by National Toll-Free Quit Line, 70% of the high-income countries or population living in the high-income countries have National Toll-Free Quit Line. In middle-income country, around 51%, and in low-income country, we don't have virtually the tobacco-free quit line. So a lot of inequity as per the WHO report on global tobacco epidemic. This is another interesting figure. You can see there are two lines here, the green line and the blue line. The blue line represents the cheapest NRT option. These are the treatment which are there for tobacco use. And on the green line, it is the cost of smoking 20 sticks per day, the cheapest brand of it. So you can, it's a very interesting figure. You can see in high income country, the NRT option is available very cheap as compared to the cost of smoking. So this is good in fact, but in middle income country, they are almost equal, or the cost of smoking, the cheapest NRT option is relatively higher as compared to the cost of smoking. So this means the NRT availability is less affordable than the cost of the cigarettes. So that means the people are not going to get. So either we need to decrease the cost of smoking by increasing taxes, or we have to increase the cost of smoking, or we need to reduce the cost of the NRT. Only then people will be able to avail this NRT. And on the right hand side, we can see that these are the policies and structural capacity for national tobacco cessation support. And you can see on the center line, the tall line, the disease-specific guidelines are present in almost all countries. But the tobacco use in medical facility and the quit line on warnings or campaigns are quite low. So this means there are few things which are quite high in the countries, but few things which needs improvement. This is another interesting slide before I come to the end of this presentation. You can see here also on the left hand side, the bar shows that in the high income countries, we have national quit lines and both NRT and some cessation services cost cover. But if you go to the same thing in the low income country, these services are not available free of cost, or these are not government sponsored. So this means that people cannot avail these services unless they are quite rich to pay. Again, NRT or some citizen services, at least one of which is cost covered. 37 countries are having that in high income, and which is quite less even in the low income countries. So this, the crux of this slide is, we in the low and middle income country do not have either the national quit line, or they are present, the treatment or the NRT is not cost covered by the government. Now, these are my take-home messages from the presentation. The comprehensive tobacco cessation services are in place for around 2.4 billion people in just 23 countries. So although 32% of the world population is covered by these services, but we need to increase it more. Only 24% of low middle income country offer any cost coverage for services. So around 24 countries are there that provide no cessation support at all. So that means that their people will not be able to afford these services. So we propose that at a minimum 3 cessation interventions should be included in a comprehensive tobacco cessation program. The number 1 is the brief cessation advice in the primary care settings to the tobacco user. So counseling facility should be there. Second, there should be national tobacco-free, toll-free tobacco quit lines. So that is also important, and that's the need of the hour, and that has proven to be a good practice in many countries, including India. And third thing is the pharmacological therapy, and very least include this NRTs, which is very important, and that should be available at the cost of the government. So I urge anybody who is your friend or family member, if they are smoking or taking tobacco, I urge you to convince them or counsel them to quit tobacco. Right? Thank you.
Thank you, Dr. Sonu. That was a very enriching and enlightening session. It's always a pleasure to listen to you. Now I would like to invite the chairperson to talk about the next speaker, Dr. Vikrant Mohanty.
He has already been introduced. Kindly go ahead with his record.
Right.
Hello, everyone. At the outset, I would like to congratulate Professor Pankaj Bharadwaj, the team from Department of Community Medicine and Social Medicine at All India Institute of Medical Sciences, School of Public Health, and all the organizing committee members for this wonderful event on Eficon. Thank you, Dr. Rakesh sir, for this opportunity, and Union, primarily Dr. Rana sir, who has been instrumental in bringing tobacco control across the country into every healthcare institution that we see today. And the team from Union, Dr. Shivam, and everyone who's coordinating this event. So today I will be talking about public health challenges and opportunities in tobacco cessation in India and role of dental professionals. So before we jump into understanding why tobacco, because we're talking about the landscape of tobacco cessation, we also need to be aware that tobacco cessation is not a one-stop solution or something which can just work as soon as you render it. It is a consistent as well as a very consolidated effort, which takes a lot of commitment, not only from the patient's side, but also from the healthcare professional's side. So it is important for us to understand that if tobacco cessation was so important, why hasn't it not been given the due recognition? We all are aware of the Empower strategy under the FCTC, that is the Framework Convention of Tobacco Control, which talks about the Empower strategy, wherein the Empower basically focuses on both demand as well as supply side components of tobacco control, of which one of the important components is the O, that is offer cessation support. If it was so important, it has been overlooked, orphaned over the years. So it is important for us to understand that if you want a tobacco control to be effective, a comprehensive approach from all sides would only lead to certain outcomes. So tobacco control means a range of supply, demand, and harm reduction strategies that aim to improve the health of a population by eliminating or reducing their consumption of tobacco products and exposure to tobacco smoke. So there are certain non-price measures, methods which are there to reduce the demand for tobacco, of which cessation or tobacco use dependence treatment is one key and very important aspect. We all know tobacco is addictive. We all are aware that nicotine plays around and controls the brain whenever it comes to de-addiction. So for us, it is very important to know that why tobacco cessation would be helpful. So the key objectives of any tobacco control program is to discourage the initiation. That means new users should not be there, as well as to facilitate so that the existing users, get the necessary services that they want. The strategy of tobacco cessation is neglected as a part of tobacco control globally and made only in very insignificant progress has been made. So what are the challenges? We need to realize that tobacco cessation, as I told you, is not a one-stop solution, is not a one-time intervention. It needs consistent efforts. So there are a lot of challenges that we need to understand that we can come across. So what are the barriers to tobacco cessation in India? In comparison to other forms of substance abuse like alcohol, narcotics, cessation related to tobacco does not get its due recognition when it comes to political agendas. Further, tobacco use is normalized. A drug addict will be stigmatized, but a tobacco user will never be identified as a stigma or a kind of, it is normalized. It is accepted in the community to smoke or to chew. So we need to work on how this, we denormalize the whole tobacco as a problem in our community. Even if cessation services are imparted, they're only imparted at certain centers. Many centers are there which claim to be providing cessation, but not in a structured or in an evidence-based manner. Many of them claim that they have proven track records of 75-80% quit rates, but I fail to understand most of the research also does not support such evidence. A national average ranges between 5 to 10, and in some places, certain consistent efforts have shown improved outcomes. Further, the challenge is that many of our healthcare professionals are burdened with multiple responsibilities. So it is very difficult for everyone to talk about tobacco. Sometimes it is so they're so focused on treating the disease, they forget to take a proper case history which would elicit such behavior. Also, preoccupied presumptions that quitting tobacco or smoking is difficult. And however, studies have reported that quitting was less traumatic as expected by many smokers. They have a preconceived idea in their minds that we can quit it. You must have heard of this saying that I have quit tobacco or smoking more than 1,000 times. That means he has gone back. Tobacco is addictive in nature and always brings you back into that vicious cycle. Further, cessation has been glamorized by many other pharmaceutical as well as tobacco industry, because now they have started providing cessation tools as well as products which aid in cessation. So the industry is always out there devising newer strategies to target its audience. So the available or the opportunities in tobacco cessation could need a more comprehensive multi-pronged approach, of which involvement of different stakeholders from the healthcare professional is important. And dental healthcare professional, ladies and gentlemen, let me tell you, is a huge workforce available in our country. And if they are trained and oriented in the right way, this orphaned offer to support can be converted into an opportunity which can be utilized as a very important and consistent service by our dental professionals. The dentistry has come over time. It has become more socially responsible, culturally competent. Now, most of the dentists are practicing evidence-based practice. The expectation from a dental professional is much more than it was before. People expected a dentist would only pluck out a teeth. But today, there are many more aspects that dental professionals are able to contribute, whether it is aesthetic, whether it is replacement, whether it is, painless relief or lasers, and many more interventions are there. And with the strong educational component, the future of dentists is very bright. So we need an aggressive approach to focus on health prevention, health promotion, and disease prevention. And that is where the dental professionals need to be guided. So the skills are very much there. The dental professionals have both the hard skills as well as the soft skills. They also focus on critical thinking and problem solving as an approach when it comes to various dental problems. And at the same time, they spend a lot of time talking to their patients, not only during their consultations, but also the chair side time, which we call, and I will be talking more about it, is very much there by dental professionals. So even though we know that dentistry, oral tobacco use and oral diseases are a huge burden and have common risk factor. That means tobacco use not only causes cardiac diseases, respiratory problems, but also causes severe gum diseases as well as oral cancers, pre-cancers, and many more manifestations. Like it also causes the grinding or attrition of the teeth. So there are many reasons why tobacco users would need a dentist support, and this common risk factor becomes an opportunity for dental professionals to actually cash in and at the same time identify these patients. Also, the workforce, as I was just telling you, we have 310 plus dental colleges across the country, 26,000 plus graduates coming out every year, and 6,000 plus postgraduates coming out every year. More than 2.72 lakh dental professionals practicing across the country. So it's a huge workforce which is available, and these guys can contribute if guided well. So there is a better physical access to clinics today, and they are not stigmatized. Visiting a dental clinic is not like visiting a psychiatric center. Maybe individual using tobacco would have a higher psychiatric need, but visiting a dental clinic is more, is just a part of routine practice today because awareness has increased, the demand for the dental services increased. So automatically visiting physically to these places are acceptable by most of them. So the role of dentist is shifting from being just a curative or a focused, treatment-oriented healthcare professional to a more preventive and a promotive healthcare professional. So dental visits, as I told you, provides a teachable moment during the chairside time, which enhances the cessation as well as the interaction between the doctor and the patient. And if this whole, chairside time, this teachable moment is used to the best, it can yield much more better results. So the opportunity screening is one of the very important things. They say the mouth is the gateway of the body. And at the same time, they also say your oral cavity is a reflection of not only what you've eaten for breakfast, but also tells us that what exactly is happening in your body. A simple oral examination is less time consuming, inexpensive, and requires little bit of instrumentation. So it's value for time and money. And a dentist can do this quickly, and as a result of which can identify tobacco users, can provide very quick analysis of what they are looking into once they look into an individual's mouth. So it can be integrated. The whole practice of pre-cancer, cancer detection can be integrated with motivational messages and routine hygiene instructions. And dental professionals become an important resource for them. Further, this was the initial part. If, example, a patient walks in and says that I want to get an implant done, dental implant done, and automatically when we take the medical history, we get to know that the individual is a smoker. And then the doctor says that, the dentist says that, you have to quit the habit because smoking interferes with the healing and the outcomes of implant treatment. The patient is very much aware of the cost of one implant, somewhere ranging between 25 to 30,000, and understanding that if he is investing so much money and at the same time his smoking habit is going to be detrimental to the outcome of the dental treatment, then automatically he has to think twice. So this can be an incentive. So similarly, there are many such treatments which actually dentists can utilize and capture and make use and sense of with the patients that they're working with. Further, dental professionals come across all age groups, from a child to an elderly. All of them will visit a dentist. The scheduling of patients, because dental treatment is never one time again. You require multiple visits. Similarly, cessation is also with multiple. If you're able to integrate these things together, the outcomes could be better. And to make patients, the whole make understanding or the whole idea of making oral health and general health in an integrated package is best provided by a dental professional. So if these kind of packages are developed, which can address different needs of an individual when it comes not only to treatment, but also to quitting a habit, it will be great. So all these things are actually supported by evidence. There are more than 6 studies wherein the odds ratio of a dental professional's intervention, for quitting over 12 months has shown greater odds ratio, and the quitting has been more favorable. So there is a Cochrane review which talks about how dental settings are in a unique position to help tobacco users quit habit. So these are the strengths, challenges, opportunities, and threats that dental care professionals can actually, make use of it, and at the same time need to look critically while providing cessation. Some challenges that we need to understand that the number of clinical trials that are done, whether it is a healthcare setting, whether it's a dental care setting, whether it's a community setting, are very few when it comes to Indian context. Today, training has become very amiable, very much approachable, and very much available. But still, uniform standardization of training is not there. Further, dental healthcare professionals, like other healthcare professionals, are more focused on treatment-oriented outcomes. At the same time, the time available for such sessions or such interventions are low. For no dentist, is aware of how much do they charge for a counseling session or a cessation intervention, whereas they know how much they would charge for a restoration, for an extraction, for a root canal treatment. So we have to keep these things in mind while we are thinking that how dental professionals can be roped in. Further, no one walks into dental clinic saying that, hello, I need to quit the habit, can you help me? So that kind of challenges are there, wherein dental professionals need to promote and propagate their own role, as well as contribute themselves as a healthcare professional, as a moral responsibility into the community, so that they can help the patients. Otherwise, dental professionals can make their workplace tobacco free by displaying posters, by the signages. They can, display quit line, the national quit line, which is there, can be displayed, and the M Health intervention, which is there, can also be displayed. So, keeping all this through this topic that I've just discussed, we have talked about how offering cessation has been orphaned, and how that orphan can be used as an opportunity if dental professionals are roped in. So there are certain challenges. I just now told you about how this intervention can be overcome. We need more structured training. We need dental professionals to prioritize their work. They need to be motivated. All of them need support, whether it's a dental professional or as a healthcare provider. And we need to adapt local context linking tobacco use to dental treatment, so that the outcomes are not only good on oral health, but also on general health. So dental healthcare professionals can play multiple roles in capacity building, behavior change, communication, research, community programs, clinical care, as well as being advocates of change when it comes to tobacco cessation. So to conclude, dentists are instrumental and an untapped advantage which have been missed out. Integrating them at the grassroots would yield great results. Reinforcing with screening and diagnostic tools would actually provide individuals as well as patients to recognize the dental problems, and rendering tobacco cessation across age groups by improving the awareness and cessation through various campaigns by dental professionals could really see a much more drastic reduction in the tobacco use consumption across our country before the GATS 3 that we're looking at. So thank you everyone. Together everyone can achieve more. I thank the chair, Dr. Rakesh Gupta sir, for this opportunity, and I hope if there are any questions, I'll be eager to take them ahead.
Thank you, Vikrant. Thank you, Vikrant, for your nice and lucid presentation. May I request the organizers to go ahead with the third recording from Dr. Shivam Kapoor.
Good evening, good morning, good afternoon, everyone, depending on wherever you are. I am Dr. Shivam Kapoor from the Union, and it's my privilege to be with you all here today. I've been given a topic on tobacco cessation under the National Tobacco Control Program, and I'll be covering it under the following contents. So friends, we know by now the need for cessation is in India is huge, with a prevalence of 28.6% among all adults, and with smokeless form of tobacco being the prime users in India. But what is the gap when we talk about cessation demand versus healthcare professionals giving them advice around it? So nearly 1/3 Indian adults are using tobacco in some form. More than half of them are planning or thinking to quit, whereas less than half are advised by the healthcare providers to quit. So this is the gap which we have found in the GATS2 report. Talking about today's scenario, why it becomes all the more important is, since we already have a background that tobacco is a major risk factor among a variety of non-communicable diseases. Also, what we found during COVID-19 pandemic, that smokers are more likely to develop severe disease with COVID-19, whereas spitting, the smokeless form of tobacco in public places, could enhance the spread of COVID-19 virus. So that's how this challenging time becomes an opportunity. While the healthcare workers are at COVID-19 vaccination program, it offers an extraordinary opportunity to offer at least brief advice. Now, when we talk about the WHO National Tobacco Cessation System approach, we see that it talks about giving brief advice at basic healthcare level by any healthcare worker will help in prompt quit attempts. Whereas if we move further, including services like quit lines or end cessation services, will increase the likelihood of a successful quit attempts. Whereas the final level could be having medications or specialized treatment curated for the patient. Now, if we talk about these interventions are broadly categorized into behavioral and pharmacological intervention. Behavioral approach at population level could range from brief advice to quit line to end cessation services. Whereas for individual approach, it could be intensive behavioral support or support given at cessation clinic, which along with behavioral support can also include pharmacotherapy. Now, broadly, pharmacotherapy could be nicotine replacement, which is present in the form of gums, lozenges, and inhalers, patches, or it could be non-nicotine prescription drugs such as bupropion or varenicline. This approach can also be classified as a brief advice, which is integrated into the national national programs in primary care services. That could be a minimal approach, expanded approach that can incorporate having quit line or end cessation strategy, which is present in India, and advanced model of intervention can incorporate specialized tobacco dependence treatment services. So when I talked about integrating into the primary care services, I was meaning that when there is a program for tuberculosis or reproductive health program, how healthcare worker can at least incorporate giving brief advice to every individual that comes to them. So that's one example. Now, talking about the topic at hand today, the National Tobacco Control Program that was introduced in 2007 and 8. What was the scenario before that? So until 2001, there was no organized tobacco cessation services in India. So later on, Government of India along with WHO came up with setting up tobacco cessation facilities, which were then called as tobacco cessation clinics, and they were set up at psychiatry, cancer, or surgical cardiology setups, with the support from team from training which was given to these investigators was from Thailand. And by 2005, the TCCs, that is the clinics, were subsequently expanded to 5 more regional cancer care centers. Now, what we see the setup today, which is under the National Tobacco Control Program, it's a hierarchy, 3-tier model. That is the central being at the apex, that is the National Tobacco Control Cell, which is further supported by the State Tobacco Control Cell at every state level. And under that, under the state, there are District Tobacco Control Program, which is mainly headed by the District Nodal Officer, supported by District Consultant. And these are next to them are psychologists or social worker, which are the primary providers that look after the cessation activities. So this is what we were talking about, is the individual unit that is at the district level. Now, if we look at the primary thrust area at NTCP, if we look at that, setting up and strengthening of cessation facilities along with provision of pharmacotherapy is already a thrust area at the district level. So talking about the program, so it came, as I already told you, in as a pilot phase in 9 Indian states, at each of 2 at least districts. So there were total 18 districts initially. The following year it was expanded to another 12 states, so total 21 states and 42 districts. And later on in 2010 and 11, Government of India decided to make most of TCCs self-sufficient and providing training, and till September 2018, the scenario is that all the 36 states and union territories in India have the NTCP functional among all the 612 districts. So under that, at the state level, there is suggestive training activities for the healthcare providers, and roles and responsibilities have been defined. Now, talking about setting up a TCC at under NTCP, the primary step is to have the proper place in there. So preferably a district hospital is considered to set up a TCC, whereas other possible places are also listed in the guidelines of NTCP. These could be tertiary care centers under any NCD program or cardiovascular disease program, and it could be either expanded to a medical college, dental college, or a private clinic or PHC, CHC. Now, looking at the budgetary allocation for setting up a TCC, there's a non-recurring and recurring budget which is given a total of 7,50,000. And if we see here, the non-recurring grant is basically around 2.5 lakh, which is for setting up basic equipment, certain like spirometer, carbon monoxide monitor, and a space enough for privacy. That is the setup. That is one-time investment. And apart from that, the recurring investment could be in training, outreach program, and the salary budget, of course. If we see what is the budget which is given for the pharmacological treatment, it is nearly 2 lakh at district level. If you can see here, I've already mentioned. And now talking about these are the budgetary allocations which are clearly defined. Now, who can actually provide these cessation services? So friends, any healthcare professional with some training like doctors, psychologists, social worker, nurses, dentists, and experienced lay counselor can even give basic services, whereas trained ANMs can even provide simple guidance. However, pharmacological interventions can be only carried out by trained medical practitioners. Now, there's a detailed mention of how the training of manpower involved at under NTCP should be done. So at the district level, the psychologists and social workers are supposed to undergo regional or state level frequent training. As I already told you, there's a separate fund for training that is around 1 lakh. And there are there's a mandate of at least having 4 training programs per year for the community health workers at the district level. So this is the number as I was talking. Now, monitoring for the cessation is also carried out when we see in the quarterly reports of NTCP, how many trainings were done, suppose for tobacco cessation per se, how many TCCs are already existing in the state level, and details of these TCCs. Similarly, the training, number of training, the budgetary allocation, and how much was spent is already given when the monitoring happens. Now, something for you to always go back are the guidelines and manuals which are published under NTCP. These are training manuals for doctors, healthcare workers, and even tobacco dependence treatment guidelines. So these manuals specially focus on the brief advice which should be at least given for tobacco cessation by any healthcare workers. In detail, if you go back, you can see the 5A, 5R approach, the pharmacotherapy which is already given for NRTs and non-nicotine replacement therapy. An interesting look which I really want you to have is on the establishment of TCC guidelines. Here it is a manual which is given for Dental Institute. It talks about the infrastructural requirement, the space, what are the HR requirements, equipments, and how the workflow can happen, the referral system which can be established. This is again a picture of how a TCC simple registration form should look like. Again, this is a template and it could be curated as per your requirement. I know it's very detailed, but of course you can shorten it as per your need, keeping the relevant information. So again, at the end, it is using a Fager-Storm scale, which measures the level of addiction of the patient for both smoking and smokeless. Now, these manual focus on brief advice, and they talk about how a teachable moment for any healthcare worker becomes important. You should really not miss it. Another focus area is community cessation. When we talk about giving basic tips in a country like India, when we see PHCs, so that is every healthcare worker should find that opportune moment, and actually all the ANMs and ASHA workers should be trained to carry this out. So under NDCP, the other two important developments which have happened in the Indian system is the provision of quit line. National quit line is a toll-free number where a person can approach and take cessation services, and M cessation is actually a number where you can give missed call, and over messaging you can actually avail these services. So you can go back to the website and find out about it. Talking about Quitline in detail, it is already functioning in 4 major hospitals in India, and these Quitlines are working from 8 a.m. to 8 p.m. Earlier, the counseling was in Hindi and English language. But if we talk about NIMHANS in Bangalore, the Quitline is actually in 6 languages now, which is a major achievement. Talking about M cessation, this model is already proven successful for India. I've taken it from WHO 2019 report. You can go back and have a look. So around 2.1 million self-registered users have actually been using it, and we found out that an average quit rate of 7% for both smokers and smokeless users in 6-month enrollment, which is very cost-effective strategy. Now, talking about evidence, all of you are epidemiologists out there. So I've taken the study which talks about how the tobacco cessation clinics over a period of time were feasible, and it found out among 34,000 subjects that enrolled from 2002 till date, they found out a cessation of 21% at 2nd month and 18% at the 3rd follow-up. So very interesting study. You should go back and have a read. Talking about future prospects of TCC under NTCP, I think one opportune moment now, which is COVID-19, is how technology has advanced, and something called as digital sickness mapping, which has happened. So I think all these services which should be utilized are having with the counselor a virtual meeting that can be done if you cannot come over time. And other areas are use of artificial intelligence, use of chat bots. So I think these are few interesting studies I'm putting across out there. So this is not done in India, but these AIs are already available on Android and iOS. You can have a look, but some of them are of course paid, but these are something where India can actually focus upon as well. So these are various models how chatbots work. Again, very interesting thing on WHO website which you can find is Florence, which is their commit to quit campaign and use of a chatbot, and similarly they have incorporated use of WhatsApp services for cessation. I'll quickly go through what are the opportunities and challenges now. The opportunities are we have tremendous amount of workforce with us when we talk about so many dental and medical colleges. So mapping of district hospitals and district level TCCs is a must today, because we have so many high medical and dental needs patient coming to us. So having that, capturing that moment for brief history taking is a must. Health and all policy, like I told you, how it can be integrated in other healthcare programs. Training the trainers, ANMs and ASHAs are serving us major health goals these days. So of course training the trainers is of course that opportunity, but the challenges are there are still insufficient NTCP staff. As per the guidance, they are not sufficient. There is lack of research, and I would request all of you to actually focus clinical trials wherever you are among SLT and BD users, especially in India, because we have a lot of them. And also referral system among the hospitals and clinic, it's not that stringent where we really need to focus. Again, a very important challenge before us is tobacco industrial tactics. I would just briefly touch this. how certain newer alternatives which are introduced in the market called as e-cigarette, electronic cigarette, which are actually banned in India now in 2019. I think all of you should be very, very much aware that these strategies are not there for cessation in India. These are already banned, and when tobacco industry promotes such products, you should be already aware. There were a lot of news where certain doctors had already also taken part in such webinars during COVID-19 when Union had monitored. So I think that is something which you should be very vigilant about. So I think that is something which all colleges or clinics could have, having a conflict of interest declaration on their website that they do not support such campaigns or such cessation strategies. So I'll just close with the Commit to Quit campaign. That is the theme for this year by WHO. And I'd be happy to take any further questions from you. Thank you.
So thank you, Dr. Shivam, for an excellent presentation. Very eloquent, very informative as well. May I ask Dr. Ravi Mehrotra to kindly make his presentation? Dr. Ravi Mehrotra, good evening. Are you there?
Yes, I'm very much here, Dr.
Thank you.
Rakesh. Thank you so much
very
for introducing me, as well as Professor Ratan for chairing these sessions, which I think are extremely important. So at the outset, let me also express my thanks to my colleague and fellow researcher, Professor Bharadwaj at the AIIMS Jodhpur and his very efficient team for organizing this Eficon and keeping cessation as one of the topics. Because as has been mentioned by the previous speakers, it is really implementation is proof of the pudding rather than anything else. So that is something which I am very, very keen that we talk about. And today's brief that I have been given is to talk about technology in tobacco cessation. So without further ado, I know time is at premium. So without further ado, let me, my life has been made a little easier by my previous speaker, Dr. Kannan, who has talked about some of the apps and some of the things that are available, as well as my other panelists who have been talking about why it is important, what are the problems that we are facing, and what is the way forward. So with that, I will just outline what I'm going to talk in the next 10 minutes or so. What are the novel, innovative, and personalized digital tools available? Shivam talked about smartphone apps. I'll be talking a little more about them. He talked about WhatsApp. He talked about Florence, which has just recently been introduced by the WHO. The various messaging platforms, quit lines, as well, he mentioned. The role of social media cannot be undermined, especially in today's day. There is so much of controversy regarding that. There are digital transdermal patches and also monitors that are available. There are smart lighters and cigarette cases which you can actually use to keep a track of what is happening. And of course, the very ubiquitous now wearable designing, like kind of smart watches, which can talk about smoking detection as well as quitting technologies. And finally, I'll talk about the virtual reality and how that is coming in very shortly. And the various, and there are many more digital tools, which, as we speak, there's something other keeps on popping up every day. Not all of them are easily available, especially in the LMICs, but many of them already are. And that is what I'll be trying to focus on, especially what's available in India. So let me first talk about smartphone apps. As you know, India has practically 80%, 80 to 90% penetration by the phones, mobile phones, which was, even in the last 10 years, it has practically rocketed, and sometimes it is doubling year on year. A reasonably good majority now, at least in the urban and semi-urban areas, are basically the smartphones as compared to what used to be called the feature phones earlier. The prices are going down, availability is more, and by virtue of it being used not only for communicating between people, but also for entertainment, as well as day-to-day stuff like the Aadhaar Setu app, which has now become so ubiquitous. Till about 3 months ago, it was the maximally downloaded app in the world, in the country, as far as COVID is concerned, and you could not even enter a mall or enter an airport without that particular Aadhaar Setu being updated. So extensive literature review was done by my team, and they talked about more than 80 apps around the world for smoking cessation. However, as has been talked about, 70% and more tobacco consumption in India is actually smokeless tobacco. So there are about 4 or maybe 5 apps currently in use, and I'll talk about that as we go along. What are the pluses, what are the minuses, and where are we to go? There is, of course, the CDC. We talk about quick start apps. There are statistics on one page, and you can actually see both iOS and Android. As has been mentioned, I'll briefly talk about them, looking at some of the pluses and the negatives. So this is an app which I'm personally very fond of. It is called iCan.
Ravi, there is a break in your voice. Kindly check on the internet connectivity.
Your voice is breaking.
Yeah. Let's wait for a minute. It may come back. Can somebody call him for the alternative source that he may be able to use?
I'll check with him. I think he got disconnected.
उन्होंने लास्ट वर्ड लिखा था आई कैन क्विट, तो सिगरेट की जगह नेटवर्क से निकल गए वो. वो न्यू टेक्नोलॉजी में यही प्रॉब्लम है. टेक्नोलॉजी लेक्चर वाज ऑन टेक्नोलॉजी, एंड टेक्नोलॉजी कभी कभी धोखा देती है.
Yeah, very rarely this happens. This pandemic has taught us a lot how to work online, and we have been doing it efficiently, I would say.
Even in the beginning, I was facing connection.
Meanwhile, to save on the time, may I suggest give some inputs until Dr. Ravi joins again. That India is one of the 26 countries out of 192 countries on the FCTC membership, which is being categorized as the country with the comprehensive tobacco cessation services. That means it has toll-free national quit line. It has the tobacco cessation services available at the primary healthcare level. It also has the availability of NRT. And so that's in a way, the pride standing we have in the internationally. But those who are in the country and those who have been in the field of tobacco cessation, we all know as to how deficiencies which we have require the coverage. And I consider therefore the higher use of quitline and another cessation tool which is called M-cessation, which is a mobile telephony application. Both these require registration through the toll-free numbers which Dr. Shivam had given in the presentation. So I will encourage and request the participants that encourage tobacco users you come across to utilize these services more appropriately, because as Dr. Sonu said that the utilization of quitline in our LMICs is just about 2% versus the high income countries where the utilization is 70%. So we need to really take through every medical association, including epidemiologists, the development of the strategies which can take us from higher awareness, which is there now. People know that quitting benefits, if you want to know, if a user quits below the 30 years of age, he saves 6 to 8 years of his life besides saving on the expenses made on tobacco and tobacco related illnesses management. So that I think is very, very important. But you should also know, because most of you are coming from Rajasthan, that in our state medical helpline, the toll-free number is 104, and we have the trained counselors who will be able to provide you the state-of-art quitline services. So if the national quitline doesn't respond in time, which is the deficiency in the terms of infrastructure and human resource that they have, you can also call on the state medical helpline to get the help. And incidentally, this helpline has been serving the users from across the state for almost 8 years. So this is relatively less known, but I think through you it can be made more popular. Also, in the Dr. Vikrant's presentation, he has talked about the opportunities, and it was an excellent presentation in the reference to the dentists particularly. And I think dentists are the best placed people in the terms of healthcare professionals who can provide tobacco cessation. Is Dr. Ravi with us now again? Yeah, very well.
Yes, I'm very much here.
Continue with your
Apologies for the delay.
Welcome.
Continue with your
presentation. Oh, thank you so much. I hope it doesn't go wrong. No. That is what happens in technology. When you don't want things to go wrong, it does, unfortunately.
Please go ahead.
Anyway. Right. So this is an app which I was talking about, in which we can actually, they say you do not go about fighting the urge to quit, but you give into it. And there's a motivational speaker who comes on at every requirement. If you have a thought of stress or other feelings, argument, how to handle this. Similarly, we're talking about smokeless tobacco cessation apps. As I mentioned, there are about 4 or 5. This is the one that the smokefree.gov is actually from the US government. And then Stop Smokeless Tobacco app is from an Astra group, which Dr. Rakesh was talking about, which I'm the co-PI. We talks about, and the best thing, it is in multiple languages, including English, Urdu, Hindi, Gujarati, Nepali, as well as Bengali. This is the only one that I could find in our search that we did, which actually it touches the Hindi and the Indian languages as well. Similarly, there's a Dip Quit Act, again from the US, which talks about dipping, which is prevalent in the US. And then a Quit Spit, which is a self-help smokeless cessation program, which is culturally tailored. When we talk about...
interrupt, sir. Sir, if
yeah,
you're sharing your screen, please, it's not visible at our end.
Oh, my apologies.
No problem,
is that better?
Sir, please.
Yes, it is.
I think it will be now.
So
it's
this
just
is
buffering.
Basically...
Yeah, it's better. Please go ahead.
Okay. So these are the 5 apps which are talking about smokeless tobacco, with again mainly from the US. And the number 2 one, that is the Stop Smokeless Tobacco app, is from the UK, from our Astra group, the University of York. And that is the one which is in Hindi, Urdu, Bengali, and so on. Then the last 2 are actually Dip Quit and the Quit Spit, or again US, which is self-help. And Dip Quit also has a live chat feature and maintains the stats daily. Oops. And this is the smoking cessation app. And there are many of them, as I mentioned, roughly 80, but these are the ones we could actually find. Some of them are free and some of them are paid. And the most common one, that is called the Quit Smoking app, as well as the Livestrong app, are actually free. And all have their pluses and negatives, as I mentioned here. Do they have a website? Is there a patch? Are they on Android / iOS? And has they been, but just 3 of them, to the best of our knowledge, have been actually evaluated scientifically. So the importance of doing a good controlled trial and looking at all the details is, of course, cannot be overemphasized. So what are the limitations of technology? First of all, you have engagement and user retention problem. Quite often it has been shown that more than 2/3 of the people who are downloaded a mobile app use it just once or twice and then stop using it. Apps largely did not connect users to anything outside, for example, a quitline or a clinic, and did not provide opportunities to reach out for family and friends for social support. So there is more consistency needed, as well as interventional components, which would be supported by a registry and consistent set of guidelines, especially when talking about mHealth tobacco trials. Then we talk about various messaging. SMS is very, very ubiquitous, very cheap, and we have bulk messaging systems available within the country as well as outside. So I think messaging has been a program which has not been used as much as it should. So there is a national quit line number, as was mentioned earlier, from 4 different parts of the country. And they have reasonably good results now. Hopefully they'll become better as we go along, as well as they're available in only certain countries. Fortunately, India is one of them. So then talk about social media, and I don't need to go into all the details of Facebook and Instagram and WhatsApp and so on. Young people are heavy users of social media platforms, and they provide an alternative, inexpensive as well as successful way. The problem is these programs have to be geared towards the youth because they don't want to watch boring doctors and dentists talking about why they should quit tobacco. It has to be in something that they can relate to, using videos and using icons. This is something I came across recently, unfortunately not available here so far, which is a digital transdermal patch. So it basically releases nicotine at all times, especially when craving at this timed intervals, craving at the strongest. 75% of smokers have their first cigarette within 30 minutes of waking up. This is one way of consuming NRT by when the craving is the maximum, and that can be actually monitored using a smartphone. Similarly, there are smart lighters as well as cigarette cases, which can actually track support and tracking and support of the smoking personalities. And you have personalized, actionable, and these types are tailored tools. It can help the consumer understand and manage their addiction. And more importantly, provide a platform for consumer to be proactive. Suppose they want to monitor and evaluate, they want to know how many cigarettes they had. When you ask somebody, by nature, they say, oh, I just have 1 or 2 a day. But that often we know very well that is fooling themselves or fooling their spouse or other caregivers. So these newer technologies are available. Hopefully, some of them will survive, and we may see them in India as well. I was talking about smartwatches and wearable technologies. So these gadgets now are getting more and more inexpensive. What they do have is a wristband accelerometer and a gyrometer, basically identifying smoking gestures. For example, you take a cigarette in your hand, but that specific gesture uses a GPS to identify the location, as well as can also monitor heart variability. And I put the references here if anybody wants to go and look at them in more detail. I think that is the way of the future as well. Lastly, I would talk about virtual reality. Here, there was an experiment, very interestingly, by the University of Quebec in Canada, in which 91 players were taken, and they were play 2 games. One group was crushing cigarettes, other ones were grasping and smashing balls. The results showed that 15% of those who were cigarette crushing had actually cut down their smoking, not given up as yet, but at least cut down, as measured by the carbon monoxide exhale test. However, just about 2% or negligible actually participants in the ball crushing game were able to alleviate or stop their smoking habits. So virtual reality is again the way of the future. So with that, I would like to thank you once again for your kind attention, and I apologize for the delay in between. Technology sometimes doesn't work. So tobacco-free campuses all over the country and outside the country, leading on to tobacco-free living. And we have already talked about the various apps and various social media platforms, including WhatsApp, and now more and more things. And I think India, with the highest penetration of WhatsApp and other social media, I think is the ideal petri dish in which we can actually do this control experiments. And I feel in a group of epidemiologists that I hopefully am addressing, this should be something that could actually be given as a next MD thesis. WhatsApp is ubiquitous, it is free, it's easily available, and India with its programming skills is actually absolutely prime to coming up with apps which are innovative, novel, as well as easily available. So you don't require to actually have any special technology, and any IT person will be able to help you get you up and running as we speak.
Thank you,
so
Professor.
With those words, thank you so much for your very kind attention. Over back to you, Dr. Rakesh.
Thank you, Professor Ravi. And if Dr. Ratan allows me, can I make some salient comments on tobacco cessation? with the experience. And I was where I was saying that, yes, Dr. Vikrant has given an eloquent presentation on the dentist's engagement. And I think they are in the best position to give the tobacco suggestion, because that's the time when the patient is totally attentive, is suffering from an illness which has been caused by tobacco use, and his medical practitioner is telling him. But the same holds true for oncologists, for cardiologists, for pulmonologists. And I would say that it is the job of every healthcare worker to sensitize and motivate and promote tobacco cessation, to help every tobacco user who comes to a health facility at every clinical counter, every time you meet these people. That's the best way actually, and is the recommended way in which the tobacco cessation should be propagated. I would also suggest, Dr. Shivam gave a very good presentation, all very relevant points he made, specifically in the terms of challenges that you talked about. And I think there is a need for finding out the solutions as soon as we can do that, because that's the way to enhance the quit rate in the country. And I would then suggest, therefore, in the same way as I told for Dr. Vikrant, that in our country, the dearth of tobacco cessation specialist is going to be there for a long time. We need not depend on the specialist. And I think if we can train and certify the people who can do it, I think 3 qualities are required in them. They should be committed people who can deliver tobacco cessation or who will deliver tobacco cessation. They should be competent in delivering tobacco cessations. That is, means they should be knowing the subject very well, and they should be good communicators. These are 3 things which I think is required in a tobacco cessation resource. That would be a better word. We do have now the certificate courses from Gujarat University, which are run through the ICANN Care, which, although is a private institute, is committed to tobacco cessation specifically. And I think we should perhaps think of utilizing the services that they provide. They also have an app, if Dr. Ravi may be knowing about it. And their app I have used, and I find it equally applicable, although I would say that what Dr. Ravi has said is very informative. There are things which I did not know, and I would consider that using the Stop Smokeless Tobacco app makes the sense, because it is in Hindi also, and also the digital transdermal patch. But there are some of the technological innovations I think we'll have to be we should be staying a little guarded, because we need to know whether these are tobacco industry promoted technological applications, and are they going to be foolproof for the users actually. So we need to know a little more about that, I would say. And M-cessation is a good service. Therefore, in technology, I would say it has not been utilized so much, but it has given us a quit rate of about 20%. Again, I think this is what requires to be promoted more. Something which is there in the country, has been adapted for India, and is run by the Ministry of Health. So these are some of my comments. I'll request Professor Ratan to make some comments as co-chair, and also all the speakers who can come in. We have Dr. Sonu Goyal, Dr. Vikrant, Dr. Ravi, and Dr. Shivam Kapoor. All of them are the esteemed colleagues, and I know that they know so much in tobacco cessation that this 1.5 hour session is very little. And so lastly, the organizers should consider holding a day-long session on tobacco cessation for sensitizing the epidemiologists. Professor Ratan.
Okay, thank you, Dr. Rakesh Gupta. I think I'm thankful to Dr. Rakesh. He has covered most of the things. So I have to speak. I have selected 2-3 points only I want to share. I'm techno-savvy man. So I think when Dr. Ravi Mehrotra's topic I saw, I thought, let me see how much I know. Really, let me congratulate Dr. Ravi Mehrotra. Almost many new things you told me. And I was thinking that how this wristwatch will work. So you could very well explain that how this is working. So whenever sometimes we interact with postgraduate medical students, and by taking only name, it becomes difficult. So my last 2 points are, like I came across that there are tertiary care centers, and they are in each district. So if we concentrate on quality working of tertiary care center, because like like they are frontline worker, I can say. So if we can develop some method that which type of quality service they are providing, that is one thing important. So we can concentrate. I feel that tertiary care center will be very useful because I am a public health man. And second, the medical college students like Dr. Rakesh Gupta, you are in Rajasthan. Like if every state or our organization can keep some awards, like if somebody is carrying out research or thesis on tobacco cessation, so you can provide them some incentives like 50,000 rupees, or like tuberculosis program, they are giving some incentives. I'm not aware if you are already giving it, that's a different thing. But more research should be encouraged in medical colleges. So medical students who is doing postgraduate, they may come out with some innovative ideas. Okay, that is all. Because Dr. Rakesh has described very nicely in detail. And I think all these speakers, they spoke very interestingly. The Shivam looks very young, but he had done a lot of hard work and he has presented very nicely. Nice to see Dr. Sonu. Nice to see. I only saw your photograph. I missed your live photo. So thanks for coming, joining here. You are welcome anyway. So
thank you, sir. I think.
Over to Shivam.
No, I think very well, a lot of learning for all of us, and it's been a privilege to hear everyone here all together. I'm really happy Dr. Sonu is shining bright with the Indian flag behind us. He could join us. And yeah, I think really well summarized by both the chairs. In the interest of time, there are two questions, if the chairs may allow us.
Yes,
we can have that discussion. So the question which Dr. Rakesh and I had answered, I would take the second question now. Is, are there any cost effectiveness analysis to advocate against tobacco in our country?
So there is a report from the National Quit Line which says as to how cost effective the tobacco cessation delivery can be through the quit line. So yes, there is one report which is a national report. We do not have many reports or no reports on TCC's cost effectiveness, but I consider that NTCP at the ministry level perhaps will be able to analyze and give us some data. I think looking into the size of the tobacco cessation clinics in some 628 districts by now, I think it is going to take some time. From Rajasthan, I can say that when I learned about it 2 years ago, the quit rate was about 5% at the delivery level in the TCCs in Rajasthan.
Right. Thank you, sir. Any other thoughts on this, Dr. Sonu, Dr. Ravi, Professor Ratan, Dr. Vikrant?
Yeah, if the chair may allow, can I?
Please go ahead, Vikrant.
Yes, sir. So I think most of the points made were valid, but when we talk about quitting, we all are aware that it's not so easy, and medication is something which everybody looks forward to, and they want something very quickly. They would have practiced it over years, but when it comes to quitting, they feel that it should, they should be immediately able to overcome it without understanding the whole process. So one thing what I would suggest, and I have been always recommending this, is to integrate treatment lines with regard to cessation as a component. In case of dental professionals, I can say that and vouch that very well, that dental treatment along with cessation counseling, integrated cessation counseling works very well. Yes, there is adequate evidence for that. The only thing is that it needs to be practiced regularly, and the dental professionals need to actually stay committed to providing that kind of care at every visit, which is essential for successful outcomes. So similarly, if other healthcare providers, as Rakesh sir has been talking about, other professionals or other lay people to be involved in this whole practice, I would say if healthcare professionals could actually follow up the patients with keeping the tobacco use as a backdrop of treatment outcomes of every patient, whether he's a diabetic, whether he's a tuberculosis patient, whether he's a hypertensive patient, whether he's any, because tobacco is a risk factor for many non-communicable diseases as well as communicable diseases. So we need to utilize this and make sure that all healthcare professionals are understand this and speak the same language that we are trying to talk out here, because this has been happening for years. We have surely made a lot of inroads, but I think we still have to go, as Rakesh sir said, that the demand for cessation is not going to go down, and there's a much more need to reach out to many people. But those people who can be reached out through healthcare professionals need to have this kind of integrated. That is when the patients will become more will be aware, will at least realize that there's it is more holistic towards their overall health. So that's my submission. Thank you, sir.
Shivam, if I may just add here on cost effectiveness, in the sense that roughly one can say that if you need to compare the cost of cessation delivery versus the cost eventually a tobacco user will pay by not quitting and suffering from the non-communicable illnesses, that cost is going to be way huge as compared to the cost for getting the treatment for tobacco cessation. It is like investing in the market to get the returns instead of wasting your money through the equity market.
Correct. Couldn't agree more, sir. I think Dr. Sonu has raised his hand. Probably sir would like to add.
Yes.
Right. So I think not on this comment, but I want to congratulate the department, community medicine, and for organizing this wonderful webinar. I have been listening to it, and I can see Professor Ratan here, and that shows the commitment of the association on tobacco control. It has been my dream that tobacco control is reflected in all the conferences, and in this year 4 conferences were held. First was in PGI, IAPSM. We did 4 sessions on tobacco control. 1 exclusive workshop was there, 1 panel discussion was there, 1 plenary was there, and another session exclusive symposia was there. Then we had exclusive conference on National Conference on Tobacco Health, again being held by PGI. So that was a session where 150 speakers spoke on tobacco on 3 days. Then came IPHA. In IPHA also we had 1 panel discussion, I think plenary session was there, and 1 award session was there, exclusive award session, in which Resource Center for Tobacco Control established in PGI distributed some award for best paper on tobacco control. And this is the 4th conference, Epidemiological Foundation of India, and here also we can see an exclusive session on tobaccos. So I think the tobacco is gaining that momentum, and rightly so, because it is a risk factor for many diseases. So congratulate the department, and I hope that all the listeners, all the audience who are here from different fraternity, I think learn more about it, research more on it, and I think you can make a career out of it. So that's my word. Thank you, Professor Ratan, and thank you, Dr. Rakesh Gupta. I actually had a conclave here, which is going on right now. So Dr. Rakesh Gupta joined virtually, but we had a conclave here, which is right now running in PGI. So we have 35 speakers here. So thank you very much.
Dr. Sonu, in your absence, I spoke about you and how you are utilizing 48 hours in the day to work on tobacco control to push the campaign of tobacco control in the country. So best compliments to you for doing so many things simultaneously and taking the preventive fraternity along with in tobacco control. This is going to make a sea change actually in the tobacco control and tobacco cessation. Best compliments to you for that. Yes, Vikrant, we see the raised hand.
Sir, no, I thought Ravi sir also has raised his hand. Sir is there?
Yeah, he's there.
No, please go ahead, Vikrant. I'll go later. No problem. Nothing urgent.
As you know, and as I was just saying, just to add to all the discussions, today is World Stroke Day, and it is very important that we also have been running a national resource center here. So as a part of these public health days of significance, we come out with different media campaigns, and realizing that today is World Stroke Day, and we have this very important discussion on tobacco cessation. Now or never, as Shivam told, but as Sir modified it very well. in the beginning itself that it is now and so
Hereafter.
Hereafter it more sounds like a nice fairy tale. I hope this fairy tale continues. We are able to make it a reality rather than remaining as a fairy tale. So World Stroke Day, as we all remember, that you should all one thing which we need to propagate and promote is that those people who quit actually increase the number of life years by quitting the habit, and also reduce, for example, secondhand smoke exposures in their families, in their environment. And I think it is very important. These days are very highly recommended that we also stand together and promote this message. And I would request the chairs to actually add to this particular public health day of significance.
Yeah.
Professor Ravi. Sorry, Dr.
Yeah, thank you so much. What I wanted to say was that what I have found in my own experience over the last many decades is the willingness to quit. We might all say that we want to quit when you have a GAT survey or a GYTS survey, but how many people actually really want to do it from their heart? Even of those who want, what is the social support as far as family and friends are concerned? And at the same time, what happens after that? Many people who quit go back to taking tobacco in whatever form, whether smoking or smokeless. So that is basically the thing I wanted to talk about. The other point I wanted to talk about is research. Now, I know epidemiologists are there in this audience. And how many people want to take this up, as I've mentioned, about an MD thesis, about postdocs, whether from medicine, dentistry, or other areas? And also, whatever we talk about, is there any evidence to support? And lastly, the economics of which I think Shivam had asked. I think, at the end of the day, when we talk to policymakers, and I have been one of them, everybody asks that if we spend X amount of cessation, what is the amount of money that we lose? I know there is adequate evidence for taxes, but I don't think the same level of hard evidence is available in this country. So those institutions like the PGI and others who have a health economist on board, this would be one area where I would feel very strongly that we need more information. With those words, thank you so much for having me on this panel. It's been a learning experience for me. I've learned so many new things, and I hope you have enjoyed it as much as I have. Thank you.
So Dr. Ravi has made three very pertinent points. The intent to quit is there, but the people who want to quit as per GATS data is less than 20%. They want to quit in next 1 year. So 80% you have either not decided or they do not want to quit. We have this data from the country. Research, I think, is very pertinent. Epidemiologists are very good at doing the research. I will also definitely request them that please do more researches in tobacco cessation, field of tobacco cessation, to give us more information and the strategic points which can help in enhancing tobacco cessation. And the last point I'm missing, Shivam, as to what did he say, was on economics. And yes, economics definitely is related to tobacco use. We know that poverty and tobacco are related through the sustainable goals. We all know that there is a focus, and United Nations have definitely recommended the use of WHO Framework Convention on Tobacco Treaty and its articles for utilizing by all the member countries. I think that is very pertinent again. Shivam and anybody else wants to make any other comment, please. Professor Ratan, you want to say something?
No, actually, as far as new technology, Dr. Ravi Mehrotra was speaking about, I just want to say that I think we all should feel thankful to Corona pandemic, because it has provided us this online facility. Otherwise, it was never possible to organize such a meeting or conference and sitting by looking at the face. Either you can have conference on phone. So I am saying that this has come up and we have become all user friendly. I remember in March 19, because I was looking after telemedicine center in BHU, and I was asking faculty members to use this technology. They were all hesitant. But now, because I retired in 2020, now I have joined another one NGO here. I am working to help this government of Uttar Pradesh Director of Medical Education as technical assistance. I'm providing for Corona and other things. Now the best thing is that we are using this facility. So everything is so possible. So new technology, like we are worried for tobacco cessation now. And perhaps I'm expecting very soon we will get some technology method by which we can get very fast result. And then lastly, I wish happy Diwali to you all, because I don't know next time when I will meet. And that's all, sir. And bye-bye.
Thank you so much, sir, for the wishes. Same to you. And same to Rakesh, sir.
Thank you. I wish to thank the organizers of the conference, as well as the union, which has always been very supportive of strengthening tobacco control and tobacco cessation in the country. And if any of the speakers want to give the last line, I think we have although exceeded time, but please do go ahead and before we close this session. Let me begin with Shivam.
I have, sir, few words to close. I think if anyone else, then I'll officially do the
Dr. Raviji
closing.
I just want to thank everybody, and I wish you all the best and a very happy Diwali.
Dr. Sonu Goyal, are you still with us?
Yes. I'm still actually right. So I think everybody has been said right now. So I don't have anything, but the only message which I want to give to the public health fraternity is I think we can work a lot on tobacco. Those who are working in non-communicable diseases, I think indirectly the tobacco is the major killer for all the non-communicable diseases, be it stroke, be it cardiovascular diseases, cerebrovascular diseases. So you can do a lot of things. And I think now we are vouching towards the tobacco end game beyond tobacco control. So I think we can move in that directions with the support of all the public health fraternity. So thank you.
Thank you. I think people should join India Tobacco Free Alliance, which Dr. Sonu has initiated. Dr. Vikrant.
Yes, sir. Thank you so much, sir. Thank you both the chairs for this, healthy and very humble discussions leading to some particular outcomes. And I congratulate the organizers, Professor Bharadwaj and the whole team at AIIMS Jodhpur for successfully organizing this whole event, and Dr. Shivam Kapoor and the union, Dr. Rana, sir, and all the whole team there. Thank you so much for the opportunity. All the best.
Thank you so much.
Happy Diwali, and please take care.
Thanks.
Thank you for your participation.
Sure, sir. I think I'll just give the closing word now in the interest of time. I think it has indeed been a day of exceptional knowledge sharing. I hope all of the participants have gained immensely from today's symposium, rightly pointed out by Dr. Rakesh as landscaping now and hereafter. However, needless to say, this remarkable effort would have not been possible without the incessant efforts and endeavors of a number of people whom I would extend my heartfelt gratitude to. At the outset, I would like to thank our session chairs, Dr. Rakesh Gupta, Dr. Ratan Srivastav sir, for gracing this symposium and sharing their adroit vision, in-depth knowledge and experiences. I would like to extend my gratitude to our guest speakers for today, Professor Dr. Sonu Goyal, Dr. Vikrant Mohanty, and Dr. Ravi Mehrotra sir, who had expansively navigated through all the way ahead in tobacco cessation and how it is important for tobacco control in India specifically. The transformation of such information at the larger level is ultimately the goal of public health, and we have this vision with all the epidemiologists who are with us in Eficon 2021. A note of gratitude to Dr. Rana J. Singh, our Deputy Regional Director at the Union, for his constant guidance and support. Dr. Pankaj Bhardwaj for giving us the opportune stage to have this, podium of Eficon 2021, which made the symposium even possible. And kudos to the entire team of the event, including Dr. Chunilal, Dr. Aarti, and others. If I have missed few names, I apologize. Last but not the least, I would like to extend a special thanks to all the participants who had made this symposium engaging, and I wish all of you a great success. Like all the speakers and chairs have said, we look forth all of you, all the young minds, to join hands and be the change in tobacco cessation by bringing out the research that we need at this point of time. Thank you all. Thank you one and all. Thank you again.
Thank you, sir. Thank you for
your
valuable time.
declare the session closed. Thank you.
Good evening, everyone. So can we take the attendance of the participants?
Please go ahead.
Team A, please switch on your video. Team B.
Good evening, ma'am. Dr. Mandeep and Dr. Such.
Hi, all the best. Team B.
Good evening, ma'am.
Good evening.
Dr.
Hi.
Sandipto.
Dr. Trina. Hi, all the best. Team C.
Good evening, ma'am. Dr. Manasvi, Dr. Ishani.
Hi, all the best.
Thank you, ma'am.
Team D.
Good evening, ma'am. Dr. Girish or Dr. Anand?
Hi, all the best.
Okay.
And Team E.
Good evening, ma'am. I'm Dr. Angelin and this is Divya.
Hi, best of luck.
Thank you, ma'am.
Okay, so we have 5 minutes left, then we'll go live.
Okay, can you please spotlight the 5 teams and the quiz master, because that will be better for the streaming.
Actually, and either like இது பண்ணுங்க.
Please check your all the 5.
It's working, ma'am.
Okay, all 5 teams.
It's working, ma'am.
Neha, you are the co-host, right? So can you please spotlight the 5 teams? Can you do that? Just click on the 3 dots and there's an option known as spotlight.
Okay, sir, I'll try.
Yes. Next, go to the other team and add spotlight.
So then, okay, yeah.
Right. Go on doing this, and only the those round
Participants.
The 5 participants and 1 quiz master, so that the streaming gets good. Okay.
Okay, okay, sir.
Okay, 5 teams are there. So whoever round is there, that you can spotlight that person. Okay.
Okay, okay, sir.
Thank you.
Good evening, everyone. I would like to confirm my audibility and visibility.
You're
audible. Yeah, you're audible and you're.
Thank you, ma'am.
All the best to the teams. This is going to be a really exciting round, so just gear up. Okay.
Can all the teams check whether your sheet of paper is visible? So because sometimes if audio is not working, you need to show the paper. Can you just show? Okay, good.
I think you need to adjust your lighting so that the paper is visible.
Yeah, the
Team
whatever
E.
is written has to be visible.
Especially
Team
Team E, Team James Lind.
Yeah, your lighting is a bit,
Team E, kindly adjust your light. Okay.
Dr. Neha, are you going to go ahead with the general instructions, and then I can start from the demo part?
Dr. Akhil is going to introduce Dr. Abhishek.
Okay, then I'll take over from the demo part.
Dr. Akhil followed by Dr. Wasim.
Right. Absolutely.
We still have 2 minutes to start.
Okay. Team
All
E,
the
can
best.
you show your paper once? Just hold it down. Okay.
Kindly write something and show it, Team E.
Yeah, write something on it.
Okay. It is visible. Thank you.
Okay, fine.
So 1 minute to go.
Dr. Akhil, I just want to confirm whether we are in main hall or hall A.
Hall A.
Hall A.
Yes. Right, so it's 6:30. A very warm
Shall we
welcome
start?
to everybody. I'm Dr. Akhil Goyal from AIIMS Jodhpur, and I'm delighted to welcome everybody, all the participants, all the organizers, all the delegates to this wonderful event of National PG Quiz Mind Benders under Eficon 2021. Dr. Neha, I'll be grateful if you can project the slides.
Yes, sir. Yes, sir.
This journey started almost 2 months back when we all came together and sort of decided that, yes, let's have some dynamic event, some interaction event in which, our young colleagues can participate, come together. And I think it has been a very, very exciting journey for all of you.
So just give me 2 minutes. We are sharing the slides. Yes, sir. Please go ahead, sir.
Right, next slide, please. So these are some of the flyers that we have made for the final event. And the reason for putting this here is we want to acknowledge the creativity and ingenuity of one of our organizing team members, Dr. Sharon, who is a digital whiz and has been helping us with all the quizzing events. So thank you, Sharon. Next slide, please. So this quiz was named as Mind Benders as a part of Epidemiology Foundation of India Conference 2021. We got an overwhelming and applauding response of more than 100 candidates. So we had a total of 120 delegates from different parts of the country, all over the country, which is a huge response. So a total of 60 teams participated, first in a preliminary round, which was organized on 20th of October 2021. And from then, we were able to choose 5 teams using the Quizalize app. And today, these 5 teams will be competing for the final prize. So the 5 teams have been given names: Team Dolan Hill, Team Sir Ronald Ross, Team Chadwick, Team Joseph Board, and Team James Lynn. Shortly, my colleague Dr. Wasim will be introducing all the teams to you. This quiz, this event has been brought together by the dynamic participation of the organizing team members, Shelly, myself, Abhishek, Revu, Maltesh, Sharon, Wasim, and Neha. You'll be meeting all of us during this particular quiz competition. Thank you. Wasim, over to you.
Thank you, Dr. Akhil, for a fantastic opening to the Mindbenders quiz as a part and under the aegis of Eficon 2021. It gives me immense pleasure, proud and privilege to introduce to the top 5 teams of our country who have finalized by the preliminary round, and they have reached the final today. So meeting Team A, Team Dolan Hill, let me introduce Dr. Suraj Kapoor and Dr. Mandeep Kaur from Armed Force Medical College, Pune. A huge round of applause to Team A. Moving ahead to with Team B, Team Ronald Ross, Dr. Sandeepta Chakrabarti and Dr. Trina Sengupta from All India Institute of Hygiene and Public Health, Kolkata. Team B for you guys. Moving ahead with Team C, Dr. Manasvi Chopra and Dr. Ishani Chadda from AIMS Jodhpur. Huge round of applause for Team C. Team D, consisting of Dr. P. Ananda Selvadas and Dr. Girish from AIMS New Delhi, all the way from Delhi. Congratulations, Team D. And last but not least, teams James Lind, Dr. Angeline and Dr. Divya Bharti R from MGMC Research Institute, Puducherry. So we give you enormous amount of applause and welcome to the finale of Mindbenders 2021 in Eficon 2021. So let me proceed without doing a further ado with the general instructions of the quiz, and specific instructions pertaining to each round will be given by the quiz masters of that round. So instructions for the quiz finale. All the teams are strictly instructed to have a good internet connection. Any kind of delay, more than 10 minutes in connecting back to the quiz, will lead to automatic disqualification of the team. Both the team members must be seated together at the same place during the quiz. The visibility of both the members should be ensured throughout the quiz. All team members are instructed to have a must A4 size sheet and a pen with them during the quiz, owing to any technical glitches or audibility or visibility issues. Team must write their names, number on a white chart pad before and black with black marker. For example, they have been clearly instructed to write their names and number behind them so that it is visible throughout the quiz. And every team will be getting only one chance to answer the question. If you answer out of turn or answer more than once, 10 marks will be deducted. To make it very specific for all the teams, even in the rounds where there is no negative markings or deduction, answering out of turn or answering more than once will lead to deduction of 10 marks in each question and each round. So let me make that very clear. And also to introduce to the scorers for today's Mindbenders finale, Dr. Malatesh, Dr. Sharon, and Dr. Neha will be scoring throughout the session. For our audience and viewers, for your kind information, we already had a demo version of all the rounds with the finalists, and all the instructions pertaining to specific rounds were given to the finalists and they have understood. However, nevertheless, we shall be repeating all the specific instructions to every quiz.
Sir, sorry
Yes.
to interrupt, sir. We need to change our device. There's an issue with our device. We'll be joining from the another device.
Okay, Team D.
Yes, thanks.
Kindly make it as soon as possible.
Yes, sir.
I hope the general instructions are clear with all the remaining teams. Can I have a confirmation from team A, B, C, and E?
Yes, sir.
Yes, sir, it's clear.
Yes, sir.
Yes, sir, it's clear.
Thank you. In the meantime, let me have a confirmation of audibility and visibility from all the quiz masters. Dr. Shaili? Shaili ma'am?
Yes, Dr. Naseem, you're audible and yeah, visible.
Yes. Dr. Neha?
Yes, sir. It's clear.
Dr. Malatesh?
Yes. Am I audible?
Yes, yes.
Okay,
Thank you. Dr. Rivu?
Yes, I am audible and visible.
Dr. Sharon?
Dr. Wasim.
Dr. Abhishek?
Yes, am I audible and visible?
Yes. And finally, Dr. Akhil? Yes.
Sir, we have joined.
Yeah. Thank you, Team D. And I request all the teams to kindly be seated in the same area in spite of any connectivity issues. And if there is some kind of disconnection, you are requested to contact Dr. Malatesh or Dr. Sharon immediately. Any kind of delay, let me go back to rule number 1. Any kind of delay more than 10 minutes in connecting back to the quiz will lead to automatic disqualification and no further encouragement will be entertained. Thank you. Again, it gives me immense pleasure to welcome Dr. Abhishek Dey, the quiz master for the first round. Over to you, Dr. Abhishek.
Okay, so can I be allowed to share my screen? Is it visible? Hello, is it visible?
Dr. Abhishekda, actually, we are still seeing Dr. Prasanjit Bal's screen. Dr.
Oh.
Prasanjit, can you stop sharing your screen? Yes. Abhishekda, your demo for grade round is visible. Over to you.
Now, what is visible now? Tell me.
The slide for demo for grade round.
Now,
Slide number 8.
Is it in
Yes.
full screen now?
It is in full screen. Thank you.
Very good. Okay, so since this was advertised as a mystery round, so we should go through the process of performing the answers for this round. So very quickly, I'll just show you. So this is basically an abbreviation grid of 16 letters. So I can see that Dr. Suraj was smiling. I think he's an expert on abbreviations or something like that. He immediately smiled when I showed the slide. So what you have to do is in the sequence of your team's order, that is for this round, it will be from A to E and then from E back to A. So there will be 10 questions and you will be asked to choose one of the letters from these 16 letters. So the color of the letter does not indicate the difficulty level or the points or anything. It's all the same. It's just to have a balance of all the colors. And you will be asked to identify the acronym or the abbreviation, the full form, and it has to be exactly correct unless it's very difficult, and then I'll use my discretion whether to award you marks or not. There will be 20 marks for a right answer and no negative for an incorrect or a no response. And the question will not be passed. Okay, so is that clear? So once you choose the letter, let us say that you are team A, who will be beginning the quiz with, and you choose the letter A as well. So then I will click on the letter. This is just a demo, and you will be shown the abbreviation. And from the time that the abbreviation is shown, you will have exactly 20 seconds to complete the answer. After you do so, there will be an intermediate blank screen like this. And then I will show the answer, whether it is right or wrong, because it is not passed. And then you will have the answer. So is the process clear to all the teams? May I have confirmation?
Yes, sir.
Okay.
Yes.
Team B, confirmation that it is okay?
Yes, sir.
Okay. Fine. Team C, Team D, Team E, please confirm that you have understood the instructions.
Yes, sir.
Team D, we have understood, sir.
Okay. Team
We
E.
do have understood, sir.
Okay. So can we then go ahead with the round? Can we go ahead?
Yes, sir.
Okay.
Yes, sir.
Yes, sir.
Is it visible? Blank slide is the full screen visible?
Yes.
Okay, fine. So tell me, Team A, this is your question.
So letter B.
B.
Fine. Your time starts now. Time is ticking. Nobody should answer out of turn because there's no scope to answer anyway.
So basic primary medical unit.
I'm afraid that the answer is not correct. Let us see what the answer is. It is block program management. Since it's an easy abbreviation, I can't give you the full marks. Okay. Then direct question to Team B, Sir Ronald Ross. Which letter do you want to go with?
A.
Okay, A. Very good. So, please tell me.
Audio computer assisted self-interview.
Somehow I knew that you would get it because actually he and I were working in the same ICMR institute a few years ago. So yes, that is the correct answer. This is a new technique for interviewing people with HIV and AIDS, audio computer assisted self-interview or ACASI. Okay, over to Team C.
So M.
Yeah, okay. So you want M. Please tell me. Your time starts now.
Um,
5 seconds
so
left. There's no pass.
okay.
Okay, time is up. Can anybody attempt? There's no marks, obviously, for doing so.
Mortality in India established through verbal autopsy.
Okay, who answered that?
Team D.
Very good answer. I'm sorry, but there's some problem with this this screen. You know, it's not moving away. Yeah, okay, I got it. Fine. Okay, then Team D, your question.
So we'll go with G.
G, okay. So that's it's a relatively easy question. You will have to answer it exactly.
Sir, growth monitoring, ORS, breastfeeding, immunization.
Quickly, please. I can't give you any more time. So the answer is, and it is an easy one. So you know, all of you know the answer. OBFF, a program by UNICEF and later revised. So the first question, the last question of the first cycle of the first round, Team E.
Sir, we will go with P.
Yeah, okay. Time starts now.
Pradhana Mandri Vasishta Vayoshree Vandana.
Yeah, I beg your pardon. What was the third word? I heard Pradhan Mantri.
Vayoshree Vandana Yojana.
Well, I'll give it to you because it's via Vandana Yojana. So it's okay. Okay. Correct answer. Then moving back from E to A, we have Team E again. Which letter would you like to go with?
We'll take I, sir.
Okay, very good. So time starts now. Ten seconds. 5 seconds. And that's time. Can you say the answer? Team E.
No, sir, we'll pass.
So the answer is Integrated Health Information Platform. So you didn't score any marks for that. Moving on to Team D. Team D.
Okay. So we'll go with R.
Okay. The time starts. Yes, I beg your pardon.
So we don't.
Pass.
Okay.
Sorry,
Can anybody answer? No marks.
Rashtriya Vayoshree Yojana.
Excellent. He thought as much that he knows all the abbreviations. Okay, very good. Back to Team B. B for Bombay, B for Donald Ross.
We'll go for D.
Okay, so this is a little strange, but it's still there. Time is ticking, 5 seconds. Five seconds left. And that's time. I need an answer. So I take it that you can't answer it. Rest of the teams, can you please try?
So, development origins of health and disease.
Excellent answer. Excellent. So things are looking good. and everybody has scored, I think. So no marks there for team B. And the last question of this round for team A. You have a lot of choices.
Sir, excuse me, sir.
Yeah.
Sir, our turn is missed. Team C.
Okay, well, no problem there. Team C, your direct question.
Yes, sir. So N. So we'll go with N.
N. Okay. N for Nigeria.
Yes, sir.
Okay, tell me.
The National Center for Disease Implementation and Research.
No, that's
The
not
National
right.
Control for Disease
You can only
and
answer
Implementation.
once. You can only
Research.
answer once. Be careful. You get -10. So anybody knows?
National Control for Disease Information and Research.
It's informatics actually. Okay. This is the center, the ICMA center in Bengaluru, which deals with the cancer registry. And
Sir, we answered this only. Excuse me, sir.
No, you did not. You said information. You did not say
Oh, sir.
informatics.
Okay, sir. Okay, sir.
You said information. So it is futile to argue with the quiz master. Team A.
So
Your
letter
question.
V. Letter V.
Letter V. Okay. Vishwash. Please have Vishwash in the quiz team. That will do you good. This is only the first round. Don't get prematurely excited. There are 7 rounds. Time is ticking. Five seconds. That's time. Can you provide the answer, please? I take it that you can't provide the answer. Can the others try, please? Okay. So, Dr. Neha, the answer isn't visible here. Anyway, so that's the end of the round. So we will just go quickly to the scores, and then I will discuss the correct answers for all the letters.
Good afternoon. After the end of the round 1, so both Team B, that is Team Ronald Rose, and Team E, that is Team James Lind, are leading with 20 points, and the other 3 teams are yet to start their scores. Thank you.
Okay. So Minerva is yes, your answer was correct. It is a system to measure the cause of deaths in India, present throughout the country. THSTI was Translational Health Science and Technology Institute. It is there in Faridabad, and it goes to translational research. It's an autonomous institute of the Department of Biotechnology. CRISPR, as you know, is a technology that is revolutionized the world of gene editing, and the Chemistry Nobel Prize was awarded for this discovery. Okay, Gobi FFF, yes, it is very easy, so I'm not just going through that. SSS is Swachh Swasth Sarvatra. So that is the program, a joint program of the MOFHW and the Ministry of Drinking Water and Sanitation. F was for FSSAI, you know what it is. Okay, and UP is for PMVVY, so that is Pradhan Mantri Vaya Vandana Yojana. And I is for Integrated Health Information Platform. Okay. B, yes, we have gone through what B is. RVY is Rashtriya Vayushri Yojana. E is for ESCM, Enhanced Syndromic Case Management, and V is for Vishwash. So that is the full form of Vishwash. It is displayed there. It is a policy of the NHM. So something that happens under NHM. Okay. So that's all from me, and I'm stopping my screen share now. Back to Dr. Neha.
Thank you, sir. Can we have the scores of the round 1?
Yeah, Dr. Neha, I have already mentioned it.
Okay. I would
He
request
has already told us.
Prasanjit Bal to please share the screen for the next round.
Why are you also looking depressed? So please cheer up. It's all about a fun activity. It's not a very
exactly.
Yeah, and this is only the first round out of 7 rounds. So you can like turn around the tables in any round. This is precisely why we kept it as a mystery. You know, 2 of the rounds are not disclosed, just to have an element of surprise, so that it can't be rehearsed from
and in a very serious Eficon conference, this is a fun thing. Okay, so that's why even Dr. Akhil is smiling now. So you have to like enjoy the quiz. Do not get so tense. It is not anything is not depending on that. So enjoy the quiz. We have made very interesting rounds. Okay.
Please cheer up. Everyone, please cheer up, guys. I mean, more interesting rounds are yet to come. You have 6 more rounds left. So please cheer up and gear up also for the next rounds, for the next 6 rounds. All the best.
Like with online teaching, everybody is getting either serious or sleepy. So you're not getting sleepy now. Most of the time, people switch off their cameras and sleep during classes. So
okay, one incentive is I'll be taking a lot of snaps in between. So you have to be at your best smile.
Right. So it's ready.
Okay, are we good to go? Teams, are you ready? Okay, so I'll first start with the instructions. So this round will consist of 10 questions and we'll start with team B. So team B will be the first team that will answer the question. And you will have an image and 4 options. Out of those 4 options that are provided to you, you have to choose the best option that links with the image. You'll be only allowed to answer once and the question shall not be passed. You'll be getting 20 seconds to answer the question. And if you give the correct response, then you'll be getting 20 marks. There is no negative marking for incorrect or the wrong responses. And obviously the decision will, by the quiz master will be final. So are you ready, team B? Sir Ronald Ross?
Yes.
Okay. So please find the appropriate option for the given picture. You have your options with you and your time starts now. There is no negative marking, remember. Okay, time's up. Team B. Okay, any other team that wants to?
Ma'am, Central Social Welfare Board.
Yes, very good, team A. It's Central Social Welfare Board. It carry out welfare activities for promoting volunteerism, providing technical and financial assistance to voluntary organization. Very good. So the next question is for team C.
Dr. Neha, just sorry to interrupt. So does the passing team gets marks for correct
No,
answer?
sir.
No,
No, sir.
fine.
No.
Okay,
No.
thank you. Proceed.
Hard luck, team A. You're giving right answer, but you're not getting marks. Don't lose heart. You'll get in other, okay. Shall we start, team C? Okay.
Yes, ma'am.
So your question is, again, you have to link the options with the image.
Ma'am, it's Suraksha Clinic.
Absolutely. Well done. 20 marks to team C. So it's a designated STI, RTI clinics, which are established by NACO. Good going, team C. So next question will be for team D. Joseph Board, ready?
Yes, ma'am.
Yeah. Time is ticking, team D.
Rogi Kalyan Samiti.
Well done, bravo. Yes, it's Rogi Kalyan Samiti. It's a patient welfare committee and it's established under NRHM. Very good, team D. Next, team E. Ready, James Lind? Yeah.
Civil registration system.
Lovely, lovely. You get 20 marks. It's civil registration system. It covers registration of birth and death. Very good, team A. So next question will be for team A. Yeah. Team A fast.
Kareena Kapoor.
Option 3.
Kareena Kapoor.
Oh, I'm so sorry. That's the wrong answer. Madhuri Dixit is a brand ambassador of MA program. She launched this program along with Minister JP Nadda. Very sorry. You won't get any marks. Okay, so again, we'll start with team B. Team B, ready?
Yes,
Sir
yes.
Ronald Ross? Yeah.
Yes.
So please link the picture with the options.
Good clinical practice.
Hard luck. No, it's not good clinical practice. The answer is informed consent. Don't worry. Okay. So can we have next question for team C?
Ma'am, path.
Path is the wrong answer. Any other team who wants to try this question? You won't be getting marks, but still, anyone?
CRY.
Yeah, team D's, right? It's CRY. It's this fellow is Mr. Ripan Kapoor, who started this foundation, and he was an Indian airline purser, and this foundation addresses the child critical needs. Very good, team D. Nice try. Okay, so can you have the next question, please? It's for team D only. Time is running, team D.
Occupational diseases.
No, I'm so sorry. That's not occupational diseases. Any other team who wants to try? Don't get serious. Let's enjoy. Even if you don't get marks, you can try.
Family planning.
Yes, team C, you're right. It's family planning and it's a braided approach. So the picture was showing the braids. So the braided approach means benefit of the method. R is for the risk of the method. A is alternatives to the method. I is inquiries about the method. D is decision to withdraw from using the method without penalty. E is for explanation of the method chosen and documentation of the session for your own records. Okay, so you won't be getting marks, but okay, it's nice. Nice try, very nice. Can we have the next question, please? Team E.
Participatory rural approach.
Lovely, lovely, James Lynn. It's PRA. Very good, very good. So you get 20 marks. This round is giving good marks to everyone, every team. Team A, you need to buck up. Next question is for you. All the best. Yeah. Come on, team B.
Ma'am, BG Prasad scale.
Yeah, very good, lovely. It's PG Prasad scale. This picture is of Dr. PG Prasad. He worked significantly for uplifting the department of KGMC. Yeah, so you're getting 20 marks. So the round is up. Can we have the scores, please?
So at the end of round 2, team E, that is team Jamesland, is leading with 60 points. And all of the 4 teams are having 20 points each.
Oh, lovely. Good going, James Lind. Okay, so over to Dr. Malatish for Vignette round.
Good evening, Dr. Neha. I think I'll be taking over for the vignette round.
Okay, I'm sorry. Yeah, please go ahead, Dr. Wasim.
Can we have the next slide? Yes. So if round 2 was an elevator for all the teams, round 3 will act as a catapult. Let us go to the instructions of round 3. These are vignettes, and this round consists of 10 questions starting from team C, team Chadwick. Each team will be given 4 hints for every question, and every hint will be displayed after the interval of 10 seconds. 40 marks will be awarded if the team answers correctly after the first hint, 30 marks after the second hint, 20 marks after the third hint, and 10 marks will be awarded for the correct answer after the fourth hint. And between each hints, I request Dr. Prasanjit Bal to kindly make a note of timer to display the next hint after 10 seconds of each hint being displayed. So a total of 40 seconds will be allotted to all the teams. And after 10 seconds, every new hint will be appearing. The question shall not be passed. There will be 5 marks deducted for giving incorrect answer by any team. So specifically, the questions are non-passable. So the questions are dedicated to your team. For example, if you give an incorrect answer in the first hint itself, you will get -5 and the question will be nullified. So there will be no further hints going ahead. So if you are not sure, my suggestion is you can wait for the next hints to appear. At any given point of time, if you don't answer, if you answer incorrectly, you will be given only -5 marks. Are we clear with the round rules? Can I have a confirmation from all the teams?
Yes,
Yes,
sir.
sir. Yes, sir.
Okay. So let us begin with the vignette round with smiles on your faces. And the first question goes to team C. So your question is, name the theory. Can we have the first hint? I am one of the school of thoughts in moral reasoning given by Mr. Immanuel Kant. Team C, you are muted.
So we want second hint.
Okay. So in order to act in the morally right way, people must act from duty. This is one of the closest hint. Nothing in the world, indeed nothing even beyond the world, can possibly conceived which could be called good without qualification except a good will. And your last hint, I am derived from the Greek words meaning duty and science, and you have 5 seconds. Team C, you are muted again. And your time is up. Can I have an answer? Okay, it's a deontology theory. So there was no answer given by team C. So neither any marks are avoided, nor they will get any deducted marks. Can we have the next question for team D? Team D, your question is name the deceased. I request all the teams for which the questions are directed to kindly unmute yourself beforehand itself. So the first hint, I am an emerging infectious disease caused by a family Paramyxoviridae, a genus herpes virus. This disease was initially isolated in 1999 from the outbreak in the village in Malaysia. In India, it was first reported from West Bengal in 2001 and again in 2007.
Cytomegalovirus?
I'm afraid you have given the wrong answer. Hint 4 was in 2018, the outbreak occurred in 2 districts of Kerala, namely Malappuram and Kozhikode. Do you want to go with the round? You will be given -5, but if you want to go ahead with the answer.
So, Nipah virus?
Yes, it is Nipah virus, I'm afraid. So kindly note the scorers, -5 marks for team D.
Okay.
Next question is for
Dr. Wasim.
Yes, sir.
Can there be just a little more gap in between the hints for them to say
Yes,
whether
sir.
they're going to answer or not?
I feel the same, sir. Can Dr. Prasanjit Bal kindly note? Even I perceive the hints were displayed a little bit faster.
Yeah, I mean, it's almost instantaneous. So there should be at least 10 seconds gap in between each of them.
Thank you, sir. Thank you.
Dr. Vasim,
Next,
get a confirmation and then proceed.
yeah, Dr. Prasanjit, can I have a confirmation?
Yes, it was 10 seconds only.
Okay.
Yeah, yeah.
Team E. The next question is for Team E. Name the disease again. It is endemic in the eastern states of India. Second hint, please. One form of this disease is also known as Aleppo evil. Team E, you are muted. The organism causing this disease can be grown in Schneider's insect medium. And last hint, the promastigote stage is seen in the culture. The stage which is seen in culture is promastigote. Okay, there was no answer from Team E. Sorry?
Malaria, sir?
The answer is wrong. You have not answered within time. So at my discretion, I'm deciding not to give you -5 since the time was up. Even if it would have been a correct answer, I would have restrained myself from giving you positive marks. The answer is leishmaniasis. Okay, so none of the team has scored any marks in this. I encourage all the teams because the forthcoming questions, I hope the hints are quite easier and you'll be able to score marks. The next question is for Team A, Team Dolan Hill. Name the disease. An EYE strategy was launched in 2017.
So yellow fever.
Excellent, Team A. Bingo. For the sake of formality, let us have the remaining hints. Reservoir of infection is mainly in monkeys. Third hint and fourth hint. Severe cases can be confused leptospirosis, and the vaccine gives lifelong protection. Great answer, Team A, Dolan Hill. And scorers to note that Team Dolan Hill will receive 40 marks. Next question is for Team B. Can I have a confirmation from the scoring team?
Yes, noted.
Yes, yes.
Next question is for Team B.
Yes, sir.
Name the cancer. It is one of the 3 most common cancers in Asian countries. The mean age of occurrence of this cancer is usually between 51 to 55 years. One of the most important practices which make vulnerable to this cancer are cultural practices. It is more common in men of low socioeconomic status.
Oral cancer.
Oral cancer, bingo, you get 10 plus marks. Team scoring team can note that Team B, Team Sir Ronald Ross, gets positive 10 marks.
Noted.
Team C, Team Chadwick, the next question is for you. Name the disease. It is a bullet that kills straight away. Team C. Islands are often spared. It causes encephalitis. And last thing, please. It is a viral disease caused by bites. Okay, your time is up. Any other team would like to go for the answer?
Rabies.
Rabies.
Yes, it is rabies. So no points for team C. Next question is for team D.
Yes, sir.
Team Joseph Bohr. Gear up. Name the diagram. It is a diagram of a thing that Bengalis have with their plates. It is used for quality analysis. It is to determine the root causes.
So I think it is Pareto diagram.
No, I'm afraid you get -5 marks. It is also known as Ishikawa diagram.
We do not have Pareto in our plates.
Pareto diagram was given.
No, we do have, because 90% of the work in West Bengal is done by 10% of the people.
Okay.
Okay, any other team would like to go for the answer?
It's a fishbone analysis.
Yes, it is fishbone diagram visualization tool. Okay, can we have the next slides? Yes. Next question is for team E.
Dr. Wasimi, was it -5?
Yes, it is -5 for team D.
Okay, thank you.
Thank you for confirming. Can I have the next question for team E? Name the theory. It is a well-known theory of motivation. It assumes motivation to be hierarchical and moving from one stage to another. I think team E should get now. It assumes that food and security is more fundamental than self-actualization. And lastly, sorry?
Hierarchy of needs.
I'm afraid I'm not getting your voice again, Timmy.
Hierarchy of needs.
Hierarchy of need, yes. If you can give me the name of, you have almost got it. Name of the scientist proposing the need hierarchy theory. Okay, I can't give you because it has to be given by the name of Russian sociologist Maslow's hierarchy of need. So team, the question was, I'm extremely sorry. The question was for team E. Team E does not give any marks.
Noted.
Next question is again for team A, Doll and Hill. Name the technique. It tells information about what to do first and what to do next.
Ma'am, sir, PERT, program evaluation and retrieval technique.
It is quite close, but it is incorrect. You have given the answer as wrong answer. The name of the technique is critical pathway method.
But hints are getting flowers before.
What to do first, what to do next?
No, actually, I have taken your answer immediately after the first hint.
The hints have come after you answer.
After you said the answer.
PERT technique.
Sir, we have considered, this answer is considered.
It is considered as a negative
Right.
answer.
Sir, actually, sir,
next
in
we
heading
didn't
it
get
was
opportunity.
name the technique. It was there.
Okay, let me answer this. Actually, for this project management, there are two techniques, PERT and CPM. And
overall, we named the technique was there, so we answered PERT.
No. Please wait. In the hint 2, you will get the differentiating point. It takes.
But sir, we didn't get opportunity to
but
answer.
We answered
hint
at the
two,
first
sir.
point only. So
Yes,
so
but
after first hint, we should have got opportunity at the second hint to answer.
No, you have answered immediately after the first hint.
No,
So
the second hint was shown after you answered PERT. So that can be confirmed from the recording. So there's no point arguing. It's a negative score.
Actually, sir, name the technique was there. So we thought ki overall CPM is a part of PERT. So we answered as
let it go. There are other rounds are there.
CPM is not a part of PERT. Okay.
It is not a part of PERD, and you will get -5 for this question. Next question is for team B.
Yes, sir.
Name the method. It helps in ordering goods. All the consumables are divided according to the level of requirement. Team B. All the consumables are also divided as per their level of use. A matrix is built combining them. Team B, last 5 seconds. And your time is up. Any other team would like to go for this answer?
So I think ABC VAD matrix.
Excellent, excellent team D. It is ABC and VED analysis. I wish I could have given points to all the teams who were answering after the questions were passed, but this is a non-passable round. And that completes the vignette round. And I request the scoring teams to kindly display the scores.
Okay, at the end of round 3, team E is leading with 60 points, and team A is close behind with 55 points, followed by team B with 30 points, team C with 20 points, and team D with 10 points.
Okay, buckle up all the teams, and team E, team A, team B, team C, and team D, all the best for the forthcoming rounds. Can I hand it over to Dr. Sharon for the thriller round?
Thank you, Dr. Wasim. Can I have the next slide? Yeah, we had the scores. Okay. So this is a very interesting round, and this round you might not have seen before. And instead of testing your knowledge, this particular round will be testing your logical reasoning. Okay, can we have the next slide? Okay, so this round there will be 10 questions, and it starts from team D, and each question will have emojis, and it will be either showing a related to a disease or to a personality or to an event. Okay, and if the respective team is not able to answer the question, it will be pass. So this is the first round having a pass. Okay. And there will be more time here. So time for answering the question will be 45 seconds. So there is ample time for thinking. And for a pass question, I require an instantaneous answer. And regarding the marks, it has 30 marks for the correct answer for that team that is who has a direct question. And if it's passed, the passing team, if they give the correct answer, they will get +10. There are no negative marking. So take the time and think properly and give the answer. Don't pass without giving the answer. And if you answer out of turn or answer more than once, as we mentioned earlier, there will be 10 negative marks, and decision of the quizmaster will be final. So all the teams, are we clear with the instructions?
Yes, sir.
Just a moment. What is the role of emojis here? That I am not clear.
Yeah, actually the question will be emojis only. So based on that emoji, you have to identify that question. So we will ask you to, there will be an emoji, and pardon me?
Should we identify the name of the word based on the emojis?
Yeah, we have a demo question, so we will understand. Can we have the next slide? So this is open to all. So question will be like this. So in this particular question, you can identify the disease. So there will be two emojis that denote the particular disease. So it can be either the name of the disease that will be split in the form of emojis, or there is something related to the disease, and these emojis will be the clue to that particular disease. Okay. And there will be a timer that will be shown on the bottom right corner. Can you go to the next slide so the timer will start? Can you press next? Yeah. So the timer will start like this. So at the end of that 45 seconds, you can give the answer. So this is open to all the teams. Can anyone answer?
Black Death.
Correct. It's plague or Black Death. So you got the idea, right? So in this particular question, it is actually clue to the disease. But sometimes actually the entire name of the disease or the name of the person will be split in the form of emojis. Okay. So can we go to the next question? So the question will be to team D. Are you ready, team D?
Yes, sir.
Okay. Next slide, please. Okay. Please identify this drug. You can start the timer. Please press next. Okay. Thank you. So all the teams can think of the particular drug, since there is passing options available.
Doxycycline.
Excellent, excellent, excellent.
Yes.
Excellent. So can you decipher how did you arrive at the answer?
So basically like a cycle and the dogs. So
Okay. So there are two dogs, right? So it's dogs. And can you show the next slide? Yeah, there are two dogs and there's a C and there's a cycle. So I hope you got the idea, right? So you can expect all these type of interesting questions in this round. Okay, so at the end of this question, Team D gets plus 30 points. Scorers, please note, plus 30. Okay. Okay, so can we go to next slide? So it will be to Team E, Team James Lind. Okay, please start the timer. Please identify this famous personality. You have 45 seconds, so think properly before giving the answer. Okay, around 10 seconds remaining. It's a very easy question. Okay, time up. So the question passes to Team A.
Florence Nightingale.
Okay, excellent. So how did you arrive at the answer? Can you decipher your thinking?
Nurse.
Okay, okay. So plus 10 to Team A. So it is lady, lamb, and nurse. Okay, so it was an easy one. Okay, so plus 10 to Team E. Okay, can we have the next slide? The question will be to Team A. Okay, please identify this personality. Please start the timer. I can see a smile on Team C's face. I think they have got the answer.
Sir Ronald Ross.
Excellent, excellent. It's Ronald Ross. Okay, can we have the next slide? Yeah, it's mosquito, then microbe, and rose. So to give the clue. So Team A gets plus 30.
Noted.
Okay. So can we have the next slide for Team B? Team B, please start the timer. Team B, please identify this disease. Okay, 10 seconds remaining.
Hay fever.
Pardon me.
Hay fever. Hay.
No, it's not hay fever. So the question passes to Team C.
Corona pandemic.
Correct. It's corona pandemic. So can you deduce on how you reached the corona pandemic? Okay.
Crown, beer, and pandemic.
Yeah, actually, as you know, the word corona means crown in Latin, and Corona is also a very famous beer brand, and there is also the pandemic. So hope you got the idea. So Team C gets plus 10. Team C gets plus 10. Team B, there is no since there is no negative marking. Team B has no negatives. Okay, can we have the next slide? Okay, this is for Team C. Please start the timer. Identify this disease. So Team C, you have two clues here. Team C, any wild guesses?
So flu, German flu.
German flu. No.
Flu pandemic.
No. Team D.
Spanish flu, sir?
No. Team E. Team E. No. Team A.
Sir, Legionnaire disease.
No. Can we have the next slide? I think it was tough for everyone. It's rubella. So just run, bell, and A. It was very easy actually. And since it's called German measles, we put the flag of German also. So there are no points for any of the teams. I think everyone is loving the round because I can see everyone is very happy and okay. Can we have the next slide? Okay, now it's a question for Team D. Please start the timer. Please identify this personality. Team D. Team D, any guesses? There are no negative marks.
Dr. Sharon, kindly wait after this question. Okay.
Okay, sure,
At the back end, we need to clarify with the scoring.
Sure. Okay, time over. Team E, any guesses? Team E? No. Team A? Any guesses? No. Team B? Team A? Team A? No. It should be instantaneous. Team B? Team B? Any guesses?
Anything related to saint that will be, but I cannot remember any name of it.
Somewhat you came closer. Team C? Any guesses?
Framingham.
Pardon me?
So Framingham Heart Study. Framingham.
No. Can we have the next slide? It was easy actually. Next slide, please, for showing the answer. Yeah, it was first one was a doctor, then was a Christian, then was a Saint Bernard and a heart. So it was Christian Bernard. Okay. So there are no one scored in this particular question. So Dr. Maladesh.
Dr. Sharon, kindly wait. Okay.
Okay.
Dr. Sharon, please continue.
Sure. Can we have the next slide? So it's a question for Team E. Please start the timer. So there are 3 clues. So please identify this historic event. Any guesses?
Is it that in James Lynn's first experiment?
Which one? It's not clear.
James Lynn's first trial of like
No, it's not. Team A, any guesses? Team A?
Sir, leptospirosis?
No. Team B?
No, sir.
Team C? No. Team D? Okay.
No.
Now there are no scores. I will give a clue. It's related to research, especially ethics. Now can you guess? Anybody got it now? There are no scores, no points, but that happened in 1964. And I will decipher the third clue. It's a lab coat. And there is a drug that is given to a person. It led him to lose the hair. So it's a human experimentation. So regarding that, there's something happened in 1964 related to ethics. Can anybody? No. Okay.
So Tuskegee trial.
Correct. It's Helsinki. Can we have the next slide? There are no points. Okay. So it was Hell, Sink, and Key. That was the first one. 1964 and human experimentation. Okay. So there are no scores in this particular question. Okay. Can we have the next slide? Okay. Team A, can you identify this disease? You have 45 seconds.
Sir, kissing disease, redwood bug.
African
So-
trypanosomiasis.
Pardon me, one
Sir,
second.
kissing disease by redwood bug.
Trypanosomiasis.
Yeah, I'll give it to you. Okay, correct. Yeah, fine. So it's actually kissing disease and Chagas. Correct. Next slide. So you'll get 30 points. Next slide. So team B, can you decipher this disease? You have 45 seconds. So scorers, please note on the last question, team A got plus 30. So in this particular question, there are two clues.
The tuberculosis.
Correct. Excellent. Yeah. Can you decipher how did you arrive in that?
Two, beer, bar, Q, and there is a C. So from the dot.
Yeah, this was low. That hammer used in the low, right? Oh, excellent. Okay, this was hammer. And the second one was dots. Okay, so plus 30 to team B. Plus 30. It was a really nice. Yes. Okay. And next slide. Okay. Team C, can you identify this event? Please start the timer. There are two clues. Take your time.
So World Health Organization.
No, it's wrong. Team D.
So Framingham heart study.
Excellent. It's Framingham heart study. Yes. So team D gets plus 10. Team D. Okay. Can we have the next slide? So it's frame, ham, heart, and study. It was easy. Okay. So next slide. Okay. So we have reached the end of that particular round. So hope everyone enjoyed it. So Dr. Maldish, are you ready with the scores? Or should we wait?
Yeah, 2 minutes. We will get back with the scores.
Sure.
Okay, sorry for making wait. So at the end of round 4, team A has scored 70, team B 30, team C 10, team D 40, and team E has not scored in the any score in this round. So Total score at the end of round 4 is 125 by team A, followed by team B and E, who have scored 60 each, followed by team D, who has scored 50, followed by team C, who has scored 30. Still, there are more rounds. I advise all the teams to take an opportunity and score well. Over to you.
Thank you, Dr. Malkesh. So I'm inviting Dr. Shaili for the next round.
Dr. Sharon, I think I will invite Dr. Maltesh for the troubleshooting round.
Yes, I will take up the troubleshooting round. So may I request to go to the next slide? Yeah. So this is round 5, the troubleshooting. Can we have the instructions for round 5? Okay.
Dr. Maltesh, if I may, may
yes.
I request the host of the meeting to kindly put the spotlight on the host of the quiz master for the particular rounds? The spotlight on Dr. Maltesh, please.
Okay, thank you. May I proceed now, Wasim?
Yes, Dr. Maltesh, please.
Yeah, thank you. So this round consists of 10 questions starting from team E. So team E, be ready. Each question consists of a situation where there is a deliberate blank step or an error in the sequence of the step. You should be able to identify that error or the missing step. The questions will be passed to the next team if the direct team is unable to answer correctly. So time for answering a direct question will be 45 seconds. And for a past question, an instantaneous answer would be required. Please note this, only the directly asked team will get 45 seconds. Rest of the teams, if it is past, has to answer instantaneously. Okay, so don't answer out of turn. So correctly answered direct question will get plus 30 marks. And for a past team, the correct answer will fetch you plus 10 marks. Here there is negative mark. 5 marks will be deducted at any stage, either past or directly asked question. So please note this. This round has a negative marking of -5 if you answer wrongly. But if you answer correctly, the directly asked question team will fetch plus 30 and the past question will have plus 10. So are the instructions clear to all the teams? Shall we proceed with troubleshooting? Okay. Can we have the first question for team E? Identify the mistake in this flow chart. Your time starts now. Team E, please remain unmuted. You can opt to answer or not to answer. If you do not answer, the question will be passed. If you answer correctly, you will fetch marks, or wrongly, you will get negative marks. Yes, please.
Sir, there should be a re-entry fees.
Re-entry?
Like
no, you have
a trial
answered
of change of behavior. But if they have relapse, it should be coming.
Can you tell the spot where it has to be inserted and what? Between what
trial
steps?
of change of behavior. After that, there might be a relapse, so that we can again they will be going to.
No, sorry, I'm afraid the answer is wrong. So can we have the next team, team A, to answer? Team A, I'll be moving clockwise. No, I need instantaneous answer. Team B.
The problem is the knowledgeable and skillful, and here it should be pre-contemplation.
Can you name the correct word and sequence where it has to be inserted?
In the third box, that is the knowledgeable and skillful, it should be changed to pre-contemplation.
No. Please note team B as -5. We will move to team C. Team D, Team E. Okay, let's have a look into the answer. Can we have next slide? Yeah, the concerned step has to be inserted after they get awareness. Hope team B made an attempt, but the knowledge and skillful will not be replaced by the element over there. Okay, good luck to all the teams. Now let us have a look into next question. So the question is to team A. Can we have the next question, please? Identify the mistake in the formula. Team A, your time starts now.
Sir, it should be 1 upon risk difference. That is 1 upon incidence in exposed minus 1 upon incidence in exposed minus incidence in non-exposed.
Can you please repeat? Team A.
Sir, number needed to create is 1 upon risk difference. That is 1 upon incidence in exposed minus incidence in non-exposed.
No, I'm afraid you made an attempt. There is an error there in which you told. We will pass the kindly note -5 marks for team A. The question passes to team B.
Pass.
Team C. Team D. No. Team E. No. Team A made an attempt. So there is slight change in the formula. We will see the formula there. Number needed to treat. So it is 1 upon incidence in exposed upon 1 incidence in unexposed minus 1. Okay. So the answer fetches -5 for team A. Rest of the teams has not attempted. So it's 0 for them. We'll move to the next question for team B. Team B, identify the error in life cycle. Your time starts now. Time is running. Team B. Time is up. So team B gets no marks. The question moves to team C. We want an instantaneous answer. Team C. No answer. Team D. No answer. Team E. No answer. Team A. No answer. So let us have the next slide, please. Okay. The mistake was they had not mentioned cercariae, which is actually released from snail into water, which penetrates skin. This is a life cycle of schistosomiasis. Okay, fine. Now the question goes to team C. Next slide, please. Team C, identify the error in this formula that is related to hospital statistics. Your time starts now. Last 15 seconds. Identify the error in the formula. Your time is up. Team C has not answered. No score for Team C. We'll pass the question to Team D. Team D, you want to attempt?
No, sir.
No. Team E? No.
The hint to
Team,
100 is missing. Sir.
yes, Team E, you want to?
Yes, sir.
Yes, please.
Multiplied by 100 is missing, sir.
Multiply by 100. No. Can you think of the already given? There is an error which has been already written, not the multiplication, no addition. No. We reduce -5 for Team E. We move on to Team A.
It's a number of discharges in a given time period divided by number of active beds during the same time period.
So you want to remove the number of admissions from there? Do you
Yes,
mean
sir.
that?
Yes, sir.
No. Reduce 5 to Team A. We move on to Team B.
Pass.
Pass. So actually both will be there. We'll move on to the answer slide. It is just either of that. We need not remove it. Okay. Both stands true for bed turnover rate. Okay. Okay. We move on to Team D for a direct question. Please change the slide. Team D, spot the mistake the researcher has made during this analysis for ANOVA. Your time starts now. Team D. Go through the steps, identify the wrong step or the mistake the researcher has done. Last 10 seconds for Team D. No. We'll pass this question. No score for Team D. The question moves to Team E. Do you want to attempt? No. Team A, your turn. No. Team B.
For Team B.
Yes, B. B for Bombay.
The last one is the mistake they have made. They have done a square root transformation.
Very good. Correct. Very right. Can you tell what needs to be done?
Sir, it most likely log transformation as it is the right skew.
Excellent. Team Ronald Ross. You get +10 score. Scorers, please note this. Good. So can we have the answer slide? Yes. So instead of square root transformation, logarithmic transformation should have been done by the researcher. Good. So now the direct question to Team E. Can we have the next slide? Team E, identify the error in the procedure followed in a ICTC center. Your time starts now. Your time is up. Team E, no answer. No score for team E. We will pass on this to team A. Do you want to attempt? No. So hope you will be familiar. Team B.
Yeah, in that case also the last step is wrong because the initial test was negative. So in that case, there should be a repeat test after within 3 months. But here it said that the person was relieved and with the result as it was okay. And he left after thanking the counselor. But the counselor should tell the person that the person should repeat the testing as the person could be in the window period.
You're very near to the answer. What is this procedure called? Can you name this procedure, what you told just now? You explained the procedure actually.
That is post-test counseling.
Excellent. So team B gets plus 10 marks. This is a past question. Scorers, please note. I think many of us would be aware, right? What happens in a ICTC center. Okay, can we have the answer? Yes. Post-test counseling was not done there, which you should have identified. Not to lose hearts, there are still more questions to go. So we will have the next direct question to team A. Identify the mistake made during this ABC analysis of hospital drugs. Your time starts now.
Sir, sorting should be in ascending order of total cost.
I'm afraid your answer is wrong. So we'll take that as response and wrong response. -5 to team A. We will move to this question will be passed to team B. We want instantaneous answer. Pass. Team C. Your time is up. Team D. You want to attempt? No. Team E. No answer. So as a part of inventory control, ABC analysis, can we have the answer slide, please? Yes, it is in descending order only. What you need to do is actually calculate the cumulative total cost per drug, and lastly, the cumulative percentage of the cumulative grand total. So there they couldn't do the cumulative. That was the error that crept in over there. Okay, so we will move to the next team B. Can we have the question for team B? Yes. Find the error in this diagram of a case cohort study. Your time starts now. Yes, you want to attempt, please. Last 10 seconds. Team B. Your time is up. We take this as non-response, no score to team B. This passes on to team C. Do you want to attempt?
So cohorts are selected in the same year as of the cases. Like in first year, we have to select the control along with that the case. In the second year, the same procedure will be done for the controls and the cases. It's a nested cohort study design, and for that we do that.
No, we take that as a wrong answer for team C. This question will be passed on to team D.
Sir, in case cohort study, like, we take 5 controls at the end after selecting the 5 cases, not at the beginning.
Okay, I'm afraid your slightly erroneous in judging. We will come to that. Okay, so you told it in otherwise way. Okay, team E. Team E. No answer. Team A. You don't want to attempt. So let us have the answer slide. The team D gets -5. Okay, so what was the error there? Here, this is alternative for nested case control, right? So case cohort study, you choose the control at the beginning itself, not after 5 years. So that was the mistake. Hope we learned through this. We will move to the next question to team C. Identify the mistake in the formula of PERT. The formula is given. Please identify the mistake. Your time starts now. Team C. Last 15 seconds. Team C, gear up.
So can we attempt?
Yes, quickly.
Sir, it's 6 optimistic estimate plus most likely estimate plus pessimistic divided by 4.
No, I will take that as wrong answer. -5. The question passes to team D. No answer. Team E. Identify the mistake. No, it moves to team A.
Sir, optimistic plus 4 into most likely estimate plus P divided by 6.
Excellent. So you have identified the mistake rightly in the PERT formula. So it is optimistic time plus 4 multiplied by most likely time plus pessimistic upon 6. Very good, Dala and Hill team. So you will get plus 10 marks for team A. So we'll move to team D. Can we have the question, please? Identify the error in the given approach. Your time starts now. Last 15 seconds. Wait, kindly wait. Don't show the answer. Previous slide. I'm sorry. So we will cancel the question. So since the answer has been displayed, so we'll take up the backup question at the end. Dr. Neha, kindly keep ready the backup questions.
Either last question.
Yes, we will take that in the end.
Okay, so can we have the question to team D later? So I will cancel this off.
Okay, sir.
Yeah, fine. Team D, you can relax for a while. So the question will come again after the rounds as a backup question. Okay. Fine. So now we will have a direct question to team E. Can we have question to team E now? Hope that is the last question in this round. Okay, so has all of you got 2 questions? Any of the team did not get 2 direct questions? You can tell us, not the past questions, direct questions. Okay, meanwhile, can I ask the scorers to announce
Dr.
the
Maltesh,
scores, or we will announce after the last round? Okay, we will move to the next round. Yes.
Dr. Maltesh, all the teams received 2 questions each, except for Team D, whose second questions was cancelled.
Okay, so kindly note all the teams except for Team D. All of you have got 2 direct questions, and rest of them were past questions. Team D, you will receive your another question at the end of the rounds. Okay, so you'll be receiving that question. Okay, so thank you. May I hand over to the organizers over there to take up the next round? Yes.
So we are moving with the next round, connect the dots. You can relax a bit in this for this round because this round has got no negative marking. Can we come to the instruction part for this round? So this round, it consists of 10 questions, starting from Team A, that is Dolan Hill. Each question, it consists of 2 to 3 images, which the team must connect to each other. So you will get 2 or 3 images, and you have to connect those images to each other. Time for answering the questions for this round will be 40 seconds. And if the respective team is not able to answer the question within 40 seconds, it will be passed to the subsequent team. And a pass question, if the question passes to the other team, it has to be replied instantaneously. Okay. So correct, directly answered question will fetch you with 30 marks, and correct answer by a pass team will fetch you 10 marks. This round has got no negative marking. So I'll insist that you please give it a try to any question you receive. The decision of this, the quiz master conducting this round will be final in all the cases. So are you guys ready? We have 2 more rounds left. This is the 5th round. This is a 6th round. We have 1 more round left after this particular round. So, I mean, you can cheer up. So can we have the first question for Team A, Dolan Hill? Connect the 2 pictures. Can you connect with these 2 pictures?
Ma'am, purpural sepsis hand washing by Ignace Semmelweis.
Okay, I'll give it to you. The right answer is, can we have the answer slide? The right answer is, the first picture, it shows the image of Ignace Philip Semmelweis. He's a physician who was called the savior of mothers. And he made an important discovery in the year 1847. And he proved that the incidence of puerperal fever or childbed fever, due to which the maternal mortalities, which were very high during that time, it was drastically cut by the use of hand washing practices by doctors and nurses. So we will give 30 marks to Team A, that is Dolan Hill. My next question will be directed to Team B, Ronald Rose. Your time starts now.
Silicosis.
No, this is not the right answer. Team C, you want to give it a try?
Pneumoconiosis?
No, that's not the right answer. Team D, do you want to attempt this question? There's no negative marking.
Rajasthan.
Okay, then team E, since the answer should be instantaneous. Okay, team A. So no one wants to attempt this question. The first picture is of, can we have the answers? The city of lakes, which is Bhopal. And what happened in Bhopal, everyone knows, Bhopal gas tragedy. The image 2 is of carbide, because the methyl isocyanate gas, it was managed and operated by the Union Carbide India Limited. So that was a hint. It's fine. We have 8 more questions to go. So my next question is will be directed to team C, Chadwick. Please connect these 2 pictures. Okay, time is up. Team D. Okay, team E. Team A.
It's a jungle wala committee. Equal pay for equal work.
Fabulous answer. So you'll be getting plus 10 marks for this for the right answer. The image 1 is of Dr. Jangalwala, who developed the Jangalwala committee in 1967, and he demanded equal pay for equal work, unified cadre, and recognition for extra qualification. So that's give team A plus 10 marks. Great, team A. My next question will be directed to team D. Team D, please. Your time starts now.
Head-on matrix for
Great, fabulous answer. So this is the first picture depicts a car collision, and the image 2 is of Sir William Haddon. So this is a Haddon's matrix, which is a brainstorming tool that combines the epidemiological triangle, that is agent, host, and environment, and levels of prevention. It was developed by William Haddon in order to know the factors which are related to injury or death after an accident. So this is an Haddon's matrix. So we'll give plus 30 marks to team D. Next question will be directed to team E. Team E. Please connect with these pictures.
Sickness absenteeism.
Sickness absenteeism. You have to relate all the 3 pictures. All the 3 pictures. So you have already attempted it. Next, team A.
Ma'am, sick building syndrome?
No. Team B. Okay, team C.
Ma'am, workplace absenteeism.
That's what they told, na? Team E. So team D. Okay.
Monday blues.
No. So the right answer for this question is, this is the image first is of Bradford University. You calculate the Bradford formula. So sickness and absenteeism, that was related to the first, to the second and third images. But the first image was of Bradford University, and the Bradford factor, which is a formula which the HR departments used to calculate the impact of employees' absence on the organization, that is sickness absenteeism. So it was developed by the Bradford University School of Management, that was showed in the first picture. And it is based on the theory that short, frequent, unplanned absences, they are more disruptive for organization than longer absences. and it is calculated by the Bradford's formula. So good try by Team E. Next question is directed to Team A. Time is running. Time is up. Team A, Team B, Team C, Team D.
Ma'am, there's no negative marking for this.
No, there's no negative marking.
Is it Pavlov's experiment?
No, it's not. Good try. Anyway, Team E. Okay, so the first picture shows Priyanka's husband. So he's suffering from diabetes. So the answer is diabetes. Nick Jonas, he's severely diabetic and he wears an insulin pump. And the image 2 is of the book about the discovery of insulin. That was another hint for you guys. Anyways, no team gets any marks for this particular round. Next question is directed to Team B.
Quality control charts.
Great, I'll give it to you. These are quality control charts. It depicts, the first image depicts a histogram, second image depicts a scatter diagram, and third image depicts a fishbone diagram. So plus 30 goes to Team B. Great, good attempt.
Dr. Shaili, let me interrupt. I request for the host to spotlight Dr. Shaili, and presently myself and Dr. Maldesh are spotlighted. So kindly remove that and spotlight Dr. Shaili.
Is it fine, Dr.
Yes,
Maladish?
yes. You
Okay.
can.
It's fine now.
Okay. So my next question is directed to Team C. Team C.
Ma'am, World Prisoners Day?
No, that's not the right answer. Good try. Team D. Team E. Team A.
Ma'am, is it Suicide Prevention Day?
No. Team B. Moreover, you have to connect with these two pictures. So the right answer is mental disease, mental illness. Because what you stated was, as per the second slide, World Mental Health Day. That is on 10th of October. And image 1 is of a famous, very famous, it's a very famous painting, in fact. It is housed in the Wellcome Collection Library and Museum at London. And it is an image of the psychiatrist and neurologist Philippe Pinel unchaining the insane woman in the Salpêtrière Hospital at Paris, France. So the painting is called as Pinel Unchains the Insane. So good try, Team A. Please don't lose hope. We have 2 more questions to go. So next question goes to Team D. Team D.
Use of mask in 1918, influenza flu. Spanish flu pandemic.
Excellent answer. Excellent. You get plus 30 marks. Image 1 is the best-selling book on the Spanish flu by Laura Spinney. And image 2 is the iconic graph of peak mortality in 2 American cities comparing the effect of lockdown versus no lockdown during the Spanish flu. Excellent. So you get plus 30 marks. Team D. And the last question will be directed to Team E. Okay, time is up. Team E. Team A.
Ma'am, narcotic drugs prohibition.
Narcotics, drugs, and psychotropic substance. 1985 Act.
You have to relate these two pictures.
There was a ban on the
e-cigarettes.
Cigarettes.
No. Team B. Team C. Team D. Okay, it was a very good try from Team A's side, but you just answered one part of the question. So this is related to substance abuse. This is the famous picture depicting the substance abuse by Sherlock Holmes. And image 2 is, as you have rightly mentioned, Narcotic Drugs and Psychotropic Substance Act. So this image is related to substance abuse. Great, good try. Can we have the scores, Dr. Sharon and
Yeah,
Dr.
sure.
Malatesh?
Yeah. So at the end of round 6, we have Team A leading with 160 points, closely followed by Team D with 115 points, followed by Team B with 105 points, followed by Team E with 50 points and Team C with 20 points. And please note that one question is pending for Team D. That will be done at the end. Thank you.
So good going, all the teams, and all the best for the last round. Over to you, Dr. Ribu.
Hello. So you must be very tired, and so this round is very easy basically. And all of you must be doing crosswords in the morning. So it's about a crossword in which I am talking about some national health programs. So can you go to the next slide, please? Next slide. Okay, so this round will consist of 10 questions starting from Team B. The crossword will be shown with a few alphabets. The directed team will be asked a question whose answer will be either the across or vertical in the crossword. Time for answering the question will be 30 seconds, and for a past question, instantaneous answer should be required. For a directly answered question, 30 marks, and if it is passed, 10 marks will be given. We will be passing from S, A to B to C, C to D, etc. 5 marks will be deducted on giving incorrect answer. Now, I would like whoever is sharing screen to be very careful because all the answers are interlinked with one another. So be very careful about changing the slides. Only after I say change, you change the slide. Is it okay?
Yes, sir.
Okay, fine. Thank you. Please change. So question to Team B. And your clue is H6 across. H for Holland, 6 across. This was launched as a part of the 20-point program of Indira Gandhi way back in 1986. Remember, we are talking about national programs. This was launched as a part of the 20-point program of Indira Gandhi in 1986. H6. The first one would be tough, I know. Team B. Your time is up. Team C. Team D. Team E.
ICDS.
Excuse me?
ICDS.
No, not ICDS. So that will be -5. Team A. Okay. Please show the next slide. So it was NPCB. It was NPCB. Okay. The next slide, please. 8-6 down. Team C. The name was changed in 2020. The name was changed in 2020. We are talking about national programs. You must be answering this. The name of this program was changed in 2020. Team C. 8-6 up and down. Okay, time is over. Team D.
National TB Eradicating Program.
Excellent, excellent. So claps for teams D. Team D has got an indirect +10. Next slide, please. Team D. So now it is K5 down. K5 down. It looks after congenital anomalies. A national program looking after congenital anomalies.
RBSK.
Excellent, excellent. Big clap for you. RBSK. Next, please. Team E, gear up. All of them are answering properly. E9 across. A P will is missing here. A P is missing in H9. So remember that NTEP, the P is missing here in H9.
IDSP.
IDSP, excellent. Even before I ask the question. So last 30 to team D, team E. Now question to team A. A6 across. This will be again tough, but the glue is very a giveaway. The Bellary model was a parent of this program. A6 across. Bellary model. Whenever you think of Bellary, you think of something. Whenever you think of Chengalpur, you think of BCG vaccination. Whenever you think of Bellary, you think of. Okay, question to team passes to team B. Team C. Team D.
National Mental Health Program.
National Mental Health Program. Excellent, excellent. Wow, that was very fast.
Sir, I am from Bellary.
You are from Bellary.
Yes, sir.
That is unfair. Okay, congratulations anyway. So, NMHP. Next, please. Team B, D3 down. One of the few vertical standalone programs remaining in India. All of them has been integrated to
NACP.
NACP. Excellent, excellent. I told you this is going to be easy. NACP. So gear up all the teams. Most of you are answering very well. Next, please. So next is I3 down. One of the public health programs taking help of a plastic surgeon. Usually we stay away from surgeons, but here we need a plastic surgeons in the program itself. Any idea? I3 down. We need a plastic surgeon for this program. Some of the plastic surgeons in our college are also working on this program. Time up for team C, team D. Team E.
NLEP.
NLEP for the deformities. NLEP. Very good. Okay. So now, please go to the next question. So C4 across. You have got 2 clues in letters. A program of a quality assurance. Program of a quality.
Kayakalp.
That was easy. That was easy. Kayakalp. So team D has answered correctly. So now team E. Okay. G1 down. Financial protection program for mothers. Financial protection program for mothers. G1 down. That would be easy. Team E. Okay. Team F. No, it's team A. Team A. Excuse me?
NSSK.
NSSK is not about financial protection. -5 for you. NSSK is not about financial protection. It's about newborn ICU training. Team B.
JSSK.
JSSK. Excellent. Team B +10. Excellent answer. JSSK. So next question to team A. The last question of this quiz, and it is going to be very tough. An umbrella program of community-based health insurance. Only one blank is remaining. An umbrella program of community-based health insurance.
Sir, PMJAY.
PMJAY, Ayushman Bharat, another name. Excellent. So you have got that also, +30. Thank you. So this ends my round. Hope you enjoyed the round. Thank you. So over to the scorers for the final questions, or will you be building on the suspense?
Yeah, please give us 1 minute.
Yes, so the suspense is building. Any guess about the winner from the teams?
Dr. Ivo, I think we have one more question.
We
left
have
for
one
team
more
B.
question to be asked. So kindly wait before we take up the final scores.
Okay, okay, fine.
Dr. Malatesh, you will be asking that question for troubleshooting.
Yes, yes. If it is
Okay.
ready,
Yeah,
the
yeah.
question goes to team D. Please be ready.
So there's a negative marking for that, right?
Yes, that round has a negative
Of
marking of
-5.
-5. If you score rightly, it's a direct question +30. For passed on question, we will have +10. Even others may also get a chance if you pass. Okay, so we'll see. So if you answer correctly, +30. If you answer wrongly, -5. If it is a past question and correct answer, +10. If it's a past question and wrong answer, -5. Hope the rules are clear now. We'll have the question. So. Meanwhile, I request Dr. Sharan and Dr. Wasim to check the scores. We'll add the last question scores after this. Hope all of you enjoyed the rounds, playing against each other, but still enjoyed the questions. So meanwhile, we will wrap up with the last question to Team D. Is it being uploaded, Dr. Shaili? Okay.
Yes, yes, yes. We are ready with the
Thank you.
Final question. Team D, please get ready. The final
Okay.
question is up on the
Team-
slide.
Thank you. Thanks for that slide. Next slide. Team D, please note the question. Identify the wrong step in the surveillance loop. Your time starts now. You should identify the wrong step in this surveillance loop.
So it's not formulate health problems, formulate health policy.
Data, information, action, and event. Actually, sorry.
Team D, one answer, please. So I will take, instead of formulate health problems, what did you quote it?
Data, information, action, and event. Actually,
No, I will take that as a wrong answer as far as the step goes. We'll award -5. Wait, please. Okay, was that a wrong? Okay, fine. I'm sorry. So, okay, I think the answer is displayed rightly. So your answer was also right. So you have identified the wrong step as formulate of health problem. What was your answer? I don't think so. Half the answer, you identified the step wrongly, but the answer given was wrong.
Yes, sir. I identified the step correctly, but not the proper. I didn't give the proper answer.
Okay, so on discretion of my side, I will take it as 0, so not as a negative. The step is identified rightly, but since they couldn't answer it, the correct step, I will take it as 0. So scorers note, please award 0. So since, okay, hope that is fair enough. So take this score, and this was the last question, and we will wait for the final scores. All the teams, let's see, best wishes. And in fact, all the 5 teams have played excellently. So where you have put, there were so many things like even logical as well as other parts. So now I hand over to organizers to take over. Dr. Shaili, please. Okay, thank you.
Okay. So, did you all enjoy the quiz?
Yes, ma'am, it was very interesting.
Most of the teams, they are smiling. Team B, what happened? You performed well, I guess.
Have enjoyed.
Yeah, we have enjoyed that.
Let them guess the winner and the runners-up. Who is the winner? Who is the runner?
Okay. Can you guess?
Who is the winner?
We think team A is the winner. A.
Okay, you think team A is the winner. Okay. Yes. Who thinks otherwise?
I think B is winner and A is runner.
No, they have said A.
So you are saying B is winner, A is runner. So where are you keeping your scores? In a quiz, you should always keep your scores because we take...
Okay, sorry to interrupt. So there is some discussion with the organizing team. So still the round is not over yet. Okay. So of course, what we did was right to team D, but the only loss is to the passing team. Since the answer was shown, we cannot give to other teams. Don't worry, we have still more backup questions. Team D, buckle up now. So please, we will ask one more question to you, but I would request the persons changing the slide, do not prompt the answer. We will wait for a while. So in case they are unable to answer it, we will pass on to the next If we prompt answer, we cannot pass on. That was the only glitch over there. Is that okay to all teams?
Yes.
Okay, fine. So team D, are you ready?
Yes, sir,
Kindly confirm.
Yes, sir, we are ready.
Okay, fine. So we will have the last question. So I would request you to display the question and wait. Please don't go to answer at all. Okay, we will wait there. So team D, identify the wrong step in the stages of this change model. Your time starts now. Time is running. Last 15 seconds for team D.
So I think after action, it should not evaluation, it is recovery.
Excellent. You have identified the wrong step. Now I want the correct step there.
Action. Sustained recovery.
Be quick. Or I cannot award the marks. We will pass the question. Don't show the answer, please. No, same problem with the last question also, right? Okay. Anyway, nothing to lose. So we'll pass the question to team E for either +10 or if wrong answer -5. Team E.
Instead of
Do you want
evaluation,
to
it is motivation.
Motivation, no. I will take that as a wrong answer. -5 for team E. Team A.
Sir, after action, it should be relapse and then maintenance.
Action के बाद relapse.
Then pre-contemplation, contemplation, and preparation.
Please hold on to the one answer.
Action,
Sir, it should be evaluation. Instead of evaluation, it should be relapse.
No, relapse, I take it as wrong answer, -5. Team B. No, you want to pass on. It comes to team C. It stops with team C. So team A was very near to the answer. So now can we have the answer slide? Maintenance. You were very, very near. So, but since that's why I asked you to choose one answer, you chose it wrongly. So no worries. So you have lots of score with multiple rounds. And now it's the time to hear your scores. Over to Dr. Shaili, please.
Thank you, Dr. Malatesh. Can we have the scores, please, Dr. Sharon?
Okay, Shelly ma'am, I have the final scores. Can I go ahead with the final scores?
Please,
Sure, Dr. Vasan.
yes.
Okay, I feel the pulse of many teams. I can still hear the heartbeat, even if your mics are muted. So let us begin with Team C, which has performed very nicely, which is standing at 20 points. Huge round of applause for Team C, Team Chadwick.
Thank you, sir.
Followed by Team E, Teams James Lind, which stands within their final scores at 80 points. Round of applause for Team James Lind. Fantastic run for the money for all the other teams. Team B, Team Sir Ronald Ross, standing at 145 points. And the final Team A and Team D, do you think we have a tiebreaker? What do you feel, the teams?
So we don't think so.
Okay, Team D.
Like in the last question, what was the score of for Team D? Whether they got 0 or negative? That is my question, because the answer was not right.
Team D, the score for?
Team D in the last question.
No, team D remains 0. They identify the step correctly, but they did not utter a
But
word.
the answer
of
is wrong,
the-
actually. Yeah. I think
No. Answer is not wrong there. The step has been identified correctly. They failed to answer the right answer. That we take it as a discretion of us. So hope that is fine to you. Fine. Thank you.
Okay, Team D actually, it could have been a tiebreaker, but Team A stands at 180 points. And Team D is the winner of today's quiz, Mindbenders, at 195 points.
So we couldn't believe it.
You were very sure to guess that there is no tiebreaker, but it was head to head. Even till the last question, we were not able to guess whether it will be Team A or Team D. So it is Team D, finally, Team Joseph Bohr. Congratulations to all the teams. But for us, you are the top 5 teams of the country. Congratulations for all the teams for participating and reaching the finale. I'll hand it over to Dr. Shaili ma'am.
Congratulations to the winners, Team D, Joseph Bore, and congratulations to Team A as well. They're the first runner-ups, and to all the participants. Congratulations. A big round of applause to all the participants from all of us, Team Mindbenders. And I would like to deliver the vote of thanks. Well, I would like to...
Shaili ma'am, sorry for interrupting. Before the final vote of thanks from Shaili ma'am, can we have feedback from all the participants?
Yes, that is also important. Yes, Team D, can we start from you?
Ma'am, actually, we entered for this, made this entry at the last minute.
That is because of with the help of Shaili ma'am. At the conference actually ends at sorry.
I mean, on the last day of registration, we registered, and then we were just thinking of, we'll take a take part in this, but we never expected we'll come so far. And even in the final rounds, it was so good. The questions were so good. In the first 2 rounds, we were in the last second question, I guess. After that, we just thought we'll just enjoy the quiz and then take away from that. And I'm feeling very happy that's all.
Congratulations. I do remember the day when I motivated you for taking chance in the quiz.
And actually congratulate the other teams also. They were very good. And Team A, especially we were thinking Team A would be the winner because they are playing really well. And even we were thinking Team B and Team C, we will have the tough competition for second place. That's what we were thinking actually.
Okay, great. So congratulations once again. Any other team would like to give their feedback? Team B, Team A, Team C, Team E, any other team? Please don't get disheartened since you are the top 5 finalists of the national quiz. So please cheer up and don't lose hearts. We have many such quizzes. We will be conducting in the near future. So
yeah, ma'am, we would like to share that we were really happy to be a part of this national quiz. We were not even expecting to be selected among 60 teams. And we gave our best shot, but we were in the organizing committee, so it was really tough. And we tried a lot, and we are happy for being a part of it. Thank you so much.
You give it a very nice try, Team C. Congratulations to you as well. You are amongst the top 5 finalists. Any other team? Team B?
Yeah, that is actually a nice experience. And truly speaking, that initially there was no plan for me actually to participate in a quiz. I just saw one advertisement about the quiz, and it wrote there that if you participate, you'll get the membership for the Epidemiological Foundation of India. So I thought it's a good opportunity, so let's go for that. And then we decided, and it has been a nice journey. And congratulations to the winning team and to all of the participants. And thank you for the organizers for conducting such a nice quiz competition.
That's the spirit. Congratulations to you as well. Team A,
Team B, Sir Ronald Ross. I would just like to add, congratulations to Team B for cracking a few of the most toughest questions of this quiz.
Yes, that's true.
Actually, we were really not, the luck was favored with us. For the first question, these were really tough question, I guess our team got during the whole quiz. So
All the questions were equally balanced and all the rounds were equally balanced.
That's fine because that is a random selection, so nobody has nothing to say.
That's why most of the questions were like passing on questions. We passed most of the questions so that each team gets equal opportunity to attempt those questions. And most of the rounds, they do not carry any negative marking. So hope you all enjoyed. And some of the rounds, they were like emoji round and crossword round. I hope you all found it interesting. Any feedback from team A and team E?
Ma'am, I would like to say something. Ma'am, we have participated. I think this was the 4th quiz for us, and it has been a really, really good experience. And we are also happy that over the time we have learned a lot. And ma'am, we feel happy that now in community medicine also we are getting so many opportunities to participate. Like in other specialties, when we look at other specialties, they have so many of their sub-specialty quizzes also, so many activities. So I'm really happy. And I want to congratulate the organizers for making so much of effort for the young community medicine future specialists and giving us a platform to participate and be in touch with all of you. Because in armed forces, we are mainly concerned about our own area and with armed forces functioning only. So it is really good to meet other PG residents from other colleges and faculty also. Thank you so much, ma'am.
Thank you, Dr. Mandeep, and thanks a lot. Can we have some feedback from team E? I'm seeing a great spirit from all of the teams. I mean, that's a new thing because every team, I mean, they are all delighted. So that's a great experience for me as well. Team E.
Ma'am, we have seen few national quizzes before us. This time we were like, we'll just attend. We never expected to select, and that to compete among, like, we are from private medical college, but all of them were from central institutes. We were like really shocked to know this. Like we were selected. It was good quiz. We attended very sportively, and thanks for the opportunity, ma'am.
Team E, I would just like to add on that many of us are also from private institutes. So don't worry. At the end of the day, collaborative learning and experience in learning matters. So kindly, if you had such kind of a thought before this quiz, I want you to share those things right here, right now. But you performed very well, and selecting yourself, I mean, in the final 5 of the top 60 teams in the country is a great achievement. Congratulations to you.
Yes. And again, I would like to have a big round of applause for all of the teams. You all performed very well. Fabulous job. You all did a fabulous job, and the questions, I mean, most of the teams were able to attempt most of the questions. So that's another great thing. So can we have a group pick with all of you? Dr. Sharon, can you take a group pick?
Yeah, taken. Yeah, sure. So,
can everyone show the, like this?
Yeah, listen.
Sharon, you can do hide non-video participants. Okay, that will make the picture better.
Okay. Okay, thank you.
Thank you.
Shelly ma'am, over to you.
Thank you, Dr. Wasim. So I would now like to extend my vote of thanks. My heartfelt gratitude to the organizers, especially Dr. Pankaj Bhardwaj sir, who is the organizing secretary of this conference, who gave our team the opportunity to conduct the national level quiz, Mindbenders, at Eficon. I would also like to thank the organizing chairperson, Dr. Pankaja ma'am, and Dr. Kuldeep sir for their kind support. I would like to express my thanks to Professor Sanjeev Mishra sir, Director AIMS Jodhpur, for his constant guidance. My heartfelt gratitude to Dr. Umesh Kapil sir, President Eficon, and Pradeep Agrawal sir for showing the way under the Eficon banner. At the end, I would like to acknowledge, give a big thanks and applaud to my team of young, energetic, and dynamic members. Dr. Akhil, Abhishek, Revu, Neha, Malatesh, Sharon, for their enthusiasm and hard work throughout the journey of this quiz. Lastly, many thanks to the participants for maintaining the enthusiasm during the entire quiz, and to the delegates for making this event a grand success. So thank you once again. You all will be getting the prizes and your certificates very soon. So congratulations to the winners and congratulations to all the participants once again. So happy learning. And yes, thank you to Dr. Prasanna Jeet also, who helped us today with the slides and with the questions also. I mean, with the changing of the slides and with the technical help. So thank you, Dr. Prasanna Jeet. So thank you once again. So goodbye. Take care, everyone.
Good night. Bye-bye. See you.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Bye.
Thank you,
Congratulations
everyone.
to
And
all.
our request from our team is kindly stay connected. Kindly encourage collaborative learning. You have got a good platform to connect to each other and to all of us. Congratulations again. Thank you.
Thank you, sir.
Thank you, sir.
Congratulations,
Thank you,
winner.
okay, sir. Thank you.
Thank you, ma'am.
Bye-bye.
Message ಮಾಡಿದ ನೋಡಿ.
वाले जीत गए यार, वाले जीत गए।